and peaks. As we all know, telemedicine has been practiced in Nepal by a number of institutions and individuals for more than a decade. While the way telemedicine is practiced, many vary a lot. We feel that better cooperation and coordination among the practitioners can create the synergy and set a standard goal. In the changing political scenario of Nepal, and towards the mature practices of federal context, Nepal also has acquired equity in health with universal health coverage and access to quality healthcare.
Indeed, no one must be left behind for sustainable development goals. This workshop is a platform that brings international and national professionals involved in telemedicine together to share their experiences and expertise for the betterment of the telemedicine practice in Nepal. We are so glad that this year we are joined by around 100 participants from around various parts of the country, and we are also joined by our delegates from Japan. We also have participants joining remotely from different other countries. Now, without further ado, we would like to welcome Professor Dr. Saroj Dhital, the founding chairman of Telemedicine Society of Nepal, Vice President of FECT Nepal, and to acquaint us and deliver welcome remarks and workshop introduction. Please give a round of applause.
Thank you, dear, for asking me to welcome all the wonderful people from at least half of the world. And thank you, the organizing committee, for giving me this responsibility. I thought that now it's time for me to stay back and enjoy life at home. It's not to say that I'm not enjoying being with you. I'm a little bit after that you are making me young again, and that's a lot of extra responsibility. I welcome you from the bottom of my heart. And that's not only a ritualistic remark, but telemedicine for me is an act of love. An act of love that allows people to reach the unreachables or unreached people, to extend your love beyond the physical barriers, and a platform where the human sentiment and technology can meet. Since all of you are so active in this platform of telemedicine, you are really respectable people, and it's very nice to be able to welcome you in this Kathmandu morning. Having said that, I am sometimes a little bit worried that telemedicine can be hijacked by the market. Whether we like it or not, now it is the market which is ruling the whole world. And whatever we do, our responsibilities, our act of love, everything, all the human sentiments are also being hijacked or kidnapped by the market. And that's quite scary for me. It's not de-recognizing the role of market, but when everything is ruled by dollars, then life becomes ugly. So I sincerely hope that all of you who are so actively engaged in the activity of telemedicine, please try to save it from the vulgar market and bring it to the domain of the highest sentiments of the human beings, that is love and kindness. When I was also a little bit active as a clinician and in telemedicine activities, I have found that it's very difficult for people to understand telemedicine beyond the borders of technology or biomedical limitations. While practicing telemedicine, I have experienced myself that there are so many non-technical issues and human factors which has to be addressed. In the last few decades, information and communication technology has advanced to unthinkable, height. It has been much cheaper in comparison to the past. It is more easily accessible. The technology is ever developing. But in spite of all these things, why still so many people have to go to the hospital to get simple health services? It's not, the technology has advanced. It is advancing in a higher and higher, more and more accelerated speed. But the way people should benefit from it, especially the sick people, the needy people, it has not been at par with the progress of the technology. And I wish I am wrong, but I think that then the clause of the vulgar market, when that starts acting, even the technology cannot do much. So I hope that the new generation of wonderful people who are trying to bring telemedicine to a greater height, I hope that you will give telemedicine a soul, a human soul, where love and kindness is there, a soul where you can see responsibility towards the society. I think that since I'm a retired clinician, I'm not doing much now. So that's why I can be so frank to you. I think I don't need to say more about the introduction of the workshop. I think next Professor Moriyama and Dr. Uday, they are going to talk about it. I am seeing that everything has been very well organized and well managed. So I don't need to deal with that. I have not done anything. I have not contributed a single thing for this wonderful workshop and conference. Thank you very much. Once again, welcome all of you to this Kathmandu Valley. A little bit polluted, but it's still very beautiful. And for all our cyber friends who are meeting us in the cyberspace, welcome all of you too. Thank you.
Thank you very much, Professor Dr. Dital, for that inspiring message. And you are retired, but not tired. We always inspired by you. Thank you very much, sir. It is the honor of us to have opening remarks of the Professor Tomohiko Moriyama. Professor Moriyama is the president of Telemedicine Development Center of Asia. Let's welcome him with a huge round of applause. Thank you.
Hi, good morning, and police friend and Asian friends, and maybe good evening to Latin friends. Okay, thank you for joining the 16th ATS. Oh, sure. Okay. And before starting my talk, I'd like to show my sincere appreciation to Dr. Dital, Dr. Udaya, Mr. Rajan, and their colleagues who have made a great effort to organizing this fantastic symposium. So I'm so happy to meet many friends in Nepal, and also to know the many new people here in the venue. Since 2020, this ATS is held totally online, but this is the first time to meet in person since 2020. So it's really nice. Okay, this Asian Telemedicine Symposium was started in 2007 so far now, when the telemedicine was quite immature. Very limited people know the situation of the, telemedicine situation and what we can do using the developing internet. So we organized this symposium for the first time to share the knowledge and experiences in each country to expand telemedicine activities in the world. And already more than around 15 years have passed. And of course, a bit thanks to the COVID, the telemedicine is now quite popular, both for sharing the knowledge for doctors and medical staffs, and also for the patient. But regarding the remote patient care, it is not so familiar maybe in the world. Of course, at least in Japan, no. So still, we should make a great effort to provide our medical technique and the knowledge to the citizens in the rural area. And also we can provide a medical treatment or others to those kind of people. Still, telemedicine, of course, telemedicine is a very, very important tool, as Dr. Detail said. So we should think how to expand to the remote patient care now. So from the viewpoint of this, the theme of this telemedicine as ATS is quite important. The theme is role of the nurses in telemedicine. To expand more and provide medication to the rural patient, we should need the help of nurses. So the situation is same. Also in Japan, we would like to have many help from nurses. Without nurses, we can do nothing. So I sincerely appreciate Dr. Udaya to set this theme in this ATS. So I hope to enjoy the presentation from nurses in Nepal and other countries, and also would like to know the telemedicine situation in various countries. So I would like to learn a lot with you guys here, and also would like to have a fruitful discussion. So thank you again, and let's enjoy.
Thank you very much. Yes, nurses are the backbone of the community. Yes, so the theme is very true, the role of the nurses in telemedicine. Now I would like to call upon the stage Dr. Uday Koirala for deliver opening remarks. He is the president of Telemedicine Society of Nepal and HOD of Surgery Department of Kathmandu Model Hospital. Let's welcome, sir.
Thank you. All the guests, my seniors and colleagues, it's my great honor to be here as a chairperson of Telemedicine Society. And it is because of our seniors' great effort that has been made on telemedicine. Now it's growing up. There are still many things to be done. But at this conference, there were so many participants eager to participate in this activity. And now the area of telemedicine is also increasing. So to be the part of the Telemedicine Society of Nepal, it is always a great pleasure and honor for me. This time, when we are discussing about the telemedicine, now we can see that because of COVID also, everyone has realized the importance of telemedicine. Telemedicine, we were only thinking about rural health, remote areas, but now the area of telemedicine has grown up. Now we realize that it is also very important in urban area as well. There are so many senior citizens, they need telemedicine. There are so many pregnant women, they need telemedicine. There are so many children, they need telemedicine. And actually this telemedicine can help a lot. It was not in government's priority. It was not in priority of so many institutes. They are still not very much eager to invest on telemedicine. But now when I went to so many government officials, so many institutes, they are slowly trying to invest, at least budgeting some fund to telemedicine. And that is good thing, but the activity is very slow, but still there are some funds now which can be utilized in telemedicine. This time also, there are so many presenters, they are going to present on this role of nurses in telemedicine, role of paramedics in telemedicine, this telemedicine in urban healthcare, telemedicine in pregnant women, in this SDG. So there are so many areas of telemedicine, and even the insurance should cover telemedicine. All the healthcare professionals who are involved in telemedicine, they also should be reimbursed. It's not free service. We must know that it's not free service, but patients should not be charged, of course. And government and organizations should fund to help telemedicine to grow, then only it will grow. So that will be the theme of this workshop, I think. And we'll learn many things from many speakers, national and international, on-site and online. So we are very much excited to say you that there are more than 100 participants on-site and online, and from so many countries also. So thank you, ATS, especially Kyushu University, who initiated this Asia Telemedicine Symposium. I also got chance to go to Kyushu and participate in one of the ATS. And it's their great initiation that is inspiring us to develop, to promote. And similarly, there are so many Nepali government officials now. Ministry of Health, they are helping us a lot. WHO Nepal, they are helping us a lot. Nick Simons Institute, they are also helping a lot. They are especially involved in rural healthcare, and I think it is one of their priority, telemedicine, to connect all the MDGPs who are working in rural areas. And now MDGPs are also excited to be connected through telemedicine and to have case discussion, to have patient referral system. And government is also now has come up with a guideline, and
that I think will be improved in the years to come. Nepal Medical Council has also come up with the guideline, and we were also one of the important partners in producing the guideline. So Nepal Telecom Authority, Nepal Telecommunication, they also have now prioritized one of the part as digital health and telemedicine. So the things are improving, things are going on, developing, and thanks to our seniors who had a lot of effort, a lot of pain to develop this. Thank you.
Thank you so much, Professor Moriyama and Dr. Koirala, for your wonderful opening remarks. We have indeed accomplished many things in the field of medicine and have added many feathers to our cap. One of them is telemedicine. With that note, ladies and gentlemen, let's move on to our first session, that is telemedicine in different countries. In this session, different telemedicine end users will present the scenario of telemedicine in their country through virtual connection. May I now invite chairs of the session, Dr. Saroj Dhital and Dr. Mohammad Qasim Saha, to conduct the session. As already introduced, Dr. Saroj Dhital is a founder chairman of Telemedicine Society of Nepal and vice chairman of FECT Nepal. And Dr. Mohammad Qasim Saha is a senior program manager at Nick Simons Institute, MD in general practice of NAMS, fellowship in diabetes management from CMC Vellore, and 12 years of experience as a health service provider in different levels of the hospital. Thank you.
Good morning, everyone. First of all, I would like to thank organizing committee for this opportunity and this responsibility. We are very much delighted to be here today on this 16th Asia Telemedicine Symposium and 3rd National Telemedicine Workshop organized by Telemedicine Society of Nepal and Nepal Research and Education Network. During this first session, we will listen about the experiences from different people, and we will try to entertain on ideas, opportunities, and challenges on telemedicine. And on this session, we have 7 presentations from different people. So without delay, I would like to start this program, and I request our seniors, Dr. Saroj Dhital, to lead this program.
Thank you, Dr. Qasim. So, Dr. Sudeep, are you ready? I hope that you will be in time. It is the ugliest thing is to remind the presenters of the time. And we don't have to do that, I hope. while they are still preparing for the slides, let me take the opportunity to introduce Dr. Sudeep. Everybody can see that he is a really, handsome person. I will not reveal everything about the ladies around him. Sorry, I didn't say anything, but he is a very a good surgeon. He is now a consultant surgical oncologist in Kathmandu Model Hospital. And he has been actively involved in telemedicine activities for more than 5 years. Sometimes he has also represented Kathmandu Model Hospital and Public Health Concern Trust and attended a number of APAN meetings in the past. I have been knowing him from when he was a very, very fresh surgeon. And I have always felt very proud of him to have him in my then team was a real pleasure. Okay, Sudeep, please.
Respected chairperson and all the participants of this symposium. Good morning to all. I'm Dr. Sudeep Sakya. Dr. Dital has already given a brief introduction. So I'm going to kickstart this workshop, and I'm going to talk briefly about the telemedicine in Nepal. I'd like to give some brief overview of how we started and where are we now. And I'm sure as we move on in this telemedicine, different presenter will be sharing their own experience. So if you have been in telemedicine, we will know this famous personality, Dr. Bingmar Sherpa, Munira Sakya, Dr. Mahabir Poon, and Dr. Saroj Dital. We can consider them like pillars of our telemedicine, or like fathers of telemedicine. It's because of them that their vision and their hard work that we are here right now. So if we talk about telemedicine in Nepal, like history, the Ministry of Health, they started the rural telemedicine program from 2 districts back in 2010. Right now, it's already expanded to all the 7 states of the Nepal. So before the MOSP, there was a project, HealthNet project of the rural medicine, telemedicine, and hospitals like Om Hospital were also providing telemedicine services in various departments. But the real when started was by Dr. Mahabir Poon and the Nepal Wireless, who set up the connection of the to the rural Nepal. So there were many challenges and difficulties setting up the connection to the rural areas. If you have attended some of the lectures of Dr. Mahabir Poon, you have seen might have you seen these pictures of setting up this long range testing back in 2002 at Mohare. All these our mountainous region also provided some very difficulty in setting up these connections. So finally, with the help of NREN, by 2006, Kathmandu Model Hospital was able to establish a communication with the Gauri Shankar General Hospital in Dolakha. So Kathmandu Model Hospital worked as a hub. So since then, we have been having regular telemedicine session between the remote health center and Kathmandu Model Hospital. So we used to provide teleconsultation, and we even used to do rounds, morning rounds at the beginning of this program. So by 2011, there were many other remote areas were also connected by 2001, and the telemedicine activity was slowly started to pick up. Our work was also recognized by our national news like Nepali Times, which published this article about a long distance medicine, where they talk about initially there was difficulty in internet connection and so on. So about that time also, there were other organizations also like Ask Foundation, which also provided telemedicine services from 2009. So in Kalikot district, Kalikot clinic. So then after connection with the TEIN, then we were able to expand this globally. We were able to connect further to various medical universities in Korea and Japan. And from then onward, we were able to share knowledge. As we also were able to save expenses, because to attend the conference, we didn't need to go to abroad, because we could virtually attend and gain experience and knowledge from these conferences. So thereafter, like from other hospital also, this was a news published in Kathmandu Post, like the Patan Hospital also started the telemedicine services back in 2011. Dharan, I think Dr. Pramendra will talk about this, in 2015 began its telemedicine services. And so as the Beer Hospital, even Institute of Telemedicine also started the DIT back in 2008 and started the telemedicine services. So after this, we were able to conduct like all this inter-hospital sharing department in different hospitals. So, and not just in the medical field, even in the information and communication technology, the telemedicine topic was discussed in their conferences also. Also it was also recognized by like a non-international, non-medical fraternity also. This was the article published in Denmark, which also talk about this telemedicine activities in Nepal. Now, there were very benefit of telemedicine, especially it has drastically improved the healthcare system in Nepal. Like, especially it has improved the telehealth for women and girls. They were able to discuss their sexual and the reproductive health problem. There was this article published in Telematics and Informatics. Okay, sorry for the interruption. So there was this article published in Telematics and Information, which talk about telemedicine helps to overcome gender barrier in healthcare, which won the Okay. So also the telemedicine also help in the appropriate referral of the patient. Yeah, Baba. Yeah. Okay. So there were with telemedicine, there were also various challenges, and this was the systematic review, which brief like what are the challenges in terms of, there were challenges in terms of technical, like a geographical, because of the no proper roads, lack of transportation. Also, there were lack of supportive policy, like Dr. Uday briefly mentioned about it. There were also lack of skilled manpower in the rural areas. The funding was the issue in some places. But there were opportunities with the telemedicine in terms of education, training, and awareness. There was a cost-effective treatment because patient didn't have to go all the way to the center for the treatment. And also there was equity and the increased health access. So by this time, there were many like organization and hospital which were providing a telemedicine services. So, but there were no any coordination. So this Telemedicine Society of Nepal was established to bridge a proper coordination and organization among the organization which are working in the field of telemedicine and e-health. So this Telemedicine Society of Nepal and REN were able to organize this first telemedicine national workshop back in 2016, and then the second in 2019, where we were able to discuss from the medical side, from the engineer side, they were able to discuss all the telemedicine activities and how we can develop. But the process was slow. But then after this, the COVID pandemic hit, and it was a slight of a blessing also in the field of telemedicine, because because of this, more people were using now the telemedicine. We knew the importance of telemedicine after the COVID pandemic. So this study have shown that telemedicine usually save time, effort, and money, especially for people living in the remote areas. Now, because of this, now we already have our governing body in Nepal Medical Council already have a telemedicine guideline for us. And even the government has also this telemedicine guideline. Now, in future, hopefully in our curriculum also, we could include telemedicine in both engineering and the medical side. So the future looks good for the telemedicine. So I can tell Dr. Dital that he can enjoy his retirement happily, because the future is in very good hands among all the young and the very active members of who are actively participating in telemedicine. This was just last year a digital telehealth conference which was organized by Dharan, where we were able to again share the various telemedicine activities all around the world. So right now the field is even increasing. The telemedicine is integrated in the electronic health record, which has made the life even easier. So hopefully in soon time, they may not need medical anymore. It might be all AI also. So with this, I'd like to end my talk. Thank you very much.
Thank you, Sudeep. Just in time. Very proud of you. के गर्ने क्वेशन्सहरु अहिले गर्ने हो र पछि गर्ने होला पछि लास्टमा ओके
Our second presentation is by Dr. Omen John. This will be virtual presentation, and he's going to talk about telehealth for strengthening primary healthcare service delivery, evidence from the COVID-19 pandemic in Southeast Asia region. Dr. Omen John is a physician researcher, elected fellow of the International Academy of Health Science Informatics, associated editor of Oxford Open Digital Health, and conjoint lecturer of Faculty of Medicine, University of New Wales, Sydney, and professor at Parana School of Public Health. He served as an international advisory board of Commonwealth Center for Digital Health. Now we are going to listen Dr. Omen John. Dr. Omen John.
Namaste, Ajur. Thank you for this opportunity. I am grateful for giving me this chance to share about a study that we did along with WHO Southeast Asia Regional Office. I am just going to start sharing my slides. Please confirm that you are able to see it. I would need to be allowed to share the slide. Post, please enable slide sharing. Apologize for this. Thank you. Could you please confirm that you're able to see my slides?
Yes, John, we are seeing.
Yeah, thank you. So this study is called REACH, or role of telehealth in enhancing access, ensuring continuum of care, and supporting health systems for primary care in the Southeast Asia region. This was undertaken by George Institute for Global Health and on behalf of WHO Southeast Asia Regional Office. In this study, we used the WHO Digital Health Guidelines Development Framework, which divides the domains into interventions that face clients, interventions that are primarily for healthcare providers, interventions that are primarily focused on health system managers, and fourth domain being data services. So we identified in consensus with several stakeholders that there were three thematic areas that were important to study. This was in the context of the COVID-19 pandemic. So we were interested in looking at the telehealth uptake in the routine health services delivery before COVID, during the pandemic, and what does it look like for the future. So this was primarily looking at utilization of telehealth model before and during the pandemic and looking at what are the emerging trends. Secondly, we were interested in understanding what are the enablers and barriers to implementation, as well as what is the scale up of telehealth intervention. As all of us are aware, telehealth is nothing new. This has been around for several decades. However, the pandemic has really given us an opportunity to relook what were those systemic enablers that were probably lacking that COVID brought along, and how systems, both primarily from the governmental side and the regulatory side, that enabled quick deployment and massive scale up in response to a public health crisis. And what is the impact of telehealth on health services delivery? So quite often when we look at telemedicine, we look at from a point of a person who is in a remote area just trying to get care, and it's a transactional one-time activity. However, when we look at it from an ecosystem perspective or from health service delivery perspective to use as a tool for strengthening primary healthcare services, then we have to look at the accessibility of services, the cost of care, and what is it doing to the out-of-pocket expenditure, and how does it help in the continuum of care. All of these, there are good examples from the region and from Nepal as well, which we will delve into in the next coming slides. So just a quick overview. So like I mentioned, in 1990s were the beginnings of telehealth interventions in the Southeast Asia region. In the 2000s, there were launch of various primarily donor-driven pilot initiatives, and in the 2010s, there were advanced stages of implementation, but to very little success. And whereas suddenly comes the pandemic, and we saw huge growth because of the pandemic itself. Why did this happen? This was because of the disruption of routine health services, because health services was like repurposed for responding to the pandemic, and routine OPD services, routine care was suffering, and therefore telemedicine was a bridge to address that. Also, there was a need for massive scale-up of supportive services such as contact tracing, public communication, and even counseling and mental health counseling that needed to be, and for psychosocial support. And these were all easily deployable through a telehealth platform approach, and therefore it has been extremely successful during the pandemic. I will, in the interest of time, I will just quickly move on to what the region looked like from a pre-pandemic and a during pandemic scenario. So we looked at it from, was there a national e-health strategy in place? So several countries in the region, including Nepal, had a national e-health strategy, and there was a regulation to govern the coverage of telehealth. This was there in Indonesia and Sri Lanka, and active promotion of telehealth modality by government and public health infrastructure was there in Sri Lanka. During the pandemic, many countries, as you can see on this slide, rapidly ensured that the coverage of telehealth regulation through the guidelines like the previous speaker mentioned were introduced by several countries. And also active promotion or engaging of both private sector and public sector telehealth players into the public health delivery system also were embedded during the pandemic. Again, this is a busy slide, but I will just try to highlight what are the key components where telehealth can play a role in from a health system strengthening and a primary care supportive. So early screening and referral support. There are multiple modalities in which this is being done in the region: health workers training, behavioral change interventions, specialized services, diagnosis, treatment, and in particularly in rural and remote areas. And continuity of care, like I mentioned earlier, is a domain that we could look at from how telehealth could be a lever to strengthen our primary care services and the continuum of care. So there were various modalities like simple audio-based telehealth providers were there, then both audio and video like eSanjeevani, HelloDoc, and MyDoc. And then in many of our contexts, there was an assisted telemedicine model that was there. For example, in India, local, and in various other countries in the region, this assisted telemedicine seemed to be a modality that were taking up very well in the region, probably because of the digital illiteracy of many of our populations in this area, and also the need for that assistive decision making in our region. I'll just quickly go on to give you an overview of what different countries in the region have been doing. This is again a very busy slide, but India actually is leveraging telehealth for supporting its national digital health mission, as well as its ambitious Ayushman Bharat, which wants to give universal health coverage to its population. So 150,000 health and wellness centers have been established across the country. And at the core of this is a community health officer who has access to specialists across the entire country, who is available to provide telemedicine consults and continuity of care through the eSanjeevani platform. Bhutan has a robust national e-health strategy, and they have been leveraging telemedicine, particularly because of their geography and its remoteness of many of its citizens, to meet its public health objectives. And Sri Lanka has been investing into comprehensive national digital health framework, leveraging telehealth services with a focus on streamlining healthcare data sharing and population level interventions. So from these three countries that we just mentioned about, there seems to be an important role that a national digital health architecture, a national digital health roadmap, and supportive legal frameworks being in place for telemedicine to be implemented, scaled, and sustained. I want to just focus a little bit on this slide, which is because this relates to Nepal. Nepal has piloted several telehealth projects. However, there are several opportunities for scaling the existing as well as upcoming telehealth interventions for strengthening PHC with an aim to achieve universal health coverage through an ecosystem approach. What do we mean by an ecosystem approach? It is that telemedicine needs to be seen, or telehealth needs to be seen as an integral component of the health delivery system. It is not just an add-on just to make the connection between a remote patient and a doctor, but it should be an integral component, which means that it needs to figure in our line item budget. It needs to be considered part of the investment in our budgets as a health service delivery tool and mechanism. And it's fortunate to know that in May 2020, the Nepal Medical Council has launched the telemedicine guidelines, and that has helped scale up of telemedicine during the pandemic. There are several opportunities, like I mentioned, to ensure that this kind of becomes embedded from the ecosystem approach. And we look at that in the next coming slides. So like I mentioned, if you look at the analysis from the region, there are several challenges that are in front of us, but these are also immense opportunities given what we have seen during the pandemic. So on the policy level, there is still quite a bit of ambiguousness on the regulatory guidelines. We still don't have good mechanisms on the reimbursement. How will telemedicine or telehealth be paid for? And there is no real mechanism in place in most of our countries for accreditation and licensing of healthcare provider. Because when telemedicine or telehealth gives scale, if you're doing something wrong, the scale also enhances the harm at scale. Therefore, there is a need for having mechanisms for accreditation as well as of licensing of telehealth provider. A doctor cannot go out and just practice on their own. They have to pass the exam, they have to have a license. But today, telemedicine providers can practice with no assurance of quality because there is no regulatory framework for that. So there are several of the policy interventions that need to be taken care of. On the technological side, there are a number of challenges, which again are huge opportunities. So today we don't have frameworks for data security. We do not really dwell upon privacy standards, and interoperability is still yet a challenge. And our user experience for telehealth has been limited. There are lots of tools, like the previous speakers mentioned. Artificial intelligence, machine learning provides immense opportunities for actually generating a case report and a longitudinal health record just from the conversation using natural language processing. These are all opportunities that are just knocking on our doors, and I think we should just leverage them. And at the organizational level, there is lack of consensus on telehealth standards. While the telehealth standards were made in response to the pandemic, most countries in the region would need a little more focused work on standards that bring together different stakeholders and address all of the challenges as well as opportunities that are coming, and leverage this. And we really need to build in incentives for provider. Nobody is in this for charity. We need to look at how can we look at return on investment for the people who are investing in this, people who are building technology, and people who are developing these platforms, as well as people who are going to be providing these services. There are more challenges, but I'll just move on in the interest of time. So in summary, telehealth has been at the forefront of COVID-19 response. Sustained adoption for strengthening health services delivery really needs a strategic roadmap. And together, many countries in the region, if we come together and work together, we will be able to do this. There is definitely an opportunity for telehealth and telemedicine solutions to enable the continuum of care, including the longitudinal. Thank you.
Thank you very much, Dr. John. It was really enlightening.
Thank you. Thank you. Sorry that I've run out
you
of
have
time.
shown us that there are opportunities. There is just a fear that the rituals sometimes hijack dharma. That is the problem.
Yeah, thank you.
Now, while waiting for Dr. Anil Sawal, is he here yet, Dr. Anil Sawal? No, not yet. So while waiting for Dr. Anil Sawal, who is supposed to give us virtual presentation, I request Dr. Prakash Paudel, if you are ready. Dr. Prakash is at the Global Telemedicine Center in Nepal. He is very active nationally and internationally. We were just talking about the experiences in California. So, Dr. Prakash.
Thank you. Can you hear me clearly? Thank you. Thank you, sir. So Today, myself, Dr. Prakash Podal, I'm a physician, pulmonologist, and taking care of critical care patients at Nepal National Hospital. Today, I'm presenting on what we are actually doing as a global telemedicine center in Nepal National Hospital, and we have been doing a lot of activities through global telemedicine. So I'm trying to keep it very simple, and we'll be talking like what we are actually doing. So Global Telemedicine Center was established at the premises of Nepal National Hospital on 8th November 2019 with Professor James K. Good being the valued guest from California, USA. And I was very enthusiastic about Dr. Good because at the age of 78, he was taking care of almost 50 ICU patients through telemedicine, and he was working as a nocturnal critical care physician. So, and he was doing a lot of activities in telemedicine. So I was very impressed by him. So our background was one fine day, 6 enthusiast doctors from 6 different institutes all over Nepal came together to do something good in the field of telemedicine. So the institutes involved were Nepal National Hospital, Sahid Gangalal National Heart Center, Bhaktapur Cancer Hospital, IOM Maharajganj, Karnali Academy of Health Sciences, and Kathmandu Model Hospital. So doctors from these hospitals, we got together and we were planning something to do in the field of telemedicine. And I can see Pradeep Vaidya sir, he was also part of this. So with the global grant of Rotary International and support of global telemedicine, we got trained in San Francisco Bay Area. And after returning to Nepal, we decided to develop telemedicine in the respective institutes where we belong. And Nepal National Hospital is the center of all 6 institutes, which we developed as the Global Telemedicine Center. Later on, we added one more center, that is Mugling Highway Hospital. So altogether, we are now working on 7 different hospitals, and the to and fro of information of all these centers, Nepal National Hospital is acting as a center of this. So Global Telemedicine Center at Nepal National Hospital has been catering for a huge number of patients from inside and outside of the valley. And this service, as it has been a center of all these centers, so this service has been made easier by its dedicated toll-free hotline number 1174. So we developed this hotline number during COVID-19, and through this hotline number, we could get a lot number of patients calls regarding COVID cases and other issues also. So we took a lot of cases during that time. It has slacked a bit, but we are still working on it. So during COVID-19, this hotline number was instrumental in providing patient consultation as well as treating patients through telemedicine. It's a basic system, like we have developed a telemedicine consultation room, and these are the common devices used in telemedicine. And one interesting device which we have been using in telemedicine is Kubi. It's a telepresence robot, and when attached with a iPad or any kind of smart phones, then it enables practitioners to connect and engage with patients in many different telehealth settings, such as inpatient and outpatient visits, rural clinics, or any location where care is being provided. And I used it a lot during COVID times in my ICU, and during COVID, so since multiple rounds were not possible, so I use this, and every activity can be assessed through my mobile phone, so it made me very easy. So Kubi, when it is integrated with Zoom, it provides a special in-app feature through which Kubi can be remotely accessed and controlled, which enables better interaction with patients. And Kubi's pan and tilt moment personalizes telehealth for the patient and provides practitioners with the ability to engage and connect with both patient and on-site caregivers. So we can directly talk with the patient, and we can without any assistance from anyone. So it is easy to connect with the patient, so whether patient is in the ICU or patient might be in the remote place. So it helps both way, to the patient side as well as the caregiver side. So tele-ICU and telesepsis, Nepal National Hospital has developed a tele-ICU system for which we have placed PTZ camera in our critical care department with central monitoring system and telepresence robot Kubi. From the central monitoring station, vital monitorings of the patient along with communication with the live feed of the patients. We are doing this and it's an ongoing process. So after seeing these things of EICU, this concept of EICU, I didn't know anything about EICU, but after visiting in USA, I saw EICU, and after returning back to Nepal and me myself being a critical care expert, I wanted to reach more of the patients, critical patients to the remote places and in remote hospitals. So we are planning to develop some local system through which we could connect to the patients in remote hospitals. So in this regard, Nepal National Hospital, in collaboration with Global Telemedicine, have developed an intra-hospital networking system through which we could integrate monitors from different hospitals through a remote central monitoring station. 3 ICUs at different locations, that is Nepal National Hospital, Kalanki, Yeti Hospital, Bafal, and Nepal National Hospital, Nuwakot, could be integrated through this system. So we developed this system locally and we tested on that. And I think we did some good job. We tried a lot. We worked almost 1.5 months to develop the system. For this, broadband internet with 10 Mbps speed is being used at the central location for real-time updates. So objective was to monitor the data from medical equipment in a centralized manner, to monitor CCTV audio video in a centralized manner, to centralize the transfer of data between separate organizational entities. So the proof of concept was possible with the installation at the primary location. Primary location was Nepal National Hospital, and secondary location was primary location at Kalanki, and secondary location was at Bafal, one hospital, AT Hospital in Bafal, and one hospital at Nuwakot. So for this, we placed a stable internet connection, backup connection if needed. Public IP was used, high-end firewall devices, properly configured for the scenario, and intranet. So we use this, and at the secondary location, stable internet connection, firewall device, and intranet. In the secondary location, the firewall device, strong firewall device was not required, but a very strong firewall device was used at the primary location. So it is a brief model of what we did and what we are doing. Like in you can see in the picture at Nepal National Hospital CMS server, we have placed a server and a MBR server at a central monitoring station, and we have connected monitors, patient monitors in different departments. We have placed 6 monitors in ICU, 6 monitors in neonatal ICU, and we have installed PTZ camera in these departments. And through firewall, we could encrypt it. We made an encrypted tunnel, and we could connect the monitors of different hospitals from this station, and all the data were present in the live condition. So, and even the blood pressure monitoring and even the inflation of the cough was possible with this system. So constraint was broadband internet service at remote location is one of the major constraints, and we are still working to develop a device which can actually work on all kind of monitors and even extract real-time data from the ventilator monitors. So in this regard, we used the same monitors. We used Mindray monitors in all the remote locations, and so it was possible. But we are still trying to develop a system through which we can connect every kind of monitors in every kind of hospitals. So that would be easier for us. And the use of different HMIS in different hospitals will be a current setback, as we can transfer real-time radiology and pathology data and images between 2 hospitals. So other activities of Global Telemedicine Center include, since we are in a global network of telemedicine, we have been conducting weekly global grand rounds where we have been discussing all kinds of remarkable medical cases from all around the world, followed by question and answer sessions. And every session is accredited and CME points are provided, which are funded by Global Telemedicine. So different training and seminars is an ongoing process. We have conducted a lot of training sessions for paramedics and school children about telemedicine, and as well as we have been conducting different training and webinars through telemedicine. I think the 9 and 10 class has this one chapter on telemedicine, and they, many of the students nearby our hospital come to get trained about telemedicine in our center. This is a brief. This project was featured in Rotary International Convention as one of the fine project that was ongoing during the COVID times, and I was even featured in one of the renowned international magazine. So this is one of the picture where policy formulation of telemedicine, and I had presented there, and we have been using, we did a lot of calls during COVID, and it was all free, and it was possible through a toll-free hotline number. And conclusion would be, without proper demand, appropriate licensure requirements, fair reimbursement, and supportive regulations, the full benefits of telemedicine will struggle to be fully realized. Telemedicine should be utilized to support and strengthen existing doctor-patient relationship, not to supplant them. And Global Telemedicine endeavors to enhance and strengthen the quality of care provided through telemedicine. Thank you so much.
Thank you, Dr. Prakash. You completed your presentation in time, and he explained how Nepal National Hospital initiated to form Global Telemedicine Center in Nepal. And this is time, not only time, this is smart time. Now we have ICU, not only ICU, smart eICU. So let's see how this eICU works in Nepal. Now, thank you, Dr. Prakash. Now we are going to join with Dr. Sanjay Yadav virtually. He is going to talk about experience sharing in mental health management through telemedicine. And Dr. Sanjay Yadav is a faculty member in the Department of Psychiatry and Behavioral Health at Penn State Health in the United States. He is also involved in the development of an integrated mental health service delivery program in Nepal. And I would like to call upon Dr. Sanjay Yadav for his presentation.
Just making sure, is my slides visible? All right. So thank you so much. I feel very fortunate to be a participant here, and just saw an impressive line of several works in South Asia. So this is mostly my objective for this presentation is to show how we're doing a usual mental health work in the United States. It has been a humbling experience. I think before COVID, I almost did not know that telehealth or telemental health was utilized in different parts of America. So this is, and also to touch upon with my work in mental health in Nepal, how this might be more, can be associated as something for a future work. So what changed? And we're going back to this 18th March 2020, exactly 3 years for today. So most of our organizations in the United States got a similar email, and this is one of the emails that I am paraphrasing here, that transferred the care delivery overnight. So this email read in a similar line, like, colleagues, a long email, but please read before progressing. And we wanted to roll this out to you as quickly as possible. And followings were several tips and how the processes were built up. And within a day or two, from almost working in person with most of the patients, inpatient as well as outpatient, we suddenly had a rollout of telehealth, including telemental health. And that was very amazing as I reflect on how things transformed overnight. So as telemental health, and the purpose for this particular presentation is how telemental health would be slightly different. That but mostly similar, which is the use of telecommunications or video conferencing technology for particularly mental health services. It has been used in all variety of settings, including community mental health centers, and then prison or correctional facilities, as well as nursing homes, while mostly catered in outpatient care as well as inpatient hospitals. Telemental health uses very similar styles and technologies, such as synchronous and asynchronous services that you see in most of the non-telemental health works as well. So what happened? And this particular figure tries to highlight that mostly for almost a decade, the health use in the United States was about 1% or slightly even lesser. And you can see this huge bump that happened almost overnight. And in the first 2-3 months of the initial wave, we saw almost, particularly mental health, being part of 40% of all outpatient care. And that was definitely, while increased the access, it is also very impressive to see that rest of the healthcare, besides mental health, were in the range of 11%. And over just as the first wave was tapering off, we could see that some of this of the bump actually tapered off, and you can see that the rest of the outpatient care dropped from 11% to 5%, while mental health persisted. And that was partly because of the modality of care that mental health had access, and that still is going on very persistently on quite a significant, considerable percentage. So right now in the market, there are several different platforms, but these have been the leaders like Teladoc and Amwell. In our organization in particular, where I work, Penn Health, we've been using Amwell. And as you can see, telemental health now certainly has so many accessible features, as well as how several different innovative technologies have caught on. But in the landscape of the United States, it seems like the growth has slightly tapered, mostly in this past year. And then there was, again, another bump in 2022 earlier on, and while it has really now been plateaued. So, but it has also seen like almost several hundreds of startup companies, and they are in a very competitive market, while there are few very much like leaders, which are still holding like majority of the market. So I go back to some of the studies. As I read this, I think it was really good for me personally, just because I'm pregnant, and then having a young toddler already, it was good to just be able to use a speaker over the phone or Zoom, having multiple options rather than rushing around and trying to care for my baby, and then having to worry about leaving the house late and things like that. So definitely a cultural difference, as you can see, Western versus Eastern world setting, but these are very important in a daily US life, that this transformed and made accessible for a lot of mental health care. As there is no one size fit, and that holds true for mental health as well. What we have seen where the advantages have been similarly with remote settings, or where people have looked for more convenience, especially when it comes to childcare or flexibility, and people with more severe disabilities, and particularly in mental health care, such as people who have more anxiety disorders, have utilized this much more often. Well, there's exclusion, and that again, there's a lot of effort to make this inclusive. We see that people with most severe psychiatric condition, or people who have lesser access, or people who have been digitally divided, have faced and suffered exclusion in mental health as well. So largely, again, equity holds, that we're always trying to make things equitable. America suffers in a very similar way, although the internet penetration is more than 90%. It suffers in a very similar way, that the poor people, the more disadvantaged, the more vulnerable, also have further excessive of the digital divide. And again, similar recommendations of improving, consolidating, expanding the broadband have been made especially over the COVID-19 years. And there were several programs which boosted this, but we still see that there's a lot of divide which exists. So the success story, as we're highlighting, really has been that compared to the rest of the telehealth or telemedicine service, telemental health has been very much widely received. Is particularly helpful for conditions such as OCD, social anxiety, and a variety of other conditions. But these are the ones that have seen, like, people have been drawn out of their houses and then be able to have the access to the psychiatric providers. And certainly in terms of reducing stigma, how the mental health care facilities can be stigmatizing. This has been a great relief to be able to use telemental health. So these challenges, again, it's fairly universal, but what we have seen is to really provide a very most high quality mental health assessment. Telemental health falls short in several situations. It also does not or cannot easily overtake barriers such as, when it comes to doing a physical assessment. And there are several mental health conditions as well as medications that requires physical signs evaluation, and which is not possible through telemental health. Ethics, and again, this is much more upheld as the regulations are expected to be carried out, but just when it comes to ethical considerations, we see that the challenges comes like, how do you make consenting much more easy, or consenting in a proper way? There are several practice regulations which keep changing, and they are hard to keep up with, and those things becomes very much harder when it comes to telemental health. The HIPAA, which is the Health Insurance Portable Affordability Act, which actually tries uphold the protection of health information, and that becomes issue, especially when it comes to like telemental health. And we've made a lot of advancement in protecting this, but we see that that becomes always a challenging thing. And then there are several crossing boundaries that can happen. In particular, when we are doing the services in the personal homes from both the end, from the provider end as well as the service receiver end, and those remain as a challenge. So I was going to show like the usual workflow in terms of mental health, and this is not much different, but just at the advancement, they're much more regular in America. And I thought this simple workflow is worth showing, and that's why I'm presenting here. So the first thing in most of this process becomes the enrollment of the provider itself in telemedicine or telehealth. And similarly, patient requires enrollment, which is several security checking as well as identification, verification process. But the scheduling of patients I've seen that it has really improved over the last several months. And as you can see, a variety of ways like patients would be placed on the scheduling, and there would be a mixture of hybrid type of models, like some utilizing telephone, and while others are coming there for in-person visits, while the rest could be on video visits. These are all testing environment pictures, and none of them are actually real actual patients. But you can see how the next step of scheduling happens, where again a lot of data are verified, and this slide where the physicians or the nurse practitioners or one of the providers initiates this as an invitation to the patient, so that time, and then you go to the next step of starting the visit. So they're also given the choices of having them contacted by email or phone, and then there is a real time gap where both the patients as well as provider can have some time to preview where they are. Then comes the process of informed consent, which is very important, and particularly it is determined that especially name, age, and date of birth is verified before any of these visits actually take place. Similarly, clinical encounter, again, they can vary, especially in mental health. An initial visit goes along up to a length of 1.5 hours, but the follow-up visits are anywhere from 20 minutes to 30 minutes. And so, again, those are the processes of intimate interaction and several different forms of evaluation. The side-by-side documentation can happen as well, but as we see that, those documentation, if you're doing well, engaging in patient interaction can be hindrance. But nowadays, again, most of the platforms have made things very easy to document and as you know, psychiatric documentation tends to be longer. Then comes several different things like how you're billing, coding, for falling under the licensor, and then there are several issues as well of how insurance are reimbursed, and there are regulations that makes you again be under the site of practice agreement, and each of these devices have to be HIPAA compliant as well. So I'm going to end this with another statement from the qualitative study. The clinic is a bit far from my house, and I was working during the period, so it's a bit far for me to spend 2 hours on public transport. And as you can see, this matters a lot for in any level or class of American system, and where telemental health has really made things easier. So future direction wise, again, we're trying to figure out how hybrid models would be much more feasible, when to use appropriately several different apps and digital therapeutics, even in mental health. There are a lot of work still to be done in how to make better reimbursement. And there are still restrictions how, as a provider, you cannot practice across US state lines. So those things are tending to be more lax as we have seen the utility of telemental health. And this is to show that we're what is called payment parity. So COVID actually laxed for the reimbursement to occur, as opposed to prior to COVID, all telemental health services were not paid equally.
Thank you, Dr. Sanjay.
So right now, yeah, we're almost like 21 states have already gone to payment parity. And this is to conclude that it has really helped with expansion. And I think, again, there's a lot of value and scope to do similar things in Nepal. Thank you.
Thank you. Thank you, Dr. Sanjay. Your presentation shows what is doable and at the same time what needs to be corrected. Thank you so much. Now, Dr. Pramendra Prasad Gupta is here, right? He's going to tell us about the journey of BPKIHS towards digital health. He's associate professor in the Department of General Practice and Emergency Medicine and does a lot of things like being medical coordinator, e-health and telemedicine program in BP Koirala Institute of Health Sciences. He also chairs ONCA Working Party on e-health GD Hub, Nepal. Dr. Pramendra.
Thank you, sir. Good morning, everybody. And thank you, Dr. Uday, for inviting me and getting me opportunity to deliver a speak on this wonderful symposium. So, BPKIHS is an academic medical institute. So I'm going to tell you what we have done in digital health so far. With the objective of to demonstrate the feasibility of deploying distance CME and tele-expertise in district hospital in Eastern Nepal and link them to a tertiary care center to produce quality detective contents for distance CME adapted to the needs of practice in district level hospitals, and to organize a tele-expertise service at BPKIHS able to respond to the expertise request from distant hospital in the region. To involve healthcare authorities and decision makers, disseminate lessons learned, and implement a plan for sustainability and scale up.
to evaluate the impact on healthcare process and care outcome of a distance CME and tele-expertise network. With those objectives, in 2014, we started e-learning. Like we have in BPKSS, with the Ministry of Government, we have 5 or 6 healthcare centers, the district hospitals, which are joined with BPKSS. We send our interns to work over there. So we started e-learning with all those centers, in all those 5 centers, once a week, where all the consultants from different departments deliver updated topic which are used in primary level care. The challenges was inadequate technical facilities, with a lack of electricity and internet, and rough geographical distribution, which make transportation difficult in hilly and mountain region. Shortage of skilled workforce and supportive policies were also notable challenges documented. Meanwhile, major opportunities were education and training of the students and health practitioners and increasing awareness among the general population. With all those challenges, we started in 2015 the telemedicine, and 2014 the e-learning. E-learning were in all those district hospitals in Dhankota, Ilam, Sira, Gaigat, and Bhadrapur. So this is the website of our BPKSS, where we put all the CME lectures which was delivered during the e-learning session. In 2015, we started telemedicine. The selection of deploying tele-expert center considering geographical limitations and sustainability of the project was the main focus for selecting the survey site. And the site which was selected were Hikal PSC, it was Patle Community Healthcare Center, Parewadin PSC, Dara Bazar PSC, Belka PSC Rampur, and Pauli PSC Bhojpur. So these were the center where we run the telemedicine. But since COVID, it was held because government was already started isolation center where all the healthcare facilitators were pulled up in their isolation center. But now we have again started and we are planning to extend our telemedicine center in 100 healthcare center in eastern part of Nepal. So these are the total number of patients which we've seen in the telemedicine during 2014 to 2019. So these are the number of percentage of a patient in different district hospitals. These are the referred patients which are referred from different district hospital to BPKHS, like for operation, for investigation, further investigation, even for the specialized services. And this, the 12.1% was lost. We didn't follow up where that patient gone in BPKHS. The benefits, it was like the time saving, cost beneficial, direct contact with consultant, not have to sit in long queue, useful in counseling, effective in screening and health education. Where there were barriers and challenges also. The barriers were with internet failure, difficulties in audio visual, concerns about privacy, hesitation in adapting new technology, and lack of technical expertise. So to bear up these challenges, we train all the healthcare providers in a district hospital. In every 6 months, we do a training to them. We provide training to them. And then we also share all our telemedicine guidelines and our structure operative procedure for telemedicine with those, how we can operate telemedicine in those district hospitals. So there were lack of supporting environment also. It takes several weeks or even months to maintain the equipment and software if they stop functioning in the district hospitals because they are far away in the district, in the hilly regions, in the mountains. So we have to send our technician from Dharan there. But nowadays it has been already been, the issues has been solved. There are local technicians who goes over there and solve the problem. Health workers try to avoid the responsibility due to the lack of confidence, knowledge, and skill to use the available technology in delivery of health services. Lack of governmental coordination has also affected overall management of the rural telemedicine program due to the unstable political situation and frequent change of government. The policy related with the healthcare delivery system is fragile in Nepal. So these are the challenges like counseling to patient, because it was very hard to counsel the patient to consult through telemedicine, using telemedicine software and technical acquisition, clinical examination, basic surgical procedures, selection of patients, funding and sustainability, and low resource and underdeveloped infrastructures. We have also helped Bhutani refugee camp to start telemedicine in the refugee camp. They have got health post, then they refer the patient to AMDA for secondary care center and then BPKSS for tertiary care. So we started telemedicine from the health post to primary healthcare level. And these are the results where the referrals were decreased and the budget that was fixed for the referrals was also decreased after implementing the telemedicine program. So these are the paper which already been published from BPKSS. During the COVID, we started tele-OPD because in the first lockdown, all the hospitals were shut. So we started tele-OPD where all the department will make a schedule, a fixed schedule to come up in a tele-OPD services. These were the patient portal where patient can fill their form and then it goes to our system department wise and every department will come and see the patient via telemedicine. So these were the number of patients which were shown in tele-OPD. It was more than 10,000 patients we saw during the first lockdown. These are the percentage, department-wise percentage. And these were the follow-up patient in tele-OPD services. In second lockdown, we started teleconsultation program for the COVID-19 patient who were in home isolation. So we take a record from the municipal government, like municipality, and then we have put in 2 staff nurses with us who calls every and each patient and then asks regarding the requirement. So if they need any medical services, psychiatric counseling or dietitian counseling, we provide them. So these are the data, gender-wise data of that teleconsultation. So benefits of telemedicine in medical college will be to improve the transition of care for discharged patient from clinic to home settings. Telemedicine in medical education, clinical training for undergraduates, which we are already been doing. Well, undergraduates are sent to district hospital for a clinical training where we discuss the cases via telemedicine. Pre-surgical evaluation can be done via telemedicine, and telehealth can also be utilized as an excellent tool for trainees as well as increased participation of educational programs in the community. So there was the GPMER and BIMSTEC telemedicine network for all the medical institutes. So it with the aim of knowledge sharing among member countries of BIMSTEC, promote standards and quality control surgery by sharing operating videos, to initiate evidence-based guidelines for the common disease condition in the BIMSTEC region, use of teleconsultation to assess medical treatment in landlocked countries and small island states, preservation of traditional medicine knowledge, document and manuscript by digitalization, and to promote mobile health program in BIMSTEC countries. So these are the hospitals of Nepal and other regions who are joined in BIMSTEC countries telemedicine network. Then we done Nepal first digital healthcare ecosystem mapping. There is a Telementum app which you can download from Android and us users also. So we did ecosystem mapping where we tried to collect all the data of the leaders of the digital health who are working in Nepal, the organization, institute, even a person who are being involved in this ecosystem mapping. So we tried our hard to collect all the data, but there are still some organizations and people who are being missed. So I'll leave my email ID so you can contact me so we can update that in our app. So this was the workshop that was done during the mapping program. We did Nepal's first digital health hackathon, where the student of engineering college and the health participate in that hackathon, where they develop a medical app which can be used for a digital health in Nepal. So this was the runner of the digital hackathon. Even we did our Nepal's first digital health conference, which was on 29 November 2022. And I'll thank all of the people who were present in that conference to make that conference a success. And I'll thank Nick Simon Institute, WHO, Nepal Telecom Authorities, Subisu, and University Geneva, who were the main supporter of our program. And this was a training session which was done before starting telemedicine in rural health. So this was a telemedicine services done during the COVID lockdown services. So thank you. That was my experience for doing telemedicine and digital from BPKSS, and we are trying to extend our telemedicine services in eastern part of Nepal. So in this, from 2020 to December, we are trying to connect more than 100 healthcare centers of eastern Nepal with BPKSS for telemedicine services. Thank you.
Thank you, Dr. Parmendra. We are a little bit late in time, which is allocated till 10:20. And still we have 2 more presentations, both are virtual. And Dr. Parmendra did very marvelous job through BP Kerala Institute of Health Science. And he is one of the passionate person in digital health. Thank you, Dr. Parmendra. Now, I would like to request Dr. Miguel Tanimoto for his virtual presentation. He's going to talk about telemedicine experience in Mexico. He is a Vice Director of Ancillary and Diagnostic Service and Director of Telepresence, former outpatient gastroenterology clinic coordinator at the Gastroenterology Department in the National Institute of Medical Science and Nutrition, Salvador. Dr. Miguel Tanimoto.
It is a great honor for me to participate in this important telemedicine congress in Kathmandu, Nepal. I want to thank Dr. Udaya for his kind invitation to develop this topic. The title of my presentation is Telemedicine at the National Institute of Medical Sciences and Nutrition, Salvador Subirán. I have no financial conflicts of interest to disclosure concerning this presentation. This is my hospital, the National Institute of Medical Sciences and Nutrition, Salvador Subirán. We have 8 medical specialties, 16 subspecialty programs, 42 postgraduate fellowship programs, 13 medical schools attend for undergraduate courses, but we have only 221 beds. Our institution, below the medicine director, has 11 vice directions, and I'm the vice director of the ancillary and diagnostic services, as you can see in the image. This is the outpatient building in which we have more than 290,000 medical consultations every year. This is the new hospital building under construction. Before the pandemic, no one imagined or considered telemedicine present. Some even consider it is irrelevant and that it could never replace the traditional practice with physical contact with the patient. However, isolation due to the pandemic has led us to have an accelerated acceptance of the telemedicine globally. In an ideal world, research is financially supported. However, since the beginning of this telemedicine project, 6 years before the SARS-CoV-2 pandemic, we have not always had financial support for teleconferences, live demonstrations, consultations, case discussions with movie clips or slides with high definition. Thanks to TEMDEC and CUDI, we have had IT and financial support at important venues in Mexico. Also, thanks to the technological infrastructure of TEMDEC and the network of Japanese friends who are key opinion leaders in endoscopy, we started self-financing using a laptop and a commercial internet line with reasonable and stable bandwidth that connected to TEMDEC infrastructure through the video platform. With a high-definition webcam and a microphone donated by TEMDEC with a mute button, they could see us and hear us. The laptop then projected the received images through a projector, and we listened the conferences with some commercial speakers. With the breakneck speed that technology continues to advance, as with artificial intelligence, cloud applications, and social networking, clinical case discussions, webinars, and teleconsultations, new horizons have opened for the telemedicine. Nowadays, with 5G networks and devices that are increasingly available in any computer store, it is possible to create and participate in international symposiums like the one we are at now can be held. In 2014, thanks to the support of TEMDEC and CUDI, we carry out the first live demonstration to our knowledge between two hospitals in Japan, Kyoto and Osaka, and the Mexican Digestive Disease Week in Cancun. These are some images of the 5 Japanese opinion leaders who participated in the discussion table and the giant screens that broadcast the cases live from Japanese hospitals with an auditorium full of Congress attendees. In 2018, also with the support of TEMDEC and CUDI, we successfully carried out the first telemedicine workshop in Mexico within the Mexican Digestive Disease Week in Mérida. Between 2014 and 2023, we have participated in 29 Latin endoscopy teleconferences, together with several Latin American countries. Again, in 2015, we carry out a live demonstration between hospitals in Japan and Korea with the Mexican Digestive Disease Week in Mazatlan. 6 years ago, we began a series of teleconferences with leading professors of opinion in endoscopy on the diagnosis and endoscopic treatment of early esophageal, stomach, and intestinal cancers. Throughout 2 years, between 2016 and 2018, there were 16 conferences of 1 hour each. These conferences were held with the sole purpose of being a non-profit educational resource for the training of the new generations of gastroenterology endoscopists in Latin America. Thanks to a generous donation from the Cisco company in the United States, the first telepresence room was built at our institution. This is the inaugural ceremony of the Telemedicine Center. Before the start of the pandemic in 2018, teleconferences between Japan and Mexico were held in this telepresence room. For several years, numerous papers on computer-aided diagnosis, big data, and artificial intelligence have been presented at international venues around the world. They represent challenges and new projects for our institution. These are some images of the study sponsored by JICA and the Kyushu University for Nikkei doctors from Latin America. 2014, the beginning, and 2023, the present and the future of this project. Thank you for your kind attention.
Thank you so much, Dr. Tanimoto. Thank you so much. You were not only in time, but it was very important information for all of us. You showed us the power of the global cooperation and everything. So do we still have time for Q&A, or shall we defer it? We are already delayed by more than 10 minutes. So maybe we have a tea break first. Dr. Tanimoto, would be very glad to meet you someday. We are in the same planet, okay? And there is a big cyberspace for us to meet anyway. Thank you so much. So in the presentation of the first session, we could see the huge potentials of telemedicine and e-health. At the same time, the power of cooperation and networking. And maybe indirectly, we also could see the impedances created by unwise, regulations and other things, in contrast to accelerating the speed of the progress in ICT. Thank you so much.
Now that will be the end of session 1. What a wonderful session. Thank you so much, chairs, and all of you speakers for your wonderful, great presentation. Now we'll have a tea break for about 15 minutes. Let's come back sharply after 15 minutes. Thank you.
This. Okay, thank you. So is there anyone from Telemedicine? We would like to test the movie clip presentation.
Okay. Please start.
Okay, so please share a movie. And I think you can share by the screen. Display is okay. No, here. And the screen. Please share the optimize the video clip and the sound share. Yeah, both. And share.
So if you have a emergency, we bring the
And
people
make
from
the
here and into
audio bit,
this,
the display bigger.
emergencies for just under 200 people.
So,
This is the
Ueda-san,
consult
can
room,
you
one of the
hear
consult rooms. We have
audio over video?
We have
Yes, it's
three
audible.
consult rooms here. Again,
And
standard.
how about the
consult
image
room with
quality of the
Australian
video
standard.
movie?
It's good.
And this is the pharmacy. I've just
It's
opened
good?
the clinic.
Good.
Nobody's here yet.
Okay. Okay, then
It
the
is locked all the
た
time.
だ、ちょっと、左上に
And
グレーの箱が
basically,
出てます。
this is our pharmacy.
左上になんか出てるんですか？
Very well
はい
organized.
グレーの箱で
This
す。
is the
なんかそこアイコンかなんか置いてませ
immunization
んか？
fridge.
左上
We
です
take
か？
左上
temperature control.
いい
We
ですね。
report twice a day in emergency. This room is temperature controlled. And this is the
ありがとうございます。
controlled drug like morphine and midazolam, which is checked
本当だ。
daily, counted by 2 nurses.
今画面
Basically,
上
this
では消え
clinic
て
is
るん
run
ですけ
by
ど、
what
残り
we
ます
call
ね。
remote area nurse, which are
うん。
especially skilled nurses who have extended responsibility and skill sets.
あれこれ今大画面にしてるけど、大
And
画
the
面になって
doctors
ない
visit。here only once. Once.
ちょっと共有の仕方を変えます、じゃあ。
はい。
ムビーに選んで。Can you open video again? Could you share as a display? Screen が。Because
Yeah.
this
We
speaker
are
want
about
both
500
share
kilometers
both.
south of Alice Spring and close to South Airways support.
これ YouTube ですかね。じゃあ時差があるかな。
And
上田さん、今どうです
so
か？
if you have a emergency, we
ま
bring
た出てます。
people from here and
箱が出てます。
this
ちょっと待ってください。
emergency for just under 200.
Can you share again? You mean the PC is YouTube, so it's delay. I am checking the Zoom. Yeah. So no. Please share. Now it is no sharing. Screen. Yes.
This is the immunization fridge. We take temperature control. We record twice an emergency.
Could
This room
you?
is temperature controlled.
Yeah, this is the black
And this
black
is
space.
the,
Black space, as you can see here.
controlled drug like
Can you see?
morphine and midazolam, which is checked daily, counted by 2 nurses. Basically, this clinic is run by what we call remote area nurse, which are especially skilled nurses who have extended responsibility and skill sets. And the doctors visit here only once
消えました。
once a week.
はい。
And they
もう
do not
ちょっ
deal
と
with
こ
the
こまで
emergencies.
やら
We
なくて
do
もいいかも
basically
ですね、でも。
um,
なんか、
this is
ちょっ
another
と現地のスタッ
consult
フ
room,
が
as you can see. And this is the doctor's room
まあ
here, which is
やってもいいけ
basically
どって感
same
じで
setup
す。
as any. And it's an amazing setup, and it costs a lot of money and effort and the quality control to give the best possible care to
it's
the
okay.
client, even remote areas. If there's an emergency, we stabilize
ありがとうございました。
to
ありがとうございます。
contact the
Video will be within the first you speakers notes and access.
Oh, do you have IP1, no? We set up. Push IPv6 is B35D8 তিনটা ভ্যালু কোন 9C 4605 120 oh 5
So next presentation is from this venue.
Your 4.215. 4.5. 4 your 5.120
I'm not a public speaker, so. Once I start speaking, I think I'll do it. You want to be your first? Yeah, PowerPoint is there. Okay. I never run PowerPoint before with those slides. So I had to be there last night. For your report. Okay, I will take a picture. Oh, sure. I guess this is, yeah, that's it. It's well, it's pretty additional. I think that one, that was better to share screen, camera, yeah. That's what about it. It's so large. And I know that Telemedicine is now very popular in Australia. All this happened. Last 40 years that I've been working. My friend that was very to take care of the such as or so that we collaborate with you guys and start more all simultaneous I just work with us. It's a kind of I've demonstrated from the tree to the front, right? Yes, it's kind of should have an competence, but now they such yeah, using a lot of we need to, so what do you think? Sometimes yes, yes. So you need to share the I think that you're sharing the PowerPoint. Yes, yes, yes.
No, it's not, you in PowerPoint mode, is there in PowerPoint.
I see. Then please share the display setting to the duplicate.
Okay, no, sometimes.
But you want to, yeah, I think, I think that it's a problem of the PowerPoint. No. Usually, so user presenter view is always on, and I don't think this setting is keep for another presentation. So this presentation is okay because I check off the use presenter view. As you can see that in the slideshow menu, there is use presenter view setting. If it's on, if on, so this is a presenter view. That's the problem.
Yeah. Oh, yeah. Any
Yeah.
Otherwise,
It will be the
Okay, now we
Welcome back. Now we are going to start our second session. This session is focused on the role of nurses in telemedicine. Here we have also the virtual presenter. I would like to introduce the chairperson of our session, second session, Dr. Arvind Joshi, consultant surgeon of BNB Hospital. Please be seated, sir. Give him a huge applause. Thank you very much. And we have another chair, Ms. Radhika Gimire. She is a matron of Kathmandu Model Hospital. Please be invited her. Thank you, ma'am. Likewise, we have another chair, Ms. Sumita Pathak. She is a campus chief of Kathmandu Model Hospital School of Nursing. Please be seated, ma'am. Thank you very much. I would like to invite Ms. Radhika Ghimire for short remarks on the role of nurses in telemedicine.
Thank you very much. Thank you for the organizer team to give me opportunity to chair the session. Telehealth and nursing is very close words, not close words, close relationship. Medical science is failure without the nursing team. And we have seen in the pandemic COVID period, there was a big role of the nurses. And we are unconsciously, consciously, or formally or informally doing the telenursing. This is now the time about thinking the telenursing expansion in Nepal. I think the telenursing is not, it cannot be done in the simple settings. It is because of the license and nursing practitioners, there are the questions are big. That's why I would like to request our 3 nursing body in Nepal, Nursing Division of Nepal, Nursing Association of Nepal, and Nursing Council. These are 3 bodies to give the opportunity to expansion the telenursing. If we expand all over the country telenursing, we can give the critical care also in the remote area. And the nursing is the pinpoint. I usually said, nursing is the pinpoint. It has very much scope in education, caring, treatment, advising, counseling. Nowadays, there is a very big issue in the psychosocial counseling, school health. There as government has chance to give the school health nurse. And we can also expand in the telenursing in the school health program. In school health program, there is a nurse, so that we can create our group, student health club, and we can give them counseling, lifestyle changing, challenging life, how to deal with. So that telenursing is now the time to operate. We are happy to hear that this symposiums is, the theme is the role of the nurses in telemedicine. So we are so happy as a nursing professional, and Telemedicine Society of Nepal will emphasize and further work with our 3 bodies which mentioned before me. Thank you very much.
Thank you so much, ma'am. Ladies and gentlemen, it's my honor now to hand over this floor to the chair for the second session. Thank you.
Thank you. So we are here for the theme session of this whole symposium, Role of Nurses in Telemedicine. And without further delay, I would like to invite our first speaker. I think this is the remote presentation, Gandhi, Nepal, and the title is Provision of Healthcare in Remote Australia, Role and Responsibilities of Remote Area Nurses. Gandhi Pant.
Good morning to you all, and thank you, Dr. Zudai, for this opportunity to share my experience working with a remote area nurse. Remote area nurse in remote Australia. It's a really honor and pleasure to be here. As you can see, Australia is a huge country. Australia is a huge country. When we think of Australia, we basically think of Sydney, Melbourne, and Great Barrier Reef. But the interior of the country is extremely large. As you can see, Australia has a population of 26 million. Land mass is 7.88 million square kilometers. And it is the 6th largest country by mass, and 80% of people live just across that green area in the coastal region. And the interior of the country, as I said, is vast, arid, inhospitable, and empty, except the scattered settlements of indigenous people who have lived there for millennia. I have been working in Northern Territory. Northern Territory itself is quite huge. Population is only 230,000 people. Land area is 1.42 million square kilometers. 18% of Australian landmass. Darwin is the capital city with population of 150. The second largest is Alice Springs in the central of Australia with population of 30,000 people. North and south distance of Northern Territory is 1,600 kilometers and east to west is 970 kilometers. This is one of the communities that I've worked, and all the pictures that I have presenting it today are taken by myself and with permission. Just a warning, there are some clinical pictures which are a little bit of gory, and but it's a reality that we have to deal as a nurses on a daily basis. This is the map of Northern Territory from the island communities and all the way down to the Central Australian communities. These are indigenous settlements. Population size is, there are 72 communities, as you can see, that are scattered all around. Population size of these communities can be anywhere from 100 to 3,000 people. Most of the communities are below 500. So, and the Northern Territory has the highest population of indigenous residents amongst its population. And as you can imagine, providing quality healthcare in this landscape and in this environment is quite challenging in many ways. Nearest hospital can be anywhere from a few hundred kilometers to 1,000 kilometers. Unfortunately, indigenous health is quite challenging. They have the worst of the both worlds. You have the scourge of communicable disease, primarily caused by poor nutrition, poor hygiene, cramped living conditions, and the harsh environment they live in. The temperature can be up to 50 degrees centigrade in summer times and very arid. And also now they have adapted the Western lifestyle, and they, as you can see, the 5-year from 2015 to 2019 data, the mortality rates by categories you can see, as it is explained there. So, we have a special category of nurses in remote area. They are called remote area nurses, and they are the backbone of nursing care and medical care, providing quality medical care to the indigenous communities. As you can see there, RANs work, we work independently. Sometimes we work alone. During the night times, we are on call and we deal with all the emergencies. The good thing for us is that it's a protocol driven and the help is only a phone call away. Telemedicine has been well advanced in Australia for the last 14 years that I have been working there as a freelance remote area nurse in different communities. As you can see, the previous map that I have probably worked in all the communities that were scattered in that map of Northern Territory. We assess, treat, and evaluate care that is based on standard of treatment manuals and protocol manuals. And when those, and that is our scope of practice, we practice within the guidelines of those manuals. And when that manual, that practice of guidelines requires, then we communicate through medical retrieval and consultation center, which is called MRAC, via phone or video. And we have been doing this for a long time. All clinical data enter into PCI's patient care information system, which is remotely accessed by attending doctors. Some of our MRAC specialists actually working from Melbourne, working from Sydney, and some of them actually working from Europe and South Africa. They are all Australian certified and qualified, and they have to go through a lot of training as well. So standard of care is, these are our essential books. We practice within the guidelines. As you can see, CAPA, which is the Central Australian Rural Practitioners Association. It tells us all, allows us to prescribe certain antibiotics. It allows us to do certain procedures. And the Women's Business Manual, which is culturally appropriate for Indigenous women. And then we have the other reference manuals, which are the Central Australian Handbook of Injectable Drugs, Australian Medical Handbooks, and so on. So what are in order to provide a quality healthcare, you need to have a quality education, quality training, skilling, reskilling, and upskilling. We are quite proficient in stabilizing patients that come to us. And these are the basic criteria where you have to have in order to become a nurse. 4 years of postgraduate clinical nursing experience. They prefer you have their ICU and emergency. And in some cases, they will take you if you only have ICU experience. Have gone through an 18-month of transition program from RN to RAN, remote emergency care, which has to be recertified every 2 years. Maternity emergency care has to be recertified every 2 years. Advanced cardiac life support and pediatric advanced life support every 2 years. One of the most important thing that we do is we actually dispense medications. So we are the pharmacy. So for that one, you have to have a pharmacotherapeutics for registered nurses, which is a certification from university. We also provide primary health care. That is our bread and butter. For that one, we have to do childhood vaccinations. So you have to have a certification understanding vaccine and national immunization program. And Australia has a very, very high rate of vaccination, up to 80–90%. So in terms of core competencies, you must be able to work independently as a remote area nurse. You have to be able to make a decision and escalate as required. Must be proficient in basic suturing skills, plastering skills, phlebotomy, urinary catheterizations, venous catheterizations, NG tube insertion, and must be able to have a computer skills. In addition to that, obviously, licensing is well controlled. Your nursing license is renewed every year. And the police criminal check will have to be also done every year, as well as working with the children check, which is just to ensure that you are okay to work with children. So that is also controlled by the police. And there are other many requirements on an annual basis. Continuous education is another part of it. So in order to renew your license, you have to have 50 hours of continuous education, and sometimes more depending on your level of expertise. So this is one of the last community I work, as you can see how it is. Only 170 people live there. Nearest hospital is about 400–500 kilometers away. And this is, I worked there last month. This is a 2-nurse post, but unfortunately, because of the recruiting issue, I was alone there for 6 weeks with a non-clinical person, a driver as my support, and I was on call most of that time. That's another community in the Western Australia, right in the central. This is just a view of how the community looks like. This is one of the community called Ingawala. That's another community, the local people just enjoying a little bit of evening time with the fires. And then there's a kangaroo on the fire as well, as you can see. Just to warn you, as I said, some of the pictures are a little bit gory. So this is the central of Australia. I've worked close by here as well. And we are very close to Western Australia. This is absolutely arid and absolutely inhospitable climate. So what are the emergencies that we manage? Stab wounds, lacerations, and the head injuries. Unfortunately, there is a lot of mental health issues and substance abuse. So we deal with the successful suicide attempts, successful otherwise. Chest pain and the respiratory distress are actually taking a lot of our times as well. As you know, when there's a chest pain, you have to rule out the cardiac origin of it. And being in Australia, of course, we deal with envenomation. snake bites, spiders, scorpion, and up on the top end, box jellyfish, envenomation, irukandji as well. We also attend motor vehicle accidents. As you can see, unfortunately, roads, there are no traffic lights and no speed limits, and the roads are often dirt roads, so you can tip over very quickly and very easily, and it is not a good experience to deal with motor vehicle accidents. As a matter of fact, last year I had to deal with one, and it was not a good experience with some fatalities there, and I was the first on the site. We also deal with acute rheumatic fever because of the prevalence of skin problem, especially in impetigo. That is it's a developing country, poorer sub-Saharan country disease, but we deal with it.
Time limit.
Okay. Under 2 is febrile, as you can see, and acute alcohol intoxication and all that sort of issues there. So there are some of the clinical pictures, just be mindful. Infected scabies and abscesses, and as you can see again there, cellulitis developing in the last picture. Unaffected catch in both instances, and in the second picture was he came with the wound dressing, but he had a blood sugar of greater than 39.4, which is 628. These are some laceration. This lady, alcohol intoxication required, I won't go through that video. That's what happens when you have a head injury. So we had to transfer the through Royal Flying Doctors, which are always on standby for us, depending on the acuity. It is a huge problem with the dental, especially amongst the mental health client with the oral issues. A little bit extra that I do with the patient from time to time. And this is one of my patients that is very good painter. And as you can see, I'm having a little bit of time with the locals there. And this is also something quite interesting in the Australian community. And unfortunately, that little Joey didn't survive. His mother was killed on the road accident. So the people brought that to the clinic. And the boys are always boys, so they wanted to have a fun and caught a little bit of saltwater crocodile in the water hole and brought to show us. In the outbacks, sunsets are always out of this world, and the sunrise as well. And that is the presentation. And I also take care of the little bit dogs whenever I get opportunities in the communities. So there are a lot of feral dogs. So without the telemedicine, we wouldn't be able to survive working in remote communities, often alone and making decisions, and without the support of the other professionals on the other side of the phone and the video. And it really, really works well. And I hope we can all learn from Australian experience. Thank you for your time.
Thank you, Mr. Nepal, for enlightening us with the concept of remote area nurses.
We are really honored to have Dr. Mingmar Sherpa sir here. He's a telemedicine legend. And also Dr. Mahavir Pun, he was here. Yes, sir. So thank you. Yes, Mahavir sir. Thank you. Here are our seniors, our partners, and thank you so much for being present here. Thank you.
Namaste. I would like to invite Kanchan Gautam as a second presenter. She is from MNCS FP Rural Healthcare, Nepal. He is presenting about telemedicine in primary healthcare center. Kanchan Gautam had completed her bachelor degree in nursing science and master degree in clinical psychology. She has been working in her remote areas for Nepal for quite some time. Currently, she is working as a technical officer for maternal, neonatal, child health and family planning in rural places of Nepal.
Okay, then this is your screen there. And
In the meantime, I would like to have some comments for Mr. Nepal. It's very interesting to know that there is a definite this term of remote area nurses is not very known in Nepal. So I think this whole concept of specialized remote area nurses could be very new for Nepal. I'm sure that you must be making Nepal very famous in Australia. Thank you very much for your presentation. So, Pansan Gautam, you
Yes.
can start.
Namaste and a warm good morning to all of you. It is a matter of great pleasure and honor to be speaking in front of all the respected personalities present in this premise today. I'd like to especially thank Dr. Uday Koirala for giving me this opportunity to speak in front of everyone. And I'm thrilled to be in the 16th Asia Telemedicine Symposium. I'm Kanchan Gautam. I'm currently working in the maternal neonatal child health and family planning field, and as a part of my job, I train and educate the health service providers of various health facilities of rural areas in Nepal. As we all know, telemedicine is the system where the healthcare professional communicate electronically with the healthcare participants located anywhere in the world without having to physically visit them. Through telemedicine, the healthcare provider can examine, investigate, and manage a patient with both of them located in different places, and they can treat them through electronical devices and technology. Similarly, primary healthcare is an approach which addresses the broader determinants of health, which focuses on the comprehensive interrelated aspects of physical, mental, social health, and well-being. It is the initial level of health facility with essential primary healthcare such as maternal, neonatal child health, family planning, immunization, reproductive health services, first aid services, and so on. Every one of us witnessed the usefulness of telemedicine in the times of COVID-19. The number of people taking online health services, including counseling, increased exponentially at that time. The engagement of telemedicine in primary healthcare level helps to bridge the urban and rural health divide. Having worked in the field of maternal neonatal child health based in rural part of Nepal, I have experienced various instances where a complicated delivery managed successfully by virtual mentoring provided by nursing staffs through the help of trainers. I recall this one time when a nursing staff of a primary healthcare center called us because she was skeptical about the management of eclampsia. So we mentored her and she was able to manage the case successfully and refer it to the higher center. Besides that, multiple cases of postpartum hemorrhage has also been managed through telemedicine, saving the lives of many women. Furthermore, I have witnessed the patients with mental illnesses getting better with regular online counseling session. With that, healthcare professionals are providing birth preparedness counseling, family planning counseling effectively through telephone, and in many cases, forcing complication has been prevented through a simple phone call consultation with the healthcare providers at the primary healthcare center. Having said that, there are still some challenges that comes along by providing healthcare facilities in the primary healthcare center through telemedicine. Firstly, the inaccessibility of internet services, electricity, Proper network, lack of basic amenities like computers, router for internet, or a simple smartphone are some of the hindering factors. Second of all, the mindset of healthcare participants can play a major role. Because as far as I have experienced, the low literacy rate, language and cultural barrier in the people residing in rural areas of Nepal make them reluctant and rigid towards new technology while more inclined to the traditional health-seeking approach. So these aspects should be taken into consideration. It goes without saying that telemedicine is an enormous step in healthcare. Government and non-government bodies need to align their efforts towards sensitizing importance of telemedicine to the people, ensuring the accessibility of technology, basic amenities, and providing the healthcare professionals with basic training and incentive, especially in the underprivileged areas of Nepal. I firmly believe that this generation will get the bulk of our healthcare in the palm of our hand. With telemedicine, the future of healthcare system seems brighter and full of hope to me, and it has a long way to go. Thank you so much and have a great day ahead.
Thank you, Ms. Gautam, for sharing your experience about saving life with technology. And I would like to invite our next presenter, Professor Yoko Simpuku, and from Hiroshima University. Professor Simpuku is Vice President of International Public Relations and Professor of Global Health Nursing. So Professor Simpuku, his title seems very interesting. His title is Use of a Smartphone App in Telemedicine.
Thank you very much for the kind introduction. I'm Yoko Simpuku from Hiroshima University. I'm going to talk about use of smartphone app in telemedicine. And my field of research is Tanzania, and especially in maternal child health. And maternal health indicators of Tanzania includes maternal mortality ratio is 556 over 100,000 live births, and births attended by skilled personnel in rural area is 55%, which means nearly half of women do not have any access to healthcare when they are giving birth. And if anything happened during delivery, it's going to be too late to save mothers and babies. So I developed educational materials using midwifery point of view, which means to keep normality of mothers and babies and prevention of complications. Because if complication happens, it will require a lot of resources, including human resources. So it is better to prevent complications. And I use evidence from WHO guideline and local findings. Because if you use international global guidelines in the local area, it is sometimes difficult to understand what this means and how you can really implement the content of the guideline. So I use this expertise in local area and merge the global evidence. And I developed the picture story, and we provided educations to mothers and their families in rural side and followed them up 1 year later. And we found that if they received education, they knew more health center or hospital in case of emergency, and they arranged someone to accompany her to go to health center or hospital for birth emergency. And woman decide her birthplace with family members. And they attended antenatal clinic more than 4 times. And in the end, there are less trouble like bleeding or seizures during labor and delivery. There are less cesarean section and there are less complications of newborns. So we found this education is somewhat meaningful, and we want to expand this education to national level. And I was also finding some issues in the medical record in Tanzania, which is paper-based. This is like antenatal care and the labor record, and it's paper-based, which means it's easily broken or lost sometimes. So it's better, we are thinking it's better to make it online or records, electronic records, so that we can keep the record if you lost some piece of paper. So this is the idea of the app. This is called Personal Health Record, and midwives can access to this record, and also mothers can access to the record. And midwives can input the data of antenatal care, and they save in the clouds. And mothers can access to their own records so that they can see what their condition is based on the antenatal care. And we also put educational materials into the app so that anyone can access to the educational materials, and which means that midwives used to provide education to each woman. It would take a lot of time to educate everyone one by one. But if the contents are already in the app and anyone can access, this can create the knowledge network and connection in the platform, and the workload of midwives can reduce. And this is how it looks in the app. It's called Talifa the Mama in Swahili, which means mother's record. And if you go to the second page, you can see how many months you are and your expectant delivery day. And according to the gestational weeks, you can see the condition of the baby and pregnant woman. And if you go to the chart of yourself, you can see visually your weight and blood pressure. And if any abnormal data are available, you can see immediately. And you can see the more detailed data if you click it. By the way, it's all written in Swahili because it's the language used in their original local area. And this is the Mama's BBS, which means this is the social media. Mothers can ask or write anything to share the information. And midwives sometimes jump in the conversation if any information is not medically correct. And mothers can share the information like peer education. And this is how you can look to input the data into the app. Midwife is just touching the phone and she's checking edema of the pregnant woman, and they are saying, oh, there is no edema. So she can just put no into the app and it's already recorded. It's very simple and easy. Anyone can use it. And it's already available in the iPhone and Android as well. And in the social media, BBS, there are many, many comments they send. And if you look at the words they use, they wrote like go, give, midwives, mothers, and ask. And if you analyze this data, how the words are connected, you can see mothers is asking midwife about their problem and asking if they should go to the hospital or not. So they use, as I said, they have limited access to antenatal care and delivery care, and they don't know, they are not sure when they go to the hospital. But in this app, they can ask directly to the midwife if they should go or not, which is quite useful to save the health condition of mothers and babies. And another interesting fact is that fathers who came to the antenatal care with their wives, they kept asking us to let them download the app. So it was meant to use for the mothers, but it's also useful for the fathers to learn about their condition of the wives and the babies. Then they can know how to take care of their own wives and babies. And currently, we are trying to develop the project with more electronic mobile devices, which is called ICTZ, which is a mobile fetal monitor, and it's created by a Japanese company called Melody International. And we collaborate together, and we also try to run the mobile clinic and use this device and app together. Then app can be the network, the platform for sharing the information, and any doctors and midwives can access to the this fetal heart monitor record. Then they can say the baby is in a good condition or not, and if there is any bad condition of the baby, we can refer the mothers to the hospital. I hope this project can be helpful for mothers and babies because we used to focus on mothers and we had less information about babies. But now we can see more condition of the baby, and then we can save more mothers and babies together. So this is our current project, and we hope to see the effect of this project in the near future. Thank you very much for listening.
Thank you, Yuki. We have to learn about the very dedication to the health service from the remote area health workers. Thank you very much for your nice presentation. Now we would like to invite the Professor Fumihiko Yokota from Kyushu University. Fumihiko is presenting the mask wearing behavior among people who were unaware of their diabetic status or cross-sectional study during the first COVID-19 wave in Indonesia. Professor Fumihiko, the floor is yours.
Hey, good afternoon. Namaste. My name is Fumihiko Yokota from Kyushu University, Fukuoka, Japan. I want to thank all the organizers, Moriyama Sensei, Kudo Sensei, all the Telemedicine staff, and all the Nepalian audience and staff for giving me this opportunity and make this conference happen. I would like to start my before my presentation, I would like to share 1 minute video which shows our telemedicine project at the Kyushu University called Portable Health Clinic. So can anyone see this video now? Is it shared?
Yes.
Okay, thank you. I will start. This project called the Portable Health Clinic Telemedicine System started in 2012 at the Kyushu University in collaboration with Grameen Communication in Bangladesh. And the purpose is to increase access of a basic health checkup screening to the rural area and to save lives and to save medical costs by detecting disease at the early stages. So basically, this portable device carried by the nurse outreach service to the rural area. This portable box contains more than 20 medical device sensoring connected to the mobile phone and tablet. And the nurse will first goes to the outreach hotspot and doing the registrations using a barcode for each patient and do the health checkup, the blood test, BMI, blood pressures, and this is a glucose test kits and urine test as well. And the result will immediately screened and diagnosed these using screening device and categorized into 4 depending on the priority of the disease. And those who have orange or red color, which has some type of disease, will arranged by the nurse to access to doctor at the central level by telemedicine. So this is supported by the nurse and can get the e-prescriptions for them to get the drug nearby the hospital. Okay, so having said that, I would like to start my presentation because this presentation is based on this activity, telemedicine activities. The data is used. This is a mask-wearing behavior among people who are unaware of their diabetic status, cross-sectional study during the first COVID-19 wave in Indonesia. So this slide shows the conceptual framework of this research, and I'd like to explain about the objective and the research question and hypothesis, which basically we would like to find out the association between type 2 diabetic and mask-wearing behavior. So this after adjusting for these confounding factor, 6 confounding factor, which influence both diabetic conditions and mask-wearing behavior. Another objective is to find out the percentage of people in rural area who are not aware of their diabetic condition and who are newly found the diabetic condition after this health checkup. So the hypothesis is if they already know their diabetic condition, they are more likely to wear mask. However, if they are not aware or not known about diabetic status, they are less likely to wear the mask. That is a hypothesis to be tested in this. And mask wearing, these data are corrected by the questionnaire and health checkup data. This one is health checkup data using the Easy Touch GCU. And mask wearing, we ask question, in the past 30 days, ever used mask? How often do you use mask outside the home? Always, often, sometimes, not, never. And we categorized into 2, always or not always. And to test this hypothesis, we use the SPSS and chi-square test and the logistic regression test. And this data was collected at the 3 rural districts in the central Java in Indonesia called Yogyakarta suburbs. And 206 patients received this health checkup who are voluntarily recruited from the community residents. And this one was corrected. This activity was implemented during the first wave of COVID pandemic in Indonesia. This graph shows that the y-axis is a number of COVID positive patient, and the x-axis is the time. So this is the February to April in 2021 is a survey period. So this graph shows the data collection process, how the nurse played an important role in this data collection. As you can see, as you saw in the movie, nurse played an important role for registering the patient, asking the questions, and checking, conducting a health checkup and the data entry, and arranging for the doctor's consultation, patient, nurse to doctor, telemedicine, and e-prescription printing, and the explanation, education, and the next appointment for follow-up, and the continuation of the follow-up. So this is a result showing that looking at the two factors, first one is, have you previous history of diabetes? They already know or not know. And this is this survey's result of the diabetes. So this red box showing that they didn't know before they are type 2 diabetes, but they newly found at this survey, at this health checkup, that they got blood glucose level is more than 226. So which means 74% of the rural people are not aware, not known about their diabetic condition. And this yellow part saying that they say, yes, they knew they are diabetic, but they still, their glucose is high. So which means they are not controlled. 70% are not under control. And the blue color box means they are aware and they are controlled. They are not, they didn't get 126 milligram or more blood glucose at this survey, at this blood test. This is another result that showing the relationship, association between newly found type 2 diabetic status and the mask-wearing behavior. When you look at this red box color, 16% are not always wear mask among those who are type 2 diabetic this time, comparing to only 6.7% are not answered, not always wear mask among non-type 2 diabetic participant. So it means that if they newly know, they didn't know before, but they knew this time, they are more less likely to wear a mask. And this is another, this is looking at the history of diabetes. They already knew that they are diabetic, then they are more likely to wear mask and less likely to not always use mask. So this is the opposite result. So this is the final result that those who have diabetes, newly found diabetes, they are 3.8 times more likely to not always use mask. And if they are already they knew already they have a diabetic condition, then they are less likely to not always use mask, meaning they are more likely to use mask. So based on these results, it will be important to increase access to screening tests for those who are not aware, not known for the diabetic condition, and as a nurse role to educate rural community people for appropriate method to prevent from disease at the early stages for increasing mask wearing behavior for next pandemic. And thank you so much for all the listening. Dhanyavad.
Thank you, Professor Fumi Iko, for your wonderful presentation. Now we would like to invite Suruchi Khadka for presentation. She is presenting on revolutionizing home-based nursing care, the benefit and challenges of the integrative telemedicine, benefit, opportunities, challenges.
Your time will be 10 minutes only.
A very warm good morning. Namaste, everybody. I'm Suruchi Khadka. Today, I'm going to talk about revolutionizing home-based nursing care through telemedicine. I'll give a brief introduction. We'll talk about the benefits of integrating telemedicine in home-based nursing care, challenges of integrating telemedicine in home-based nursing care, and potential solution to overcoming challenges of telemedicine. In recent years, there has been a substantial change in the healthcare business toward home-based nursing care. With the introduction of telemedicine technology, patients can now obtain quality medical treatment from the comfort of their own homes, while healthcare practitioners can provide more efficient and cost-effective services. Talking about the benefits, there are lots of benefits of telemedicine in home-based nursing care. So the first one is increased access to quality care. One of the significant benefits of telemedicine in home-based nursing care is that it increases access to quality care for patients, especially those in remote or rural areas. Telemedicine enables healthcare providers to deliver high-quality medical care and consultation to patients and from a distance, overcoming geographical barriers. Improved patient outcomes. Telemedicine enables healthcare providers to monitor patient progress in real time, allowing them to intervene quickly when necessary. Talking about another benefits, we can say telemedicine helps in enhanced patient engagement. With telemedicine technology, patients can actively participate in their care by monitoring their health, communicating with healthcare providers, and accessing educational resources. This can lead to better patient engagement and empowerment, resulting in improved healthcare outcomes. Cost effectiveness. Telemedicine technology can significantly reduce healthcare costs by eliminating the need of patients to travel to healthcare facilities, reducing hospital readmissions and optimizing healthcare delivery. So now let's talk about the challenges. Technology barriers, security and privacy concerns, legal and regulatory challenges, integration with existing healthcare systems, reimbursement and funding challenges, resistance to change, and lack of awareness are some of the challenges. Talking about technology barriers, one of the significant challenges of telemedicine in home-based nursing care is the lack of access to technology. Patients who do not have access to smartphones, computers, or high-speed internet may not be able to benefit from telemedicine services. Security and privacy concerns are also one of the challenges to apply telemedicine in home-based nursing care. Telemedicine involves the transmission of sensitive health information over the internet, which raises security and privacy concerns. Healthcare providers must implement strong security protocols to protect patient data from cyber threats. So, legal and regulatory challenges. Telemedicine is a subject to various legal and regulatory requirements, which can vary from state to state. Healthcare providers must ensure that they comply with all applicable laws and regulations to avoid legal and regulatory issues. The next one is integration with existing healthcare system. Telemedicine technology must be integrated with existing healthcare systems to ensure that patient data is properly captured and shared. This can be challenging due to differences in software and hardware platforms. Reimbursement and funding challenges. To support the implementation and maintenance of telemedicine programs, it tends to be costly. Resistance to change and lack of awareness. Hesitation due to lack of understanding or familiarity with the technology. It can be one of the biggest challenges in telemedicine. So some of the potential solutions can be needs assessment and goal setting, stakeholder engagement and collaboration, training for healthcare providers and patients, effective communication and documentation can also be one of the greatest solution, continuous quality improvement and evaluation. Thank you very much. I would like to thank the organizer team and special thanks to Dr. Uday for providing me this opportunity. And thank you all. Thank you very much.
Thank you, Ms. Kharga, for letting us know about this new facet of nursing care, home-based nursing care. And now we'll move forward for the next presentation. Our next presenter is Dr. Prabhat Adhikari, and he'll be talking about tele-ICU care. And a brief introduction about Dr. Adhikari. Dr. Adhikari is MD in infectious disease and critical care. He's been practicing both in Nepal and USA. And he's been leading some research project, mostly in the field of infectious disease and ICU. Dr. Adhikari has established a medical IT company called Dafe Care. And Dr. Adhikari has been providing healthcare services to the underprivileged population of Nepal through the ASK Foundation, a non-for-profit organization. Dr. Adhikari, the floor is yours.
Good afternoon, namaste, everyone. And it's my pleasure and privilege to be here. And today I'll be talking about tele-ICU. So we'll be focusing more on the tele-ICU, the technical and the clinical aspects of it, and our experience in Nepal, and what's the future holds for tele-ICU globally. So I think I'm the last speaker, and then we have lunch. So let's please bear with me for the next 10 minutes. You come with me. So, so the subtitles of today's presentation would be, we'll talk about the problem statement, especially in Nepal, and why there is need of tele-ICU. And then we'll talk about what is tele-ICU. Then we'll talk about impacts of tele-ICU and how to implement it. And then if we get some time, we'll also talk about our experience in Nepal and some telemedicine research we've been doing and what next in the world of telemedicine and tele-ICU. So let's start with the problem statement. So I'm going to go with the real cases that we've been dealing in tele-ICU. So this is a case from Nepal back in 2021. So there was a 55-year-old female. So I don't know, some of us are doctors, so we'll understand. But anyway, I'll try to simplify it. So there's a 55-year-old female who got COVID pneumonia, and she got a really bad complication. We call it ARDS. That's when your lungs are totally shut down. You can look at the picture. So if you have ARDS, it's really bad. You can put the patient on the ventilator, but it's very tricky because you have to manage the ventilator, you have to manage the other medications. So it's a lot of issues going on. The patient was already on shock and wasn't getting better, and they were of course having problem with extubation and taking care of the patient. That's when they reached out to us. That was a local hospital within Kathmandu Valley, and the hospital reached out to us for help. At that point, we're too much occupied. There was a lockdown, so it was not possible for all of us to, or some of us, to go to the hospital every day. So we went to the hospital for the first time, and then we set up tele-ICU kind of thing. And then onwards, we started taking care of the patient by tele-ICU in Nepal. And within 4 or 5 days, the patient got better and even got extubated, and that was all good. So the scenario with Nepal is that every 1,000 population in Nepal, there is only 0.8 doctor. That I'm talking about general overall doctor. So there are only 30 plus critical care doctors all over Nepal, and most of them, or almost all of them, are centered in Kathmandu. So you can see that there's no critical care, proper critical care, I would say, outside of Nepal. So it's really bad, And if you talk about USA, I also work sometimes do tele-ICU to US. So there's another case in US. So that happened in 2019. So 35-year-old male in ICU with status asthmaticus and AFib with RVR, and the patient was on BiPAP, then maybe got acidotic, intubated, was also on diltiazem drip, and soon after intubation, the patient coded cardiac arrest. So they followed the proper ACLS treatment. That's a protocol, but they need help. So critical care doctor were there. So what happened is that this patient was given cardiagem. So for cardiagem, you need antidote. You need glucagon, right? So the patient wasn't getting glucagon, was getting all different meds of ACLS, and the patient isn't waking up, right? So what you need, you just give glucagon. You give 1 shot glucagon, the patient woke up next after the shot, So that's what you need. So 1 glucagon, the patient woke up, and the patient was later on extubated, walked fine. His mental status was good. So this is a few of the examples where saving life is important. And what you need is just the idea or just a discussion with the critical care doctor. So the critical care doctor shouldn't be there all the time, because you have other doctors who can take care of the ventilator. They can put lines, they can do a lot of things. But this kind of situations happen all the time, and you need somebody on your back, and that's tele-ICU. So what is tele-ICU? Let's go into details. So this is a really nice article from Frontiers review article in 2021. And especially after the pandemic, the telemedicine as such is booming, right? So telemedicine is a lot of things. So we discussed about telenursing, home isolation, telecare, so it starts from home to the outpatient, even in the ambulances, goes to the emergency department, goes to inpatient, goes to the ICU, and even goes to pathology labs, because you have telepathology, you have teleradiology, and you have all different specialties we have in medical sectors. You can do it telemedicine. So it's called telemedicine, tele-ICU, telepathology. So you can do everything tele, most of the things tele. So it goes with the cycle. So whenever there's an introduction of new technology, there's always denial. People are not used to it, so they will kind of deny or they refuse. There's hesitancy, there's reluctancy, and later on they see the benefits, and there's acceptance, and they start becoming advocates. So it takes time. So we are in the baby steps, right? So telemedicine has been introduced in Nepal, and one after another, we're taking baby steps. So ultimately, we'll get there. We'll get to tele-ICU, we'll get to tele-stroke, we'll get to telecardiology, we'll get to a lot of things, you know. So why did the telemedicine picked up during COVID? So idea is simple. So not only in Nepal, the situation of doctor-patient ratio is bad even in the developed countries, because doctors, the hospitals are short-staffed, you know, and especially they are really short-staffed in ICU and super specialties. You don't have enough doctors, right? So so Society of Critical Care Medicine in the United States, they came up with a plan because they had COVID. So all different hospitals, they were flooded with COVID patients, and everybody has to take care of the patients, right? And they didn't have critical care doctors enough, right? So what they thought is that they will just make a team of service providers. So this will be an ICU doctor, and under him will be non-ICU doctors, and then there will be ICU nurses, and under them will be non-ICU nurses, right? And they were like, each ICU doctor under his team was taking care of 24 patients or even more, right? And then even that was not enough, because not all the hospitals had critical care doctors. So then they came up with tele-ICU. I mean, it was already there. They jumped to tele-ICU. So what they would do is that they would actually, so sometimes there will be no doctor at all, right? There's no critical care doctor at all. So how would you do? So what you do is that you put on the tele-ICU doctor or ICU doctor on telemedicine, and you also have a parallel team of paramedics consisting of clinical pharmacists, nurses, whatever you need, right? And then they will be coordinating with each and everyone, and especially they'll be focusing on here. So that's a pyramidal system. So with that, with one telemedicine doctor, he could take care of 24, a lot of 24 groups, you know. So one telemedicine doctor or one critical care doctor would now be able to take care of hundreds of patients, right? So that's the trick. And that's what they did. And fair enough, you know, telemedicine or tele-ICU kicked off. It saved a lot of lives, you know, problem kind of solved until they had more plans. So this is tele-ICU. What you do, so what you see in the picture, it's really complex, but it's very easy to understand. So this is a tele-ICU doctor, critical care doctor. So there will be a team of nurses and other paramedics will be involved. So you'll be in constant communication with them here, right? And sometimes you can actually see a patient, you know, with a video, audio visual, right? And then the patient's monitor, you know, EKG monitor or other monitors, they will be seen here. They are called physiological monitoring. And if you want to look at the X-ray or CAT scan, you have PACS monitor, right? And after all, you need the EMR, online EMR, right? Where you can see the labs, you can see everything, and you can put the orders, or you can write a note, you know, so everything through EMR. So that's all you need. So to summarize, what you need is actually, you need inputs from three ways, you know. So the first input you might need is audio input. So you talk to the patient, you talk to the nurses or the doctors at the bedside. So you need audio input through telephone. You can actually talk to the patient or the patient's family there through visual input or camera there. And actually you can look at the monitors or even at the ventilator through the camera, right? Because ventilators, they haven't been integrated yet, right? So you have to look them up. So these are your inputs, and of course you check on the labs and everything, notes and everything through your EMR. So what you need is, you need EMR, you need PACS to look at the X-rays and CAT scans. You need physiological monitoring to look at the EKGs or whatever you want to look. And also nowadays there have been clinical decision supporting apps. So there's been different apps that have been out there where they can categorize the patients based on Apache score. So in ICU, you use different score. You can use Apache score, SOFI score, whatever. And those scoring system, they can predict the prognosis of the patient. So based on those Apache score, you can actually prioritize who is the sickest patient there and who is less sick. And based on that, you can prioritize your work, you know. So it's all technology. So it's a complex slide, but what I'm trying to show is that the intensivist could be remote, and he needs all these three inputs, and there will be a really good connection, you know, internet, you know, that's really important. So you need bidirectional audiovisual link, you need data transfer, information management, reliable network, you know, everything. So it's complex. The biggest thing you need is you need a team, and you need a really good IT with the internet, you know. And it's good for Nepal, because Nepal, we already have 40 Mbps or even higher, you know, dedicated IPS lines you can get. So that's really good. We have fiber optics, right? So it's good. So actually tele-ICU can be even broadened, because through the tele-ICU, you can actually connect to the blood bank, you can connect to the pharmacy, you can actually sync with other hospitals, and you can even sync with clinics, you can sync with ambulance and the emergency, you can even sync with the mobile apps. And recently we're talking about the patient portals, like you can have patients glucose monitoring thing or EKG loop recorder, whatever. So you can actually integrate those. So you can have real database of the patients, and you can provide live teleconsultation. So let's talk about the impacts. So there's been a lot of studies. I think this is from 2018. So you can see that they did a lot of studies. So they were actually dividing the patients in the ICU, those with telemedicine and those without telemedicine. And if you look at the curve, so patients who had regular care, on top of that, they had telemedicine care, they had more survival. They had survival benefit, stands out, right? So telemedicine actually, or tele-ICU actually adds to survival of the patients, and it's proven. And so there's been a lot of other researches, studies. So the Society of Critical Care Medicine in the United States, they have mentioned that it saves life, it usually adds on to decreases your mortality and morbidity in the ICU. It decreases your length of stay in the ICU, right? And overall doing so, you'll actually be saving cost. There will be cost benefit as well. And also you'll not be hiring a lot of doctors, right? So you need one ICU doctor, he can take care of 100 patients. So you'll be actually saving a lot of money, right? So to summarize, the benefits of tele-ICU is that you have reduced length of stay, you have constant coverage, you have decreased mortality, you have decreased burnout of the physician, because critical care doctors who don't want to work in the night, they can have nice nap, and the other doctors, tele-ICU, will take care of them. So there's a lot of benefits, and this is from the remote ICU I work with. So how to implement tele-ICU, if you're talking about how to implement tele-ICU in Nepal. So it's going to be a phase wise. So what you want to do is that first you want to make sure the receiving team or receiving hospitals who want to get tele-ICU support, they get the idea and they are ready with it, right? Ready in the sense they have the team, they have their administration, they have the budget, whatever, they are ready with it, right? Or maybe it's a government. If the government is ready, that's the first step. And then you need to go for planning. So in planning, we'll go for detailed project planning. So you look at the human resources, you look at the infrastructure, internet, IT infrastructure, EMR, look at all those things, right? And of course the budget estimation. And then we'll do the training. We'll do training of the local people, because it's always better to empower the local doctors and nurses so that the process becomes smooth. And then we go for implementation, and as we implement, we get the monitoring and feedback loop, and based on that we improve ourselves and the team. So it's a phase wise. So our experience in Nepal. So so first we started actually with the COVID. So we're actually working with CCMC. I'm glad to see our colleagues there. And so when COVID hit in Nepal, we were in panic mode because we didn't know what to do, right? So. And the government had actually mentioned that the patients should be staying home because they didn't have enough beds. But the problem was that who is going to monitor the patients at home, right? There was lockdown, there was not enough doctors. So the idea was to do remote monitoring of the patients at home through telemedicine. That's where we started first. And we provided free telemedicine service for the people. And then we started commercially. We started like providing the service all over Nepal. First, we started from Kathmandu. It was really good. And then we got to learn a lot of things. And we're doing the triage system based on CDC. So CDC had a tele-triaging system. So based on the tele-triaging system from CDC, and also implementing our own Nepal Medical Council's guideline, we made our own tele-triage, train our doctors, train our nurses, and we went in a pyramidal system, just like I mentioned earlier. And then we rolled out the telemedicine care all over Nepal, and we had 24/7 hotline, And then we really got motivated, and then we actually had agreement with NMA, and then we started. We also provided telehealth consultation for Nepalese out of Nepal. So that's a non-residential Nepalese association, right? Organization. So they reached out to us. So we started providing telemedicine care to people outside Nepal. So we had people especially from Middle East, Japan. In the first wave, we even had patients from Europe, and all of these people were Nepalese people, right? And they had problem with the communication or language or some other barriers or financial barriers. So they couldn't get proper care in the hospitals in their countries. And we were there for rescue, And then in the meantime, American Nepal Medical Foundation, they reached out to us, and then we started doing tele-ICU care, because a lot of our patients, they were getting admitted in the hospitals, in the ICU, and they would, of course, want us to provide our care. So we would do an MOU with the local hospitals. And also we worked with American Nepal Medical Foundation, tapped into doctors from United States, and we used to provide tele-ICU care. We started in Janakpur and I think Birganj, and that ran during the first and second wave. And then we were also awarded 2021 Best Startup Healthcare Award from International Organization.
I think you have exceeded your time.
Yeah, I think that's pretty much from my side. Yeah, tele-ICU is growing, and I think the future is bright. Thank you.
Thank you, Dr. Adhikari, for the wonderful presentation. You showed us how to do it, how to make it happen. So we can see that the telemedicine horizon is broadening and is expanding. Thank you, Dr. Adhikari. So I'd like to invite our Radhika ma'am to summarize the session, please.
Sorry, ma'am. Before summarizing, I can see ma'am Sanu, Professor Sanu ma'am here. Thank you, ma'am, for being present here. It's an honor. So our theme, role of nurses in telemedicine. Now there are so many presentations, excellent presentations, and excellent works going on. And I also see so many online participants, especially Professor Changji Chuang from Taiwan, Satya from India, and so many other online participants from Nepal. Thank you all for participating online. Thank you, ma'am.
Thank you, sir. This session is very important because our voice is nurses' roles in telemedicine. The presentation were very good, and I wish to conclude the session. The remote area role of nurses is very important. Nurses not merely work in health, but also in empowerment of women through lifespan. Through your presentation, it is the message to nursing professionals. But basic training, define and train nurses are with the core competencies are must necessary. And we have to work for the standard treatment manual, protocol manuals for the nurses to work in the remote area. And the Kanchan Gautam, thank you for your primary healthcare. This is very important because our nursing is the home-based care. Home visit, clients' needs and health problems, identification and care accordingly is the job of the community health nurse. Our healthcare system has the public health nurse as such in the remote area also through the various healthcare systems. So telenursing must be based on the emergency nursing, can save the many lives and prevents the complication for their quality of life. Government must empower the nurses and should have to consider in the retention of nurses in their service setting. There is another presentation, use of smartphone in telemedicine. We are using and it is very popular. And in this case, dedication to the health services in remote health workers are most important. There is a portable health clinic tools was presented here. Basic health checkup kit, nurses needs, every nurses, community health nurses in the home-based services should have to provide the basic health kit. And healthcare system using nurses in all areas. So nurses' role in healthcare improvement in nation is very important, that government must be centered in nurses are a major part of the body system. After that, the Suruchi revolutionized the home-based nursing care through telemedicine. It is our goal, empowerment of people for achieving their own health through the nursing action. There are most of the challenges. Most challenges is among them legal challenges. In Nepal, there is no provision of the nurse practitioners. That's why the curriculum must be developed and the universities should have to work in this case. Awareness of people for provision of, awareness of people about the importance of nurse for their own health is most important. We nursing professionals should have work in this to go on the public. Challenges in trusting relationship to the nurses from the public parts. So at last, tele ICU care, we also, Kathmandu Model Hospital is using this tele ICU nursing, and some systems are for the tiredness of the healthcare professionals. Some systems, ritual systems, we were changed. The 3-shift nursing shift were changed to the 4-shift nursing shift. It is a pioneer work in the Kathmandu Model Hospital. Some of the, I have to share in simple yoga and meditation practices using CC camera monitoring to the patient with video call to the individual patient was practices. It was very useful. And so in nursing curriculum, now we have to include the telemedicine and telenursing also. Include the technological practical orientation to the all nurses is must necessary. Service provider, the nurses, some ritual standards must be changed. Very useful in the disaster management in like disease outbreak conditions. The nurses are the vitals organs. So we can conclude from this session that nurses are vital organs in healthcare system, and public awareness about nursing profession is the key to expand the telenursing in all over the world. We have to lots of work on this telenursing and people's health. So there is a 4 P's for the telenursing: preparing, planning, preparing, providing, and performance evaluation are most necessary. Thank you very much for the quiet listening.
We have a wonderful session. Thank you very much for the presenter and our chairs. Please go through this survey form and fill up for us. Here is a scan. And now this is the time for our lunch break. We will.
Small announcement. So after lunch, 1 o'clock, we'll have photo session, and we want the photo of all participants as well. So those who have not given your photos, please consult Dr. Rajkumar Dangal. Yeah, he's here, and he will be collecting the photos if you have. Otherwise, you will be taking your photos. Thank you. And after 1 o'clock session, we'll have photo session downstairs in the lobby, and then we'll join again in 1:30 here. The presenters who have not submitted the presentations, please submit your presentation here, and please scan this for your feedback. Thank you.
Hospital. He's a professor and also coordinator of DM Medical Oncology, and he's the current president of Nepalese Association of Palliative Care, and is also the advisor for the Telemedicine Society of Nepal. And I will also like to request Dr. Sanjeev Tiwari. He is the General Secretary of Nepal Medical Association to chair this session. Let's give him a warm of applause.
Now, after lunch session, the first speaker is Dr. Rajni Sakya. The title of the topic is Dholikhel Hospital, Kathmandu University Hospital Journey Towards Research in Digital Health. And to introduce, Dr. Rajni Sakya is working as a project manager at the Research and Development Division under the Dholikhel Hospital, Kathmandu University Hospital, Dholikhel Hospital, Department of Public Health and Community Programs, vision to be a center of excellence for the innovative and holistic approach to community-based healthcare and community development in developing countries. So let's welcome Dr. Rajani Sakya.
Thank you, sir. So I think most of the post-launch sessions are bored, but I'll try to be more informative. But I also agree, I think everybody agrees that we carry our health in our pocket, in our hand. So from the very morning, we have been discussing about lots of things about the telemedicine. And after this post-launch session, now I would like to connect telemedicine, digital health, and M-Health. So on behalf of Dhulikhel Hospital, Kathmandu University Hospital, I am privileged to present here about the Dhulikhel Hospital journey towards M-Health in research. So my colleague, Dr. Rajkumar, will be talking about the Dhulikhel Hospital a bit after this presentation. So I would like to jump directly to the Research and Development Division. That is one of the division that is in Dhulikhel Hospital. And the vision of Research and Development Division is to establish Dhulikhel Hospital, Kathmandu University Hospital, and we call it Kathmandu University School of Medical Sciences as well, as a leading center of innovative, cutting-edge, and high quality research. So the mission is to improve lives of people through innovative, ethical, and high-quality health-related research with multi-sectoral approach. I think for every every implementation of the programs have to be evidenced, and that is what research help to bring the evidence and to implement the programs successfully and to scale up the program, not only in the community or in the nationwide, but globally as well. So we have 18 researches completed, 20 ongoing projects, 22 plus collaborators, 19 plus sponsors, and 100 plus researchers working in R&D. So in this 100 plus researchers, as the theme guide today, there are lots of nurses. More than 50% are the nurses, and I would also highlight the role of nurses in this particular project in few slides later on. So the area of the projects that we are being covering are non-communicable diseases, infectious diseases and genomic surveillance, mental health, maternal and child health, health system, health behavior and promotion, and vaccine trials. So we have lots of collaborators and sponsors from all over the world, and these are some of the glimpses from North America, Asia, Australia, Africa, and also Nepal. So we have some partners from Nepal, like World Vision, Medic, Possible, Nepal Health Research Council, and so on. I can see lots of faces, the stakeholders that is being partnered with our hospital and all over the world. Thank you. So now coming to the particular M-Health researches and programs. I already said there are lots of researches going on, but now I will be talking about the researches and programs. Only the 6 programs. So here the first one and the 6th one is the program. Besides that, others are the researches. So in brief, WDF project, that is World Diabetes Foundation project, that is nurse-led continuum of care approach for addressing diabetes in Nepal, and OCEAN, that is optimizing a community health program for hypertension in Betanchok and Panchkhal municipalities of Nepal. And third one is the MIRA project, that is an implementation study of M-Health integrated model of hypertension, diabetes, anemia, and antenatal care in primary care settings in Nepal. And then fourth one is a GDM project, that is development and testing of mobile health application for management of gestational diabetes. And fifth one is about the mental health, that is sensing technology to personalize maternal depression treatment in low resource settings. And the sixth one is community health support program that is run in Dolakha. So now coming to the particular projects, actually I want to show you where
the mHealth is being used and how the role of nurses is, what is the role of nurses in this particular project. Actually, what happens in this project is the nurses, there is diabetic nurse, we call it, they organize diabetes screening camp, and they register the everything of the participants, the people coming to the camp in the EHR system that is widely known, electronic health record system. And then if the client is found pre-diabetic or diabetic, then that will be counseled through the ETSs from the application. And then if the person is diabetic, then they will, pre-diabetic or diabetic, they will get this card, and this card is then goes, the patient with this card goes to the Dhulikhel hospital, and it will again record the findings in EHR system in the hospital, and then the diabetic nurse will again follow up the client monthly. So this is how the workflow is go on for the WTF project. So in this 10 minutes, I will not be able to explain everything. So if anyone is interested to know more about these projects, then I will be reachable. So another is Ocean project. So what happens, like this is the project we just got approved from NHRC. And then for this project, like what happens is, so here, not the nurse, but FCSB, that is the female community health volunteer, who are the pioneers in health in Nepal. So we are planning to give a mobile device to the female community health volunteer, and with which she will also be provided digital sphygmomanometer. So she will screen the health, the blood pressure of these clients in the community, and she will give also health education. And if she is found hypertensive, the FCSB will not diagnose the hypertension, but if she found her or his blood pressure raised, then she will refer the patient to the frontline health worker, and then this frontline health worker will have all the digital recording system in that particular health facility, and the this frontline health worker will treat the participants from the health post level. That is the rural one, the grassroots level health system in Nepal, we say. And then that will be again like training and support will be given by the medical professionals from Dhulikhel hospital and also from the government side to the frontline health workers who is working at the rural areas of Nepal. And of course, there will be policy support and government support. We seek to scale of this optimizing the health problems of the community level people, especially in hypertension. So now here comes this MIRA project. So what happens in this MIRA project is like we recently finished this project. Actually, this this project was intended to do the randomized control trial, but due to some constraints, budget constraints and all, we have to finish it with the implementation only. So we're developing the MIRA EDSs, that is with the collaboration of Public Health Foundation of India, London School of Hygiene and Tropical Medicine, UK. So when we were developing the MIRA EDSs to be used by auxiliary nurse midwife, we also came to know there is another app that can be used for the from the A&M for maternal health, especially for the antenatal care. So this green one we can see is the WHO ANC reference app. I think it is somehow similar to one of the presentation. I don't remember actually the name who presented it, but it was similar to the one presentation we came to know about in the morning. And then in this, what happens is like when the pregnant woman attains the ANC clinic, then the auxiliary nurse midwife will record the ANC details in, like we implemented this in 20 facilities. 10 facilities were using the MIRA EDSS and 10 facilities were using the WHO EDSS. And on the top of that, she also records everything in the paper record system, because we can't get rid of paper system as instantly. So everything, whatever there is in the ANC card, that is in this digital health record system. So with this, it will help the ANMs and build the capacity, build the competency level of the ANMs to detect and counsel high-risk pregnancy. And then it will help early screening, detection, and timely management and the referral of high-risk cases to the higher center. And again, just like if I get some risk and I go to the higher center from the health post of Nepal, one of the remote health post of Nepal, then I can again come back to that auxiliary nurse midwife and to the same facility, and then I can continue my follow-up. So being myself as a pregnant woman, so this is how all the workflow is worked. So coming to the another GDM project, okay. So this is also for the pregnant woman. This is what happens in this project is like when the pregnant woman come at the age of 24 to 28 weeks gestational age, then her blood glucose level is being tested. That is glucose challenge test is done. And then if she got diagnosed with the GDM, that is the gestational diabetes mellitus, then she will be provided the application, the glucometer, the digital sphygmomanometer. So what she can do is she can test her blood glucose level, self-monitor blood glucose level, and then blood pressure. And also there are some icons of this physical activity, and then how much food is being intake, and then also was educational videos about the gestational diabetes mellitus. And so with this all, like that have also the web portal to the doctor side, and then that will help doctor in the patient treatment and disease self-management by the client. And in this, seeing this web portal, and there are lots of things like I can't just I mentioned I can't explain everything in this smaller slide. So seeing this dashboard, and the research nurses also monitor the web portal and do the bi-weekly telemonitoring follow-up to monitor the patient condition. And then next, this is about the mental health in the postpartum depression. This is a bit complicated picture, but I'll try my best to simplify. So what happens in this project is the woman with depressed mother, the depressed mother will get the smart watch, and the baby will get the beacon. So this is a picture of baby. So here is the baby has got beacon, and then this smartwatch and beacon is interconnected, and then it will see the proximity of the woman to the infant. Speech, it will also, this smartwatch will also collect some speech and environmental sounds, but not exactly the verbal clips, but only the essence of the clips. And then physical activity and GPS location. And then what happens is this is collected in mobile phone through electronic behavior monitoring application. And these all things will go to the counselor app. There will be the app that is being used by the counselor to counsel the depressed mother. So with this, the counselor can see if really the woman is in depression stage or not. Then the counselor will go to the community and again verify if really the woman have or depression and she needs counseling or not. Then after that, she gives the counseling to the depressed mother, and it is an intensive process for 4 weeks, and it has very good outcome as well. So actually this is Stand Strong 2. This Stand Strong 1 was implemented at Chitwan, and previously it was like the woman did not get this smartwatch, but only the application. But now it is being transferred to smartwatch. Everything is smart, I think. So next is this is about the community health support program that is run at Dolakha. So we also use Android mobile app that is used by the community health workers, and where they register household, conduct guided health assessments, provide basic medicine and health care, and also report danger signs or referring patient to the clinic, and that the data is get synced to the health facility. That should be the one hub facility, and then there will be one person that will be the CHW, that is community health worker supervisor, utilizes this CST to mobilize and connect CHWs, that is community health workers, ensuring they are equipped with evidence-based resources, continually trained and support through proactive supervision. So these are the resources and the programs that is particularly focused in the AM Health. There are lots of challenges and then barriers that we have faced. But it is not able, I'm not able to explain everything here. So if you would like to reach me, you can reach me individually and institutionally as well. So these are some of my references. You can see about the GTM project here, and then for the Stand Strong, what type of application is this, and all this. This is in Nepali, and then this is the reference for WHO application for the ANC, and this has been also implemented in some other countries like Rwanda, Tanzania, and Indonesia. So I think I'm on time, and without acknowledging my colleagues, research assistants, research assistants, technical teams, coordinators, investigators, and international investigators, these programs would not have been succeeded. And we look forward for more collaborations and networking to build a similar platform, especially in Nepal and also around the world. So I think everybody agrees this digital health and M health have to go on open source code. So we also follows the same. So that's the last slide for my presentation. Thank you.
Namaskar, good afternoon. Now I want to introduce Dr. Rajkumar Dongal. His title is Telemedicine in Rural Healthcare, Some Experiences, Challenges, and Project. He has largely devoted his clinical work in rural healthcare, including 1 year of dedicated telemedicine work in rural healthcare, MACD, of Center for Rural Healthcare and Telemedicine under FECT Nepal. Recently, he worked in Dolakha Hospital, Dolakha, which is an outreach hospital of Dhulkhel Hospital, for about 2.5 hours. Right, and he has been working there for 2.5 years. Dr. Dongal has passion for working and advocating for undeserved and unreached population, and is currently pursuing fellowship in Global Health of Heal initiative at University of California, San Francisco as well. Dr. Dongal is a general practitioner and emergency physician, currently working as lecturer in Department of General Practice and Emergency of Dhulkhel Hospital, Kathmandu, University Hospital, Dhulkhel, Nepal. Dr. Dongal completed his medical school from
Hebei Medical University, China in year 2010, and residency in general practice and emergency medicine, MDGP and emergency medicine from Institute of Medicine, Nepal in year 2018. And he was under me at that time. I want to introduce him. Oh, thank you.
Good afternoon, everybody. Namaskar. Thank you, respected chairperson, respected delegates, my senior colleagues, friends, ladies and gentlemen. It's my privilege and honor to be here in front of you and present some of my previous experiences and some of the recent advances going to be in our Dhulikhel hospital. So let me continue. So here I'd like to acknowledge Telemedicine Society of Nepal, Dr. Uday sir and team, FEC Nepal, respected Professor Saroj Dhital sir and team, of course, respected Mahabir sir for previous my support for me and all the motivations, and of course, Dhulikhel Hospital team, including Dr. Biras. Okay, so here I would like to share some of the experience some 4 or 5 years back. So in Magdi, Nangi, the remote village, at least 4 or 5 hours travel from the Beni, very serpentine, very muddy road. So there is a rural setting for the telemedicine, of course, through the Center for Rural Healthcare and Telemedicine, CRST, through FEC Nepal. So there has been a huge experiment also, and that's also a huge try also, I say. And at that time, there was, of course, some good experience of delivering service to the underserved population, remote population. So we could establish the telemedicine gadgets and services. The hub was the center where I used to stay with my colleagues and medical officers, and around there other health facilities which were usually government facilities, health post and sub-health post, they were overseen by the hub center. So that was the experiment also, and somehow successful. And that was the scenario. So that the picture on the right, that was the hub center, health center with the operating theater facility also. That was far away remote. With you can see the geography, topography of the picture. Okay, thank you. So there was the operational modality. So red one hub, that was the picture on the right, just before that. And there are supposed to be mobile units with the medical officer or general practitioners, and then other village units that may be the our own operated village units or the health post operated by the government. So we try to establish that kind of model of the healthcare. And so yeah, the same picture, and these are interconnected by the ICT. And that's I would like to mention, of course, the network connection over there was all mostly provided by Dr. Mahabir Pun. His efforts, the network already established far long years back, and that is so innovative and so appreciating job. And we use that network to establish that kind of telemedicine service. So here, I'd like to go into another aspect. I just going through some of my colleagues working in the different rural setting in Nepal. So recently, so I was just asking personally, what is the current status of telemedicine service in your center? So I could see, you can see the red marked things that they have no telemedicine service or even set up in most of the district level hospitals. Some of the faint pink, you can see these centers, they have partially functioning or somehow just slowed down telemedicine services. And from this, we can appreciate, we can think that most of the telemedicine service is still, we are advocating for the rural healthcare and distant healthcare services. And Dhital sir was afraid of, being handicapped, or kidnapped these healthcare delivery system, though we are advocating for the rural healthcare and distant healthcare by still maybe urban healthcare system. And I also afraid the same. I would like to go to now my work facility, Dhulikhel Hospital. Dulika Hospital has been pioneering in community healthcare services for last more than 25 years, and it has 17 outreach centers. They work like the health post facility, and one outreach community hospital is located in the Dulika. Previously, it was Gauri Sungal Hospital under Fake Nepal also. And now recently from 2021, they have established with the telemedicine service to at least 4 outreach centers in Kavarage, in Palchok, Solukhumbu, and Nuwakot. And they have just started to function. And then this program has been implemented in collaboration with the ANSEL, and it's a huge project actually. And the tentative plan is in near future, the telemedicine project will be implemented in all the 17 outreach centers and will be monitored, especially through the outreach community hospital that's located in Dulika. And this is one of the example of the outreach center and the new gadgets for telemedicine being installed and the telemedicine service is started. We started with the tele-psychiatry, tele-dermatology, and some of the tele-radiology services that's easier to start with and more informative and useful. Here, the Dulika Hospital, this is the Dulika Hospital, this outreach hospital located in Dulika. So it's supposed to be the future plan is this will be going to be the hub for all the outreach centers, for all the 17 outreach centers. And these outreach centers in this picture, you can see located in different parts of the Nepal. And the concept is in near future, hopefully this network of the telemedicine service can be integrated with the national or other health facilities as well, so that we can deliver a very integrated kind of healthcare service to other underserved population as well, not only the network of the Dulika Hospital. So some of the challenges and the possible way forward, many people have already talked about many things. The technical aspect, human resource constraints, financial constraints, and intersector coordination. These things many people they have already mentioned. But here I'd like to highlight, the immersive training part, which I have mentioned here. And Uday sir was also highlighting a few days back, the concern is digitalization of the healthcare workers and people, So we can digitalize banking system, we can digitalize, we can work, we can talk and chat and Viber, Facebook, WhatsApp, and so many things. And then why we can digitalize healthcare system? And we have bank in our hand, then how we cannot have the healthcare system in our hand? And now we are talking about so many other digitalization, then why not in healthcare system? So digitalization of healthcare workers and other people is really important. And I think Telemedicine Society of Nepal plans to implement to address this problem by providing some framework for the training of the medical healthcare workers and also some other people as far as possible. And that's really appreciable. That's concept, I think, from Telemedicine Society of Nepal. And some of the other aspect, human resource aspect has always been a concern. People, they don't tend to go out to community. And this sounds like telemedicine, staying away and then giving health services to the community, staying in Kathmandu or Pokhara or somewhere, and somebody not reaching out to community, then maybe that's not really the concept. Okay, I think healthcare people, workers can only facilitate. They cannot really do every job staying in Kathmandu somewhere using some gadgets or some network. Okay, so I think some of the very highly motivated people should be reaching out to the community, facilitate the work. Of course, it's going to be cost effective. It's going to be very effective. Efficiency will be high, but we will be need of highly motivated healthcare workers, and these are the real concerns and challenges, and I hope that will be addressed by concern of the many people. And for prospects in regard to the rural healthcare, many people also highlighted some of the many things related here, but here I'd like to highlight telemedicine has become now new normal. So the new normal in COVID era was mask, distancing, these kind of things. And now I say, many people also say, I think they agree with this new normal. This telemedicine is the new normal. This is what we are going to agree with. This is what we are going to embrace, healthcare delivery system. And also it means to forward triage for the patients who are triaged before they visit to the emergency department or even hospital. Some people, they are supposed to reach some neuro hospital, they reach out to somewhere general hospital. Some people, they are supposed to reach to some another facility, they don't know where it is. So I think pre-hospital triage is another prospect of the telemedicine that also applies to the rural healthcare also. And I think this is a doorway for a specific service to the remote rural setting. We have already been listening so many things, including the tele ICU, of course, robotic surgeries already there. And I think another big prospect, very high burden of population, they fall into these three categories: family medicine, primary care. Telepsychiatry is biggest. If we look through the DL or disability as life years, the mental health problems are the biggest burden in this world. So addressing this biggest gap and biggest problem, I think telemedicine is the one which is very much promising. And geriatric care, of course, old age population is growing. We all are growing. We have everybody growing up, and the geriatric care, the addressing geriatric care, because they are not really able to attend the hospitals. It's difficult, so many transportation constraints, so many financial constraints. But addressing geriatric care, I think that's another prospect. And people staying in the community, in the rural setting, I think this is another prospect for them. So another thing, teleradiology, of course, I have been practicing for years. I have been sending X-ray pictures and ultrasound, some of the clips, and then consulting and finally making diagnosis and writing the reports and doing some interventions, treatment, and sometimes even proper diagnosis, then finally refer to the Haiger Center for proper management. So it has already been in practice. It looks very promising, even including CT scan, MRI, reporting from the distant, sending films from Nepal to America or Canada or somewhere, and getting back the reports and then making interventions. It's really promising, and it appears promising for the rural healthcare as well. Teledermatology, of course, dermatology has been always, if you just look the lesions or skin problems, then you make the diagnosis and you can advise for the treatment. And skin problems are one of the very common disease problems prevailing in our society. Also, telecardiology, especially when we practice with the echocardiography, I also keep on doing while especially in the emergency department, to make the proper diagnosis, early interventions, and it looks very promising with the ECG also that can be digitalized. We have also those gadgets which digitalize and we can send history and forward method. Of course, telecritical care, people have been talking a lot about the ICU, tele-ICU, and so many things. Of course, this appears in Dharka also. We have been providing near to ICU care service, but we used to have mostly pediatric resident, and we used to talk with the senior consultants and other people whenever required, but through, of course, using our gadgets or even WhatsApp or Viber also. That also looks very promising to provide the critical care service in the rural setting. So what I would like to say is telemedicine is the future, of course, and we need. This is the gateway. This is the thing we can strengthen the rural healthcare for everything to achieve the goals of the primary healthcare. Multi-sector coordination and support for everybody, including the agriculture, food and safety, and government, non-government, so many organizations. This is very paramount, very important. And I think while from our experience working especially in the MACD and also now in Dolikhel around also, the platforms which are talking about for the rural healthcare, but they need to be very user-friendly. We want the platform which are like WhatsApp. We want the platform like the Viber or Facebook Messenger, so that everybody, every community, at least every household, if somebody, every person cannot, but every household can reach out to for the healthcare delivery system, and that then only we can reach out to the community for the proper rural healthcare services. And finally, I would like to say the telemedicine is growing up, and again, I wonder, or I'm afraid of the business and the money, if it comes into play again, and every healthcare system, every gadget, every person, every training will be centered in the Kathmandu or some kind of urban hospital setting only. And again, it's going to be another foul play. So I would like to request everybody to make some step forward to address the rural healthcare, the gap, and make the future of the underserved, underreached populations. Thank you.
Now our next speaker is Dr. Shailendra Kumar Dual Sester. He is from Armed Police Force Hospital. The topic he will be talking about telehealth, our early experience in uniform hospital. Dr. Shailendra is a consultant orthopedic surgeon in Nepal Armed Police Force Hospital for the last 19 years. And he had opportunity to work in medical division during the COVID crisis period management center. And he also actually participating in different disaster response also. Welcome, Dr. Shailendra.
Thank you, Chair, sir, for giving this opportunity. I would also like to thank Dr. Uday for inviting me to talk on our experience. To telehealth, our early experience. Being a member of a uniformed hospital, we share a different kind of service scenario. And telehealth was a new thing for us. In the back, Nepal being a beautiful country, we are always prone to the natural disaster. Apart from the disaster, COVID-19 was a new lesson that taught us that the simple medical care can be a difficult task. And as a member of APF, when we were dedicated for a COVID service, our normal troops, they were deprived of a regular routine care as well as COVID. So the patient from the different part of the country used to contact us through Viber, WhatsApp, and other social media for the regular routine health problems as well as for the COVID problem. So group of our medical professionals, IT professionals gathered together and thought of something which could help in future also. So we came up with the idea of formulating a telehealth system. We named it Swastha, Specialized Wellbeing Assistance System, Telehealth of APF. I would also like to acknowledge Dr. Arun Neupani sir for giving us this beautiful name. And what is this system? It's a web-based simple application. It works on the all types of devices with minimum configuration, and a live video conferencing is also integrated in this application. And we usually use the specialist doctors who are in the referral hospital in our primary hospital can directly commence one-to-one video consultation with patient. For now, it only works inside our APF network where the intranet is connected. And we are planning to extend this service even in remote areas of Nepal and have a mobile-based application. So right now, there are 57 places where the intranet is connected, and we are in early phase of our telehealth. Like we are still crawling. So we have planned to phase it out in 5 different phases, and we are in phase 1 right now. So our system and hardware requirements are intranet connectivity, laptop or mobile devices, web camera, speaker and headphone, a simple web browser, Google Chrome or Mozilla, and a TrueConf software for the video conferencing. So our telehealth system we have developed into the emergency module and the OPD consultation module. Right now, we don't use internet. We are using only intranet due to the data security issues and other issues. We are not using the emergency module, and we have been using only the OPD consultation module. In the OPD consultation module, we have 3 sub-modules: admin module, doctor module, and a patient module. In the admin module, the IT professionals, they create an account for a doctor as well as patient, and they schedule the doctor according to the availability in the hospital. And they help patient to book the appointment, and they can see everything on the master chart. On the doctor module, after the account is given by the IT professionals, I can look into the booked appointments as well as view the medical history entered by the patient or the paramedics and start a consultation with the patient and then upload the diagnosis and a prescription. In the patient module, right now, our paramedics, they entered the patient login with their ID cards, ID numbers, and they see the available doctors on the duty, book appointment, enter the medical history, they upload the medical reports, and on the slot given for them, they start a live video consultation with the doctor. And after the consultation with doctor, we give the patient receives a prescription, digital prescription which can be printed. So this is our main screenshot where the user can log in with their name and password. And this is the admin schedules doctor according to the availability in the hospital. And this is a doctor schedule list. And a patient can book an appointment according to the availability of the doctor, and schedule is slot is given for the patient. And the paramedics can help the patient to enter the common symptoms and other chronic health conditions of the patient. And the report that the patient has, it can be uploaded in that system as well. And when after his booking is confirmed, it comes like this. And when the doctor sees, he can see the medical record of the patient if it has been entered. And then after that, we can start a consultation using the TrueCon device software. And this is the final prescription that the patient receives after the teleconsultation. So what are the challenges? We are still in the early phase, and the implementation of the emergency module has been a big challenge for us, as we have only, being a security force hospital, we are only using the intranet connectivity. So we are not using the internet service for our application. So our plan was, when our troops goes out for the emergency response, this application can be used on those scenarios also. But due to the data security and other reasons, we are holding our emergency module. And as all other participants has also said that there is a technical glitch in our country due to the connectivity problem and everything. And the challenge I find in our hospital setup is the effective communication between, it is not only run by the healthcare workers, the IT professionals and the patient. There should be a effective communication as well as concern. And patient sometimes hesitate to tell all his problems because there is a privacy concerns. And as well as telemedicine is useful when there's less healthcare worker. But in this our real scenario, we have only 32 specialist consultant doctors working in a referral hospital. So some are deployed somewhere else, some are deployed, and there's always lack of healthcare worker. And the medicine supply, this is a unique problem to us, as the patient when visit to our center, if we write medicine, they get free medicine. But when that patient from the outreach area consult with us in telecom consultation is done, if he receives a prescription, he has to buy medicine, and that medicine, his money is spent on that medicine. And in our setup, we don't have a dedicated fund for the telemedicine. All our application and everything was built by our in-house IT experts. And we don't have any formal kind of training in telemedicine as well. And we don't have IT equipments and other high medical gadgets, but still we have started our telemedicine with what we have. So coming to the end, what we think is there should be a comprehensive telemedicine policy. When we started our telemedicine service, the guidelines from the NMC was just document that was available for us. So we followed that guideline and could formulate what we knew. But there should be a comprehensive national policy or a policy from some authority telling that these are the procedures to be done in telemedicine. The privacy concern of the patient should be addressed. The data security, the technology requirement for all this stuff should be addressed. And apart from that, the financial support or a budget allocated for a government hospital like us to run a telemedicine, there should be a budget allocated for these kind of services. And we also think that we should increase awareness not only to the healthcare worker, also to the patient on using this kind of virtual healthcare services. And hospital personals, not only the clinicians, the support staff, IT personals, all should be trained about the use of this kind of platforms. And to us, the wider reach of adequate bandwidth intranet service across the country might help us to spread our telecommunication round across the country. Thank you very much. And this is the picture of the recent Sari Facility Center that was inaugurated in our center. It was handed over by MOSP to us in this week. Thank you very much.
Thank you so much. Now, I would like to introduce Dr. Ramesh Kandel, titled Geriatric Telemedicine, a New Dimension of Care for Older People. He also served as a consultant in WHO Southeast Asia Regional Office. Before he joined as a consultant in healthy aging at WHO, Shero, he founded the first department of geriatric medicine in Patan Academy of Health Science, Lalitpur, and worked as assistant professor of geriatric medicine there for 5 years. He's also involved in various communities working for geriatric health and social service under Ministry of Health and Population, as well as Ministry of Women, Children, and Senior Citizen in Nepal. Dr. Ramesh is also a technical advisor to various NGOs working in the field of aging in Nepal. Dr. Ramesh Kandel, the first registered geriatrician of Nepal, serves as a medical director as well as associate professor and head in the Department of Medicine and Geriatrics at Rapti Academy.
Namaskar and a very good afternoon to all of you. It's my privilege to be a speaker in this prestigious forum. At first, I would like to thank the Telemedicine Society of Nepal for this opportunity and especially Dr. Uday. So to start, I'm going to start my presentation. I hope my slides are visible. Okay. Today I'll be talking about a newer dimension of care for older people. That's geriatric telemedicine service. It would be a new concept for a few of us who are around here. So at the outset, I would like to express there is no conflict of interest with this presentation. Talking about the benefits of virtual visits for older patients and their caregivers, there are so many benefits. One of the benefits would be like fewer trips outside of the home. As we know, in Nepal, now we are getting into nuclear family. The older joint family system has been disintegrating, and that has been equally applied to urban as well as in the rural sector, where the older people, the older clients are alone in their home, just supported by their spouses. So there's very difficulty in negotiating through the health system. There is a problem with transportation, going out of the house. And there is also another advantage of telehealth, that would be less exposure to infectious diseases like COVID-19 and others. Now we have an epidemic of influenza going in various parts of our country. So the telemedicine or telehealth would be another opportunity to grow in such scenarios. Similarly, there is a problem of getting appointments in tertiary care centers. So if telemedicine is widely implemented, there is better chances of being solved sooner, and there are no additional costs involving transportation. And when you go to tertiary centers, there are issues of livings in hotel or somewhere else. So there will be no additional cost involved. So there are so many benefits which are with regards to telemedicine or telehealth services, especially when we talk about older patients. So what would be the scope of telemedicine service for older people? There are various dimensions of health which can be addressed by telehealth services. One would be like health promotion and disease prevention. Like one of the measures would be health counseling, which is quite of paramount importance to the life of older people. We can talk about exercise modalities. We can talk about vaccination. We can encourage our clients for getting vaccinated. We can advise for nutritional issues like what to take and what not. We can engage the dietitians. So many things can happen with the aid of telemedicine services. Similarly, we can help in curative services, especially in terms of counseling. That can be of paramount importance. Similarly, another dimension of care, which is also a part of long-term care for older people, that's the rehabilitative services. So we can offer physical therapy as well as occupational therapy by means of telemedicine and telehealth services. So there is a wide scope of telemedicine with regards to older people. So, what could be certain prerequisites for treating older people through telemedicine or telehealth services? Like understanding whether our clients are digitally literate or not, whether they have a basic understanding of how these devices work, that is of paramount importance. Similarly, considering non-health, non-video telehealth options like using phone calls or using emails in case of educated older people, that can be another option. And giving extra time during the first telehealth appointments with older clients is of paramount importance. So because the older people, when they talk to you, you have to give so much of time to figure out what's the actual problem in those patients. It might not be so easy like serving a 30 or 40-year-old gentleman or female with health issues. Addressing older people with health issues is a very challenging aspect, and it's indeed an art. So during the first telehealth appointments, it's very important to give them ample opportunities to express themselves out their illnesses. And similarly, there can be use of remote monitoring devices such as blood pressure monitors, heart rate monitors, glucose monitors, and compiling vital information from these patients. So there are certain requisitions like preparation when we talk about telehealth or telemedicine appointments with older clients. That can happen both in the home as well as the institutional settings. Like we need to assign a staff member from our telehealth group for walking them through their home setup, because when we talk about geriatric medicine, we have to talk, it's very important to talk about the home environment in which those older people are residing, because that has a profound impact on their health. Similarly, reviewing technology basics through the employed staff member is also important. You can also think of audio-only or phone-based telehealth appointments, especially for semi-literate or illiterate clients. Similarly, getting additional help from caregiver or family member is very important when we talk about older clients, because they might have sensory impairments in terms of hearing deficits with regards to vision deficits. So the engagement of caregiver or family member during teleconsultation is very important if we wish to get exact data or exact information from our patients. Similarly, when we counsel the patients, if the patients have cognitive impairment or sensory impairments, then it's very essential to have bystander. So with regards to telehealth, telecommunication, teleconsultation, or telemedicine in Nepal, there are so many challenges. Like digital literacy among older adults is a very important issue that we have to ponder on. Like various studies have shown that worldwide only 40% of older people have access to digital communication strategies. So I think if we talk about Nepal, much of the older people, especially who are in their 80s or 90s, might not have even seen mobile devices. Getting into like desktops or laptop is a very distant thing for them. So we have to be very careful about whether our clients have digital literacy or not. Similarly, availability of telecommunication technology, like if we get out of Kathmandu, we can say if we get out of Nagdunga, it's very difficult to get access of NTC, which is a prime telecommunication network in our country. So these all are usually urban centers. So what about the rural clients, people living in the rural areas of Nepal, whether the telecommunication or technologies are available or not? That's another major concern. Similarly, affordability is other major concern. Like the data cost in Nepal is one of the most expensive in Southeast Asia, in almost we can say in Asia. So whether this comes under the affordability of those older clients or not, who have poor economic base. So that's another major concern. Similarly, lack of geriatric friendly communication tools. Now we find it very comfortable to use smartphones with touch technologies, but whether these are really friendly to our geriatric clients or not, that's another aspect we have to think about. Similarly, there are policy-related constraints which have acted as major barrier for implementation of telemedicine services for older adults in Nepal. So there have been various studies. We have assessed the satisfaction with telemedicine during the COVID-19 pandemic. We have, after COVID-19 pandemic, telemedicine has come into a limelight. So this was a publication in the Journal of Telemedicine and E-Health. It was published in 2023 January. So they have assessed various factors which have influenced patient satisfaction with telemedicine, and there are system-related factors, patient-related factors, socioeconomic factors, and nature of medical intervention. So we have to think, because this is quite challenging in the context of Nepal, where there is a lot of topographical variation, literacy variation, and so many issues. So we have to think in a holistic manner when we talk about telemedicine, especially with regards to older adults in Nepal. So what is missing from telehealth visits? Most importantly, the ease of use. Like technology may not work like what it is supposed to work, especially with regards to older people. That may one of the major issue with regards to telemedicine. The time issue, telemedicine feel rushed. Like Dr. Uday has allotted me 10 minutes for this presentation, but I'm always like in apprehensive whether I can finish this presentation within that span of time or not. So older people, we have sensory impairments, hearing impairments, visual impairments, poor health literacy, poor digital literacy, whether they will benefit from telemedicine or not. That's one of the major issues we have to think upon. Similarly, rapport. Telemedicine, telehealth may not have that emotional component of care, which is always present when we are sitting by our patient side to side, the touch, the eye contacts, and so many things, the communication related things, which are of paramount importance when we talk about geriatric care. And will that really be possible through telemedicine or not, telehealth or not? Like it is said that telehealth is not as intimate as it is like in-person appointments. So these are the things which might have, which might affect the efficacy of the effectiveness of telemedicine services. So when we talk about telemedicine service with regards to older adults, we have to think of these components of intervention as well. So while sharing about what is happening with telemedicine at Rapti Academy of Health Sciences, to introduce Rapti Academy of Health Sciences, it is one of the youngest academy, health academy under the federal government of Nepal. It is situated in Dang district. As we know, as you might know, Dang district is one of the semi-rural, or we can say semi-urban district situated in Lumini province. So here we are, as a medical director, I feel privileged to share this information with you. We are in the process of starting telephysiotherapy. We have been collaborating with Handicap International. The devices are already in place, and we'll be implementing this service in a very near future. Like the physiotherapist at our center will be coordinating with the health assistants, and we can say aged the health workers in the satellite peripheral hospitals. Like we serve the patients from Rukum, Rolpas, Fallan, Putan, and Dang. So there will be installation of telephysiotherapy mini centers at this at the surrounding districts, and there will be a referral telephysiotherapy center at Rapti Academy of Health Sciences. The physiotherapist here will be in connection with the health workers in the peripheral telemedicine centers, and they will be instituting telephysiotherapy. So we are very thankful to Handicap International. We have been very pivotal in installing these services. So we from the very new year that starts from Baisak 1, so we'll be going into full-fledged manner. We'll be studying telephysiotherapy services, and we are hopeful that especially the bed-bound patients or patients who might be requiring intensive physiotherapy and occupational therapy in the neighboring districts, who might have a lot of logistic issues to visit Rapti Academy of Health Sciences from these neighboring hills, might find it quite beneficial for the improvement of their holistic health. So talking about way forward with regards to telehealth or telemedicine with regards to older adults, we have to be more thoughtful about the digital literacy for older adults. We have to think of manners by which we can improve digital literacy in these older adults. So we can give good access. The older clients will really be benefited from this. It's important in other way also, because now when we are talking about nuclear family system in Nepal, where the offsprings are quite at a distance from their parents, for other reasons, for like decreasing the intergenerational gap, and for intergenerational solidarity also, improving digital literacy among older adults is of very importance. Similarly, availability of digital technology at an affordable price and in various geographic locations would be of another aspect we have to be thinking about when we talk about telemedicine or telehealth with regards to older adults. With this, I would like to end my presentation. I am very thankful to Telemedicine Society of Nepal, Dr. Uday, and you great listeners for your time and attention. Thank you so much.
Thank you for all the speakers. Now the floor is open for the questions and comment. Please. Yes, please.
My question is for Dr. Rajkumar, Dr. Sailendra, and Dr. Ramesh, all three speaking doctors. As a doctor, are you confident enough with the given guidelines by Nepal Medical Council? Are you confident enough in delivering the care through telemedicine modality or not, particularly because of the signature and documentation issue? And yes, the question goes to NME General Secretary as well.
Thank you, Subhas, for the question. In our prescription, we have given a digital signature of ours. So what we think is it's permitted by the NMC guideline, but the only NMC guideline, it cannot be the judge everything for the telemedicine. So that's why we said there should be a comprehensive telemedicine policy incorporating the IT departments, MOHP, and other sectors, stakeholders. This should be a complete package. Telemedicine is not only for the medical doctors. So what I think is that NMC guidelines will somehow give us a guideline, but overall, there should be an umbrella. Yeah, thank you.
Promise.
Thank you, Subhas, for this question. Yep. So especially with regards to older clients, so what we have been practicing, like client is personally present in our hospital setting or outpatient settings, is a more effective way of communication, because there are so many communication barriers when you talk about older people, especially when you talk about curative services, but especially for like when we talk about rehabilitative services, when you talk about promotive health, preventive health, and counseling, which is of paramount importance, identifying the danger signs promptly. I think this telemedicine would be of great importance. But always when we talk about geriatric patients, we have to be very much concerned about their cognitive level, their digital literacy, their sensory, the issues related to sensory impairments and so many things. So it might not be effective way when we talk about curative health services, but for the other dimensions of health, other telemedicine would be quite beneficial when we talk about older people, older clients. Thank you.
Thank you, Dr. Shubhas, for a very good question. Like, you know, actually, like for me, since Dr. Raju said so much about telemedicine, and this from this morning, we have been discussing about telemedicine, and now we know how much benefit it has been giving to our general population. So rules should be, amended. And I think there is a saying in Nepal, because of our geography, everything, I think this telemedicine is most in current situation. So NMC is here for us and for people also. So I think we should really encourage NMC to amend this thing in their, rules and regulation things. Thank you so much.
Dr.
म डाक्टर अरुण नेउपाने टेलिमेडिसिनमा केही इन्ट्रेस्ट र केही अलिकति नलेज भएर आएको मात्रै सिक्नलाई। मेरो 2-3टा कुराहरू छ, इट्स ओपन, एनीबडी क्यान आन्सर। एउटा चाहिँ म आई थिङ्क टेलिमेडिसिन सोसाइटी अथवा टेलिमेडिसिनमा काम गर्नेहरूको लागि, सबैको लागि एउटा पेसेन्ट कन्फिडेन्सियालिटी र प्राइभेसीको बारेमा यसमा कहीँ पनि अब कसरी त्यो चाहिँ मेन्टेन भएको छ भन्ने, इफ समवन कुड टेल मी। अब त्यस्तै गरी त्यसबाट आएको डेटा र कुन सर्भरमा जान्छ, कुन देशमा गएर बस्छ र डाटाहरू चाहिँ कसरी बाहिर गइरहेको हुन्छ, हामी कहाँ चाहिँ हु इज द वाच डग यो टेलिमेडिसिनको सबै चिजमा, यसमा हु इज द वाच डग, मेरो क्वेसन एउटा। दोस्रो क्वेसन इज सबै चिज आयो, युज अफ ग्याजेट चाहिँ एउटामा मात्रै आएको थियो, ग्याजेट्स र इक्विपमेन्ट, स्टेथोस्कोप, थर्मोमिटर्स, सेन्सर्स, इसिजिज भन्ने एउटा प्रेजेन्टेसनमा त आयो हैन, धुलीखेलकोमा है। यो डायग्नोसिस र ट्रिटमेन्टको लागि यसको युजको बारेमा चाहिँ हामीले त्यति सुन्न पाएनौँ आज, यसको इम्पोर्टेन्स छ कि छैन। र लास्टमा चाहिँ टेलिमेडिसिन भनेर हामीले भन्दाखेरि यहाँनिर धेरै मिक्स भनौँ कि मिसम्याच त नहुनु, मिक्स्ड भयो यो एचएमआइएस, यो रेफरल सिस्टम, डिजिटल हेल्थ, टेलिमेडिसिन होइन, यो कतैवटा के गरेर चाहिँ मिलेर अब यसलाई हामी सबैलाई टेलिमेडिसिन भने हो कि, यो मैले चाहिँ अलिकति ज्ञानको लागि सोधेँ है, मैले कसैलाई चेक गरेँ होइन, कि यो कसैले डायग्नोसिस कोही पेसेन्टले नै गर्ने, आइडियली अब खोइ अलिअलि हामी अलिकति कन्जर्भेटिभ सोच गर्दाखेरि चाहिँ हेल्थ टु हेल्थ पर्सनल भएपछि मात्रै पेसेन्ट आउने भन्ने मलाई फिलिङ थियो। पहिले हेल्थ पर्सनलाई रेफर गरेर त्यसको इन्फर्मेसनहरू सबै आइसकेपछि अनि इफ रिक्वायर्ड पेसेन्टसँग इन्टरेक्सन गर्ने हो। अब हामीले सिधै पेसेन्टसँग गर्दाखेरि आई डोन्ट नो, अब इट बिकम्स मोर एन्ड मोर कम्प्लिकेटेड। सो 3टा चिज, कन्फिडेन्सियालिटीको, यो डेटाको बारेमा, अनि यो ग्याजेट इक्विपमेन्टको, र अनि लास्टमा चाहिँ यो सिधै पेसेन्टसँग गरिहाल्ने हो कि एक लेभलमा प्यारामेडिक अथवा हेल्थ पर्सनसँग गरेपछि मात्रै पेसेन्टसँग गर्ने हो। यति क्लियर भयो हुन्थ्यो। एनीबडी, ओपन फ्लोर। थ्याङ्क यू।
डाक्टर अरुणले एकदमै रिलेभेन्ट प्रश्न राख्नु भएको छ है। मलाई लाग्छ कुनै पनि ठाउँमा हामीले टेलिमेडिसिनको नाउँमा अथवा इ हेल्थको नाउँमा जेसुकै नाममा पनि यो प्र्याक्टिस गरिराखेका छौँ भनेर भनेदेखि प्रविधिको उपयोग गरेर डाक्टरकै छेउमा नभएको, कतै टाढा भएको कुनै व्यक्तिलाई अथवा कुनै कम्युनिटीलाई प्रविधिको माध्यमबाट उनीहरूको स्वास्थ्यका समस्याहरू समाधान गर्न हेल्प गरिरहेछौँ भनेदेखि मलाई लाग्छ त्यसलाई टेलिमेडिसिन भने हुन्छ। इ हेल्थकै एउटा पार्ट होला त्यो। अब अरू जति पनि प्रश्न गर्नुभयो त्यो हामीहरूले प्र्याक्टिस गर्दाखेरि, टेलिमेडिसिन नै भनौँ अहिलेलाई, अथवा इ हेल्थको प्र्याक्टिस गरिराख्दाखेरि हामी यतिखेर कुन अवस्थामा छौँ, विकासको कुन चरणमा छौँ भन्ने कुरामा चाहिँ भर पर्ने हुन्छ। कुनै कुनै बेलामा अघि बिहान पनि मैले भनेको थिएँ, जब यो चाहिँ नि कर्मकाण्डले जब धर्मलाई हाइज्याक गर्छ नि, when the rituals start hijacking dharma, त्यसपछि प्रब्लम हुन्छ। र त्यो भएको कारणले गर्दाखेरि मलाई लाग्छ यो कुरा अघि मेडिकल काउन्सिलको कुरा आयो, मेडिकल काउन्सिलले कर्मकाण्ड बुझ्छ, धर्म बुझ्दैन, आवश्यकता बुझ्दैन, त्यो उसलाई गाह्रो पनि हुन्छ हैन। सजिलोको लागि हो नि त। We create formulas, we create rules and regulations, we try to generalize. That's because, for our own comfort, to make things easy for ourselves, not to fulfill the needs of the people. र त्यसले गर्दाखेरि होला। And sometimes, therefore, sometimes maybe if we are going to save life, sometimes we need to take the risk. If we really want to practice love and compassion, we are always afraid what medical council is going to do. I may be behind the bar, then the best thing we can do is just to run away. Leave the patient in there, lying there in the pool of the blood. Sometimes we need to take the risk. At the same time, I am very much aware that we, the doctors, now I'm not practicing at all, whether I qualify to call myself a doctor now, but many Nepali doctors, they have been mishandled by the patients or the patient parties. That's another issue. That is totally another issue. That's because of the stupidity, foolishness of the government, because they are incapable. We have been choosing useless governments for decades. That's totally another issue. The security, we cannot guarantee our security by fighting the patients or patient parties. But if we really want to practice love and compassion, we have to take some risks. Unfortunately, in many countries, including ours, where the government is useless, the doctors have to take larger risks, greater risks. That's very unfortunate. That's my understanding. Thank you.
Thank you, Dr. Dr. साहबले उठाएको तीनवटा क्वेशन्समा एउटा क्वेशन्स चाहिँ मेरो आफ्नै सेक्सन पनि भएको हुनाले मैले डेटा सेक्युरिटीको कुरामा हाम्रो पब्लिक हेल्थ एक्ट भर्खरै ले अब क्लियरली डिओआइटी ले र त्यसपछिबाट आएर आइएचएमएस ले जुन मिनिस्ट्री अफ हेल्थ एन्ड पपुलेसन ले जुन पब्लिक हेल्थ एक्टमा जसरी तपाईहरु हामीले पेपरमा डेटा सेक्युरिटी गर्छौं त्यही हिसाबले सिस्टम अल्टिमेटली डिजिटल हेल्थ भने पनि पेपर बेस्ड हेल्थ भने पनि माध्यम मात्रै फरक हो, कानुन त एउटै हो। त्यसकारणले त्यो कानुनलाई ड्यू रेस्पेक्ट दिएर जाँदाखेरि तपाईले चाहे क्लाउडमा राख्नुस् चाहे तपाई आफ्नो होस्टमा राख्नुस्, सर्टेन त्यसको सिस्टमको नर्म्सलाई तपाईले फलो गर्नुभयो भने प्राइभेसी स्ट्यान्डर्ड त डेभलपरले फलो गर्नै पर्यो। त्यो डिचेस राख्यो भनेदेखि त त्यो कानुन एट्र्याक्सन भइहाल्छ त्यहाँनिर। हामी अहिलेकै नर्मल कानुनले पनि त्यसलाई काम गर्छ, त्यही पनि जानु पर्दैन पहिलो कुरा। दोस्रो कुरा के हो भने टेक्नोलोजीको हिसाबमा हामीले जुन अहिले प्र्याक्टिस गरिरहेछौँ डाइरेक्ट पहिले पनि 10 वर्ष अगाडि डाक्टर सरोज नेपाल र हामीसँगै नेपालमा काम गर्दा एउटा क्वेशन्स एकदमै हामीले सँगै डिबेट भइरहेको थियो। डाइरेक्ट पेसेन्टलाई काठमाडौँको डाक्टरले डाइरेक्ट पेसेन्टलाई डिल गर्दाखेरि त्यो रुरल एरियामा काम गर्ने डाक्टरको भ्यालु के हुन्छ? एकदम सिरियस, यो चाहिँ सिरियस क्वेशन हो। टेलिमेडिसिन प्र्याक्टिस गर्ने नाममा कतै रुरल हेल्थ वर्करलाई युजलेस त बनाउँदैनौँ हामीले, सिरियस क्वेशन छ र यो सिरियस क्वेशनलाई हामीले पब्लिक हेल्थ एक्टमा यसपालि एड्रेस गरेका छौँ। सकेसम्म हेल्थ वर्कर डाइरेक्ट जो पेसेन्ट जो डक्टरसँग एट्याच छ त्योसँग पहिलो ओनरसिप उसैसँग हुन्छ,
उसकै रेस्पोन्सिबिलिटी हुन्छ यदि उनलाई ट्रिटमेन्ट गराउने हो भने तपाईले इम्पावर गर्नु पर्यो डक्टर टु डक्टर एउटा हाम्रो उनले पनि भनेको छ त्यस कारणले गर्दाखेरि थोरै हाम्रो डेफिनेसनहरूलाई सच्याउनु पर्ला त्यो थोरै उसमा काम गर्नु पर्ला होइन भने मलाई जहाँसम्म लाग्छ मान्छे मर्न रेडी छ भनेदेखि हामीले यहाँ जुनसुकै नर्थ कोरियाको डक्टरसँग एक्सेस लिएर भए पनि बचाउनु पर्यो हामीलाई त कुनै रेस्ट्रिक्सन जोग्राफिकल रेस्ट्रिक्सन कुनै रिजनल कुनै पोलिटिकल कुनै पनि कुरा ल्याएर किन भन्दाखेरि मान्छेको लाइफ धेरै त्योभन्दा धेरै माथि छ त्यस कारणले गर्दाखेरि टेक्नोलोजीको अवसर हामीले युज गर्नुपर्छ जुनसुकै अवसरमा युज गर्नुपर्छ डेटा सेक्युरिटीकोमा डेटा क्लियर रूपमा कानुनमा कहीँ पनि मैले ग्लिचेस देखाएको छैन किन भन्दाखेरि तपाईँले हामीले दिएको कानुन अनुसार भोलि सरकारले तैँले किन यसो गरिस् भनेर कसैले सोध्यो भने एन्सर दिन सक्नु पर्यो त्यति हो अरू केही पनि छैन मैले यति नै भने हस् थ्याङ्क यू
Thank you for excellent answer. I think now, Doctor.
Thank you. अरुण डाक्टर साहबले उठाउनु भएको कुरा एकदम जायज जस्तो लागेको छ जायज हो र सरोज डाक्टर साहब र उहाँले भन्नुभयो धेरै कुरो त क्लियर गर्नुभयो र हामी टेलिहेल्थसँग टेलिमेडिसिन अलिकति कन्फ्युज कहिले पनि यहाँ चाहिँ हामी टेलीको कुरा गरे पनि टेलिमेडिसिनको कुरामा टेलिहेल्थ वेल्थ पनि आउँछ टेलिहेल्थ भनेपछि त
एउटा रिक्वेस्ट आएको छ if we speak in English it will be convenient for others also.
Okay, thank you. Just now a few questions were raised regarding the how ethical it would be to treat patients directly through telemedicine, talking directly to the patient and prescribing medicines to patients directly. So far, it might be in practice somewhere. But as far as I know, from the government point of view, because I was kind of working with the government also, just recently, even now I'm working with the government. I'm trying to develop telemedicine software for the patients, to how to take care of them. And especially at this time, we have designed telemedicine through district hospital. A specialist from the hub hospital would talk or communicate with the doctor from district hospital, not directly to the patient. But if we want to see the patient, then it would be seen through the local doctor. That was a big issue. We do not want directly to talk to patient and treat. That was a big issue because from the government point of view, they have to do it. Before they do, they have to be really careful. So that was very well thought, Dr. Arun raised that question. So we have already seen, and in the market, we see so many equipments. You just put somewhere, it will give glucose. We just wrap around this, it will give blood pressure. How authentic, how nice it would be, how useful it would actually be, that we don't know. But so far, patients should be treated through medical practitioner. That would be the best practice, So I think that's the way it should be done. Thank you.
Please.
Sorry, there is so much time constraint, but I just want to speak a small thing about that. I connected telemedicine, digital health, and ML. So I would just like to add one point. Like I'm also naive in digital health and telemedicine, actually. But I think e-health, like telemedicine, comes under electronic health, and then what we have been doing from the Little Hospital is we develop clinical electronic decision support system for the frontline health worker. And that is developed with evidence, with the reference from the national protocol. So just like we get everything, algorithm, guidelines, everything we develop, whatever that is being developed in the mobile phones is reference from the national protocol. So why not develop the algorithms and this type of clinical decision support system that will be in the hand of the frontline health worker in the rural settings, just like auxiliary nurse midwives, health workers, and auxiliary health workers, so that they can directly connect to the great doctors in maybe urban areas and get consultation and like revised trainings with the proper guidelines that will be in the hand of the people in the rural settings in rural settings, so that they can rely on that guideline and give the treatment as per national protocol. So that's the only thing I wanted to add. I think this is the part that have to be brainstormed not only from the stakeholders, from the national government and worldwide also, because we believe in evidence-based medicine. Thank you.
Okay, thank you. Very important interactions. Finally, we'd like to thank all the speakers and interacting participants, and we chairpersons also would like to thank Dr. Uday and Telemedicine Society for giving us this opportunity. Thank you.
Thank you, Vishnu sir and Dr. Sanjeev. So with this, we come to the end of the session 3. Now we move to session 4. We have a felicitation program. I'd like to hand over the mic to Dr. Uday.
Thank you. आज यो एकदमै हाम्रो चाहिँ टेलिमेडिसिनको लागि उत्सव नै जस्तो लागिरहेछ। सबैजना मेरो सिनियर गुरुहरू सबैजना चाहिँ यहाँ उपस्थित हुनुहुन्छ। मलाई एकछिन अलिकति 2 शब्द चाहिँ नेपालीमै बोल्न मलाई यो खुसीको क्षण भएर साह्रै नै खुसी लागेको छ। So I'm really very happy that all the seniors are here. It's great honor to form Telemedicine Society. It was a hard time. Members must have so hard time to establish telemedicine, to talk about telemedicine, and to say that it's the future. It's the future of the medicine. And how difficult it would have been to convince the people. Similarly, I can see Muniraj sir here. So all the ages he has worked in science and technology, in health. He has a museum, Science and Technology Museum in Kalikastan, and he has been working so hard to establish digital, and he's so happy. It's passion for him to develop digital health in Nepal. And similarly, my guru, Saroj Hital sir, he has been working. It's because of him. It's because of his inspiration that now I'm also in the field of telemedicine, in the field of digital health. Similarly, we have Narendra sir online. Narendra Bhatta, he has been working hard in Bhutan, BBK-ATS, to establish telemedicine services in eastern part of the community. Similarly, Dr. Vishnu Datta Paurel is here. He has established telemedicine services in Veer Hospital. And he's always so happy whenever I call him. So there is some program of telemedicine. He's always ready, always ready. So thank you, sir. And I can say Arun sir, actually he knows everything. He was asking as if he doesn't know, he knows everything. And so, and because he had worked so hard in CCMC, we all know that. And similarly, I can see Rajendra sir, he was working all the way to the to Magdi, Nagi with Mahavir sir in Wireless Nepal to establish those wireless connections in the trees, the pillars, in the roof of the houses. Now they are like stories, but they are realities. They are realities. And we have to realize that it was not an easy task to establish, to go on. And maybe our younger generations won't realize how difficult it was, but still we can feel that pain. So that is why we have planned to have this felicitation program today. So thank you, sir. Thank you, all of you. And we have other members also, like Dr. Bhushan Raj Shrestha, who is in Nepal Research Education Network. He is busy down in Apan conference. Similarly, Mr. Lochon Lal Amatya, sir. They all, even in IT, they are not in health, but they have known better health than us. So that is the thing that they are always pushing, and they are always very happy. So I'm very glad to have my gurus like this. I call them VIP, very important person, but if you see other leaders, so they are like this, and our teachers are always like this. So thank you, sir. Thank you very much. Yes, and Dr. Pradeep Vaidya, sir, he has been working hard in TUTS. I don't see him. He was here in the morning. So all these are our great gurus. First we'll hear from Dr. Narendra, sir. He's online, and then we'll start the facilitation program. Dr. Narendra Bhatta, sir.
Yeah, thank you, Dr. Uday. Thank you very much. Firstly, let me congratulate you and the team of Nepal Telemedicine Society for conducting this nice, wonderful session. I wish I could have come and joined personally, but due to certain unavoidable circumstances and my own assignment, I couldn't come. I acknowledge the gratefulness that the solicitation program, and now I think it's a new era of telemedicine. It's a new thing. It's a future of the health in Nepal, and telemedicine. One has to serve the country, the people through the telemedicine and digital health, and its time has already come. Thank you very much. Thanks a lot.
Thank you. Thank you. Now I would like to request Dr. Tomohiko Moriyama. He is Director of Telemedicine Asia, Developing Center of Asia. And he has been helping us a lot to establish telemedicine, to develop telemedicine. And they have been pushing that, okay, this is the way to go. We must go together. And they are hand in hand. And they always say that we also should learn from Nepal. That is a great thing, that Japan also should learn something from Nepal. That is good thing. So we are learning a lot thing from them. So thank you, sir, for being here. So I'd like to request him to honor our Dr. Mingmar Sherpa. We'll give the certificate. Open this. Open it. Certificate. Thank you. म एकचोटि यो पढेर सुनाउन चाहन्छु। नेपाल टेलिमेडिसिन सोसाइटी सम्मान पत्र। यहाँले नेपालमा टेलिमेडिसिनको विकासको लागि गर्नुभएको अथक मेहनत र प्रयासको उच्च सम्मान गर्दै नेपाल टेलिमेडिसिन सोसाइटी साथै नेपाल रिसर्च एन्ड एजुकेसन नेटवर्क तपाईँ डाक्टर मिङमार शेर्पाज्यूलाई यो सम्मान पत्र प्रदान गरिएको छ। धन्यवाद। अब मिङमार सरले नेक्स्ट उहाँलाई दिनुहुन्छ। हस् म डाक्टर विष्णु दत्त पौडेललाई बोलाउन चाहन्छु। डाक्टर विष्णु दत्त पौडेल उहाँको पनि परिचय चाहिँ होला। अहिले भक्तपुर क्यान्सर अस्पतालमा चाहिँ निर्देशक हुनुहुन्छ मेरो अस्पतालमा। Yeah. Thank you, sir. हजुर आउनुहोस् सरले चाहिँ नेक्स्ट सरले नेक्स्ट लाइन अब म डाक्टर सरोज धिताल सरलाई बोलाउन चाहन्छु। सरोज धिताल सरको पनि परिचय खासै चाहिँ हुनुलाई यो टेलिभिजन विकासको लागि उहाँले गर्नुभएको प्रयास। Yes, धन्यवाद. Muniraj Sakya, sir. Muniraj Sakya सरले पनि धेरै नै यो डिजिटल हेल्थमा उहाँ पनि आइटी छ र पहिलेदेखि डिजिटल हेल्थमा धेरै so yes, धन्यवाद. अब नरेन्द्र सरलाई हामीले अनलाइन नै सम्मान
Thank you very much, Dr. Uday. Thank you very much. I most humbly and appreciate them. Thank you very much.
सर त्यस्तै गरी महावीर सर चाहिँ मलाई त्यो सम्मान हो भने म भागिहाल्छु भनेर भन्नु है उहाँ अलिकति चाँडै निस्कनुभयो अलिकति व्यस्त हुनुहुँदो रहेछ. त्यस्तै गरी डाक्टर भूषण डाक्टर के अरे लोचन सरको एकछिनमा आउनुहुन्छ होला, त्यसपछि हामी गर्छौँ. अब चाहिँ हामी टी सेसन गर्छौँ. Then we'll start. After 15 minutes, we'll start the next session. Thank you.
Thank you. Thank you very much. Thank you.
I say a few words here. Maybe this will be. Well, here I see all the doctors, but I am not. I'm simply an engineer. This really encouraged me so much. I'm talking about 2008, 2009. That's when we, with a group of doctors, and myself, an engineer, we started this telemedicine service. Way out in Calicut. You must have heard of the story that then, around that time, 307 people died, one after another. You know how they died? Simply, Tharabakala. That's a dysentery, diarrhea. Just the diarrhea took 307 people's life. That hit me hard. That was a breaking news. That hit me hard. I just wished I was a doctor. I just wished I could go to that Calicut, that Jajarkot actually. That's where it happened. I wish so many, but I must do something to save the life. You can do many, many things in many different faculties, but saving a life of someone is the prime duty of anybody, anyone, anywhere in the world. I must do something. How do I do it now? I had just developed something. I had a green computer. Then, we had a blackouts. Blackouts 18 hours a day, 16 hours a day, no light, nothing. So all the computers were dead. Even Mahavir Pun, he asked, then that was the time I made a green computer. Green computer is the computer which only works on 35, 30 watts. So during that time, when there was no power, this computer has saved so many things. So my attention went to these people who are dying. This is the time I must do something. How do I start? I have no idea how do I start. Anyway, I got a bunch of doctors from teaching hospital. They just had their MBBS. I approached them, and a group of them came over to my place. I had a telemedicine kind of thing, but it was a computer. One is somewhere. I said, there's a sick person. There are, I think, 8 or 10 doctors. Dr. Self already, to save the life of someone who is somewhere. The picture you'll see just now. So I had a picture in the monitor. A girl was almost dying. Doctors, please try to save this girl's life. So how to do that? So they asked few questions to that girl. It came in the screen. So they asked few questions. What happened? What is the problem? Do you have fever? All this medical, terminology. So they gave some answers. They asked questions, and the girl gave answers. They were given some medicine. The girl's life was saved. Like that, in Calicut, people were just dying one after another. Small things happened. Some people just fall down from the tree, broke the hand. Something can happen any time. That's a place in Calicut. There were no health posts. There are no doctors around. Nobody. How to do in such a remote place? How do you do any business in the health sector? So these doctors. Doctor, you don't have to go to Calicut. You don't have to go to Jajalkot. You be here one day. See the system here? I showed you the girl's picture. This is how we do it. Okay? So from there we started in Calicut, all the people came along. And a surrounding area, people started coming one after another. Just because there was no service whatsoever health-wise. So that's how we did our job. We had a mobile set just starting to come. We only had 9K. That's a small bandwidth, but we could do the video conferencing with that, thing. So we started on and on and on. Every time people come, they lined up. The people heard from nearby areas, hey, there is some service. Telemedicine, they said, telemedicine. So they lined up. Some people came walking 3 days. They rested on the way, Dokumambogara, they carried on the back. 3 days they came and came to this Calicut station. We saved their lives. This is how I just wanted to share with you, all these happy moments in my life. I've done so many other things, but this one is the most important thing in my whole life. I have done something. Thank you. Thank you.
Uh, okay, thank you. After lunch and then a long session, then after tea, so everyone must have been feeling sleepy. So now we'll have a hot discussion on how we should go. Actually, Arun sir has already initiated the discussion, so we'll continue to have the hot discussion about the different aspects of telemedicine. And it's my pleasure to introduce Dr. Subhas Pakurel. He's Director of Health Concern Nepal and also Director of MediFlow. So he will be moderating the session. Thank you.
Thank you, Dr. Uday and Telemedicine Society of Nepal. In next 25 minutes, we'll make it very interesting. We'll generate some pinching and punching points to draft the resolution from this esteemed floor. And it's not that it will be rituals, because in 2019, that symposium also generated one resolution, and that was taken as a seed or nidus for generating that guidelines from Nepal Medical Council and from Curative Service Division as well. So the floor is open. We'll fully utilize our experience, energy, enthusiasm all to make this resolution. And we all are of equal weightage, with due respect to all the felicitated persons. Okay, first we'll start from the government commitment. Are we satisfied with the level of commitment from government, or there should be some push? So floor is open. Then the first point will be the government's commitment in that resolution. So floor is open. We go constructive, being some level of critical. Okay, Dr. Saros.
Actually, I'm not doing the right thing. I should not have the mic first, because I know very little about the government's commitment. But if we really want the government to do something, then we need to understand our own needs. From what we have heard today from different speakers is that we have a number of issues. Before starting to bark at the gate of the government, we should acknowledge that maybe our understanding of telemedicine probably is not very clear among ourselves. Therefore, I suggest that we need to have a working definition of telemedicine. If you like, you can say e-health and telemedicine in our own context. As Dr. Mingma has said, you know, के अरे देश अनुसारको के अनुसारको नियम भनेको त्यो अनुसार बनाउनु पर्छ. So what does e-health and telemedicine mean to us? It has got different dimensions. It can be a wonderful earning platform also, and it can also be a platform to, you know, a vehicle to reach the unreached population. What, you know, people who are gathered here, what do we need e-health and telemedicine for? You know, and after that, there are a few things which need to be, you know, clarified. One is that definitely government seems to be not very clear. When the regulations are made, what are the regulations for? Is it for the well-being of the people? Is it for saving lives? Or is it for, you know, just imposing something? There is a saying I forgot who said that, but that is one of my very favorite sayings, and I used to teach my students and juniors as a mantra. A healer offers love and nurtures the soul. A physician offers concern and treats the body, and orderly glares at the patient and imposes procedures. You know, that applies in clinical medicine. But the same thing we have to think about e-health and telemedicine also. What is it for? What does it mean for us? And how does the government understand it? We have heard from Gandhiji how they are practicing telemedicine in Australia.
Okay.
Telemedicine has helped those remote area nurses a lot. Remote area nurses are saving, lots and lots of life. When Muniratnaji was, not a doctor, an engineer, a passionate person, much older than us also, he was so much emotional, he was so much driven by sentiment that he had to go and save, lives in the Western Hills. So when it comes about saving lives, then should the government still be, what's the government doing? In those conditions, if he had to abide by the government rules, then maybe, many more lives would have been lost. So, okay, that's fine. NMC must have regulations and rules and everything, but that should be stratified. That should be, made in many tiers. For what purpose? What sort of rules and regulations? It's not for, some quacks coming from the, outside the border and doing all sort of nasty things here. They have to be controlled, but the same rules and regulations, if that is, misutilized to control, to block the, speed of the younger generation of very compassionate people who are trying to help people, that will be criminal in itself. That will be the most unethical thing. When you are talking about ethics and, just connecting it to whether the NMC has allowed this or not, and then let people die, okay. What will be more unethical than that? So we have to urge the government to make, their rules and regulations very much, context based.
So Florida एउटा resolution त्यही pass गर्छ पाली endorsement.
The second thing I want to say is that, this is another, this may not be, this could be a little bit, selfish thing for we doctors, but then whether we like it or not, there should be some sort of standardization of, telemedicine practices so that, we are on the same floor, on the same ground, we are talking about the same thing. And unfortunately, so many groups of people are practicing telemedicine in their own ways, different ways, and that makes things very different. Thank you.
Thank you, Dr. Sarosh. Now, उनका अघिकैसँग कनेक्टेड छ तर यसलाई अलिकति सेपरेट गर्नुपर्छ होला. Are we sufficient in अघिकै कुरा आउँछ तर यसलाई रेजोल्युसन बनाउनु पर्ने भएको हुनाले are we sufficient in legal policy and strategic aspects or not? जस्तो त्यो क्युरेटिभ सर्भिस डिभिजनले बनाएको भनेको त गभर्नमेन्टले कुनमा सर्भिस राख्न दिने नदिने कसलाई कति फन्ड एलोकेट गर्ने भन्नेतिर मात्रै लक्षित छ. So what should be the improvement in legal policy and strategic aspects? त्यो कुरामा एकचोटि फ्लोरबाट केही आयो भने त्यसलाई हामी पास गर्छौं. डाक्टर मिङमार.
Thank you. I would like to speak a little bit about myself. I was
24 years I was in my village. I was there for 24 years in Solukhumbu. I got promoted as a first class officer. There were no posts in my village. So I had to come. I was not very happy to come to Kathmandu, but I came because there were no post for me. So when I came to Kathmandu, I had a lot of patients, my own patient out in the village. So I came up with the idea how to connect with these patients, I went to a computer shop. I wanted to buy a new computer. So I asked him, you have somebody who can do something like this for me? Yeah, I will give you a phone number, this and that. He gave me a phone number. I bought a new computer. And then I asked this guy, look, I have so many patients in the village, how they can just make complaints, how the other health workers can feel, and I can advise them. So I came up with it has to be online, something. So I developed something like Rural Health Online Nepal.
Great. When was it?
That was in the year 2006.
Okay, let's give him a big hand.
2006. At that time, thank you. At that time, I just wanted to connect to my patient. Then later on, when I came to Kathmandu, with the ministry people, this and that, there is one point, okay, telemedicine would be there to provide services to the rural communities, all these things. It was there. So I did not know what telemedicine is. Even then, I did not know what telemedicine is. Later on, I came to know that what I've been doing is a part of telemedicine. So then they asked me, the ministry people asked me, okay, you do the telemedicine thing. So they made me the focal person of telemedicine. Well, I will try my best. I don't have any training. I have never attended any workshop, nothing. I have no idea what telemedicine is. But anyway, I sent people all over the district, 75 districts. Are you happy with telemedicine? You want to start this? Do you have telephone? Do you have internet service? Do you have electricity? Do you have a small room for that? I did a survey, one whole year survey. And then finally I found out, I made a presentation of this survey. And then everyone wants to have this, but some do not have internet. Some, there's problem with the electricity, problem with the room, this and that. But we chose the most remote, the 16 districts, the northernmost districts, district hospitals. We chose that. And those days we didn't have any the connection as of now. No. So we bought VSAT. Those days VSAT used to be only for the corporate, some bank or big companies or a big international organization. We bought 25 VSAT and set up all in the mountain up there. Made a little software, the same software, if you have this and that, how to do this and that just. And there is one more thing is video conferencing. Those days, video conferencing everywhere in the world, it was so common. Everybody wanted video conferencing because you want to see patient can see the doctor, is so nice. But later on, they found out that video conferencing is, the store and forward technique is more useful than video conferencing because you need all the data and recordings, all these things. So that's how. So we also did store and forward plus video conferencing. I went to Beer Hospital to set up a specialist kind of clinic. Beer Hospital is it's very difficult. Beer Hospital, there are a lot of people. It keeps changing. You can't do much there. So I went to Patan Hospital. I said, "Namaste, Dr. Sahab, let us do this. Can you please provide me a room?" So they were kind. They had all these old patient register, all these records, and they removed this, and we cleaned it up. They provided the nice room. We bought computers and set up telemedicine there. We paid around 60 lakhs something per year to Patan Hospital and requested, And then the software was designed in such a way that when the gynae problem would come to gynecologist, surgery problem would come to surgeon, and similarly there are 7 or 9 different computers. and you can do video conferencing on one big one like that. So we did that. We set up that, all these different remote these things. And we trained them also. We trained. It was very difficult to train. Even the doctors did not want, they were not, they were happy to visit so many other sites, but when it comes to the telemedicine site, they forget. They forget. We lost the site, this thing. Can you please say it again? It was not at all easy. But still we tried. And later on, it was inaugurated by our Prime Minister, Madhav Nepal. He was invited there to inaugurate this. And he rightly said, okay, Dr. Saab, I'm happy to inaugurate this. As far as the running of this and maintenance is, I don't know how much it would work, you will say that. So that was 2011. By that time, it was 2011. In 2013, I retired. At the same time, we also got one special number, 1115, something like that, from Nepal Telecom. We requested them, Sola Sati Suna Kunikeke. It's a long one, so nobody is going to remember that. So please give us a very easy number. So they kindly gave us 1115, this number. So toll free. And the Nepal Telecom was going to charge 50,000 rupees a month. We said, okay. And we also went to NCL. NCL, he said, okay, this is for free. If somebody calls from NCL, okay, this is for free because you are doing great. So they were that kind. So we started like that. We put a medical officer 24 hours on duty. The Patton Hospital will put the medical officer on duty.
So based on your difficulty in those era, what will be your suggestion for this resolution regarding this?
Number one, I left and everything collapsed. It is not nice. This is institutional memory should be there.
Okay.
And now.
So proper record mechanism should be there.
It's a property of the institution, not personal. This is not Dr. Bigmas, Dr. Somebody else's, It should be. Ministry of Health has spent so much money on that. And now once this guy goes, everything goes away. It's such a bad thing. And now after so many years, because of the COVID, it has come back again. The president's program of telemedicine should come back, something like that. Then we started again, okay, telemedicine. It is almost 2 years. Every now and then I went to Ministry of Health, curative division, that division, this division. We had so many other doctors from different walks of the police hospital, army hospital, Dr. Pradeep Vaidya, everybody made a presentation. Okay, what should be done? So everybody had their own little thing. But what we thought is, okay, this is for Ministry of Health. If it was for the clinic, some hospital, and satellite this, and then the story would have been different. But as this is for Ministry of Health, it should be seen in the same way. All the records should be kept permanently. It should be, I requested them, there should be a special department. That the telemedicine is not joke. Nepal is the country who is the most suitable
so
for
is
telemedicine.
the small department inside curative service division be sufficient?
No.
Is it sufficient?
No.
Or it should be brought in the ministry itself?
It should be the ministry because
Okay.
curative department is different.
Okay.
It should be a different because telemedicine is not that small. As slowly it will even incorporate, I mean, it will be together with telehealth, slowly it will be that big.
Okay.
Then it would be very, very big itself. So we need a proper department.
So proper department is required to be
Okay.
placed inside the Ministry of Health and Population.
Yeah.
So is the floor ready to pass this resolution? Okay. La, एउटा राम्रो resolution आयो. Okay. So Dr. Rajani, you want to add just something? Okay. Last point.
Let me finish
Yeah.
this one. Yeah. And telemedicine, we started same. Finally, after 2 years, everyone agreed, okay, this is the way we should go. So we came up with some software. That software consists of something very simple. All the patients admitted at the district hospital, would be looked after by the specialist from the corresponding province hospital or whatever specialty hospital is there. That was how it was designed. That every time I told this is the first step, the very first step of telemedicine. We have to walk so many steps. Now the telemedicine is advanced so much. You can press buttons here and the operation is going somewhere there. We don't want that right now. We have to start something very simple and which is feasible, possible in our kind of situation. And we know what kind of situation we have in the village, in the district, at the Ministry of Health, at this. So then after everything, there was no budget.
So budget should be increased by the government. यो पनि point आयो.
The budget,
budget छैन जस्तो लाग्छ, increase गर्ने कुरै छैन.
I went to the minister, health minister, I went to him and explained everything. I made a presentation to the Secretary of Health and his all department, whatever. I made a nice presentation to them. And I said, are you not proud of saying that, declaring that all the patients admitted at the district hospital all over the country would be treated with the help of the specialist? Are you not proud? Would you not be happy to say that? Nobody said anything. I made my presentation and that was the last. That was all. So the budget should be there. This is not just you are not doing it sideways.
Well, we should speak point-wise, I guess, to build the resolution.
Enough budget. There has to be enough budget, not just a little thing, there should be enough budget. So I think that is with that budget, with the proper budget, this should
thank you.
Thank you.
Thank you, Dr. Myanmar, for your elaborated story that touched everyone. Dr. Arun and Dr. Vishnu, you are in some hurry. You have to leave earlier. Can you provide some input for the purpose of creating that resolution? Your input will be of high value.
No, thank you. In fact, the important things has already come. Whatever government is doing is in fact not enough in every context, including the telemedicine also. I think from Dr. Mingma, it was an important topic that there should be a dedicated unit, a team in the ministry to look after the telemedicine and with a dedicated budget also.
Okay.
And it has to be incorporated all the district and zones or regions to provide the telemedicine service, I think. And we telemedicine providing service, not only for service, it can be used for the educational purpose, academic purpose also, and research purpose also. Like basically, I'm using telemedicine more for the educational purpose. Like to run my oncology program, I do have international speakers. They took the classes also. And then for problem management, like another thing which I have been still running is an international tumor board. It's not only that the peripheral people who need the help of telemedicine, even the professor like me, I need help. So I take my help from the Western world. Every Sunday morning, 8 o'clock, I have an international tumor board. Whenever there is a conflicting or difficult cases, I get help from the international experts. So telemedicine can be used for the educational purpose, tumor board purpose, and other things also. Thank you.
Thank you. Big hand for Dr. Vishnu. Arun Doctor, agiko kuralai ali resolution ko point ma confidentiality and all. Please.
यो मलाई अलिकति फेरि डाउट भयो फेरि जाने नभन्नु है फेरि डु वी हैव अ एक्चुअल भनौं न एमओएचपी को गभर्नमेन्ट को कन्सेप्ट पेपर कि स्ट्र्याटेजिक पेपर कुनै पोलिसी पेपर अन टेलिमेडिसिन जस्तो यो मेडिकल काउन्सिल को गाइडलाइन रहेछ हैन दैट गाइडलाइन कम्स आफ्टर यु हैव अ स्ट्र्याटेजिक कन्सेप्ट पेपर हामीले नेपालमा हैव वी एग्रीड अफिसियली लीगली टु डु टेलिमेडिसिन अर नट हैन यो मलाई थाहा भएन हैन किनभने त्यो चिजै छैन भनेदेखि त्यो बनाउनु पर्ने हुन्छ होला नि त सबभन्दा पहिले सो त हामीले रेकमेन्ड गर्दाखेरि त निर्देशिका भनिन्छ हैन, इङ्ग्लिसमा के भन्छ? Directive. So is there a directive? Okay, first, and how did the medical council come up with guidelines? It's more of ethical, you know. So directives, I am not sure whether there is or not. Sir, le बनाएको directive त अब
राजेन्द्र सरलाई भन्नुहुन्छ
कुरा आयो हैन. दोस्रो कुरा चाहिँ के छ भने जस्तो यसमा यो यसको डाइरेक्ट यो गाइडलाइनमा के लेखेको छ भने registered medical practitioners भनेको मेडिकल नेपाल मेडिकल काउन्सिलको डक्टर्सले मात्रै गर्न पाउने लेखेको छ कि हैन. सो इफ यु वान्ट दैट अब अहिलेको कुराहरु अनुसार विभिन्न स्टेजमा हो भने सो डिपेन्डिङ अन द टाइप अफ सर्भिस एन्ड द लोकेसन एन्ड अल दैट maybe you have to come make it broader into registered doctors मात्रै नभएर paramedics, nurses or whatever, हैन. Even physiotherapy देखि लिएर सबै आउला, फार्मेसी आउला, के आउला,
इन्स्टिट्युसनलाई नै चाहियो नि खास त.
चाहियो हैन. सो यसमा त भन्यो हो भने त एक्चुअली anyone else doing it is illegal है, according to guideline है, according to guideline.
Okay,
हैन. But that's a guideline मा NMC ethical aspect बाट. तर गभर्नमेन्ट डाइरेक्टिभले टेलिमेडिसिन प्र्याक्टिस गर्न पाइन्छ भनेको छ कि छैन? फर्स्ट
भेरी इम्पोर्टेन्ट पोइन्ट.
फर्स्ट थिङ हैन. र छ भनेदेखि त्यसलाई अब यसमा के पनि लेखेको छ भने रेजिस्टर्ड अब यो गाइडेन्स फर रेजिस्टर्ड मेडिकल प्र्याक्टिसनर्स भनेपछि रेजिस्टर्ड मेडिकल प्र्याक्टिस एक्सपेक्टेड टु हेभ बीन वेल ट्रेन्ड इन टेलिमेडिसिन बिफोर प्र्याक्टिसिङ टेलिमेडिसिन है. त्यसपछि नेपाल मेडिकल काउन्सिल स्याल डेभलप अर डेलिगेट a professional organization to develop a defined short course on practice of telemedicine with the help of experts working in the field of telemedicine in Nepal. Has this happened? So maybe you can recommend that this should happen.
Very important point. And you want to complement to this point?
So just a quick question. I think that one of the most important things from my experience in Australia is that in order for any kind of specialty, and the telemedicine looks like it's going to be a specialty on its own right, is to have a foundations. What are the foundations? Has Nepal Medical Association created a standard clinical manuals for the workers, for the health professionals? Is there a procedures manual? Without those two things, you are really not going to be able to build a house on it. So my suggestion would be, if there is already in progress, for our medical professionals, especially doctors and the academics, to come up with the standard clinical procedures manual as well as the clinical manual in the context of Nepalese demographics as well as the disease profile, and make it as applicable as possible for the workers in the remote areas.
Thank you very much.
So
And Dr. Mingmar?
yeah, sorry. म एड गर्छु सर?
Yeah, please.
यसमा एउटा दुईटा कुरा कस्तो हुन्छ भने क्रस बोर्डर टेलिमेडिसिन भन्ने छ है. We talk about international ICUs and all that. Whether we are allowed to do this or not. So that part is also important.
Very important.
Your cross border भनेपछि anywhere. Border means across seas or everything. Privacy confidentiality ko ta Rajanji will also compliment on this. There are so many acts and all that we are supposed to know. But to privacy or confidentiality act, I think it is taken care of. म चाहिँ कन्भिन्स भएँ. तर पनि डक्टर्सहरूलाई सोद्धाखेरि त they would be reading all these acts. हैन, त्यो अलिकति सिम्पल टर्म्समा चाहिँ भोलि पर्सि भनिदिनु पर्छ होला.
ओके.
हैन, केले उ गर्छ भनेर के. अब सरले अघि भने जस्तो भुल गरेर त्यहाँ आफ्नै मोनिटर फोडेर त काम भएन, हस्पिटलमा ढुङ्गा हाने जस्तो. हैन, केही भयो भने. तर देयर आर त्यो एक्टले पुग्छ भनेदेखि डाक्टर सुवासको सुरुको क्वेसन थियो नि, लिगल कुराहरू. त्यो एक्टले पुग्छ भनेदेखि केही परेन. पुगेन भनेदेखि चाहिँ एड अन गर्नुपर्छ होला.
नपुग्ने चान्स नै हाई छ.
डाक्टर मिङमा
अरे त्यो एउटा नेपाल उसको चाहिँ नि क्युरेटिभ डिभिजनले एउटा कार्यविधि बनाएको छ, टेलिमेडिसिनको कार्यविधि बनाएको छ. यहाँबाट उनीहरूलाई जो काउन्सिलको थाहा छैन जस्तो छ, काउन्सिल हामीले थाहा भएकोलाई उताको थाहा छैन जस्तो छ. देयर इज समथिङ. त्यो कार्यविधि पनि पर्याप्त त छैन, काइन्ड अफ एउटा सानो गाइडलाइन्स टाइपको चाहिँ बनाएको छ. र त्यो कार्यविधि चाहिँ प्रदेशमा पुगेपछि प्रदेशले आफैले मोडिफाई गर्छ. फेरि त्यो प्रदेशले आफैले मोडिफाई गरेर त्यसको त्यो गरेर युज गर्छ. त्यहाँ अहिले चाहिँ नि त्यस्तो के छ, के कार्यविधि छ त्यो पनि छ.
Thank you.
Dr. Nitin, you wanted to add something? In brief, please. To the point.
Hello, धन्यवाद. म Dr. Nitin Bhandari, public health practitioner. अहिले चाहिँ डिजिटल हेल्थमा छु. एउटा कुरा यो हामी टेलिमेडिसिनको कुरा गरिराख्दाखेरि एउटा इम्पोर्टेन्ट कुरा चाहिँ मलाई के लाग्यो भने हामी बिचको अन्डरस्ट्यान्डिङ टेलिमेडिसिनको के छ. हामीले हेरेर हुन्छौँ कन्सल्टेसन भएको हेर्छौँ त्यो टेलिकन्सल्टेसन पनि टेलिमेडिसिनै हो कि अथवा हाम्रो विभिन्न प्लेटफर्म युज गरेर भनौँ न अहिले नाम नलिउँ विभिन्न प्लेटफर्महरू छन् ई-कमर्स प्लेटफर्महरू छन् त्यहाँबाट पनि कन्सल्टेसन भइरहेको हुन्छ त्यहाँ डेटा सेक्युरिटी यताउतिको कुराहरू त आफ्नै ठाउँमा छ तर हामी बिचको अन्डरस्ट्यान्डिङ के छ र त्यो हुनुपर्ने के हो वाट इज टेलिमेडिसिन यसको वाट डज इट इन्कम्पास है त्यो बिचको अन्डरस्ट्यान्डिङ चाहिँ हामीले एउटा सबैलाई अवेर बनाउनु चाहिँ जरुरी छ जस्तो लाग्छ र हामीले डाक्टर साहबले भनिहाल्नु यो इन्स्टिट्युसनलाइज गर्नुपर्छ भन्ने कुरामा त्यसमा कुनै पनि दुई मत छैन तर समस्या के छ भने टेलिमेडिसिनलाई मात्र इन्स्टिट्युसनलाइज गरेर हुँदैन हामीले डिजिटल हेल्थ इन लार्ज सोच्नुपर्छ र डिजिटल हेल्थमा काम गर्ने एक्टर्सहरू स्टेक होल्डर्सहरू जो हुनुहुन्छ एक ठाउँमा आएर अनि बल्ल सोच्नु पर्यो कि यसलाई हामीले इन्स्टिट्युसनलाइज कसरी गर्ने जस्तै अहिले हाम्रो स्वास्थ्य मन्त्रालयको कुरा गर्दाखेरि हाम्रो ह्युमन रिसोर्सकै कुरा गरौँ कतिजना त्यहाँ हुनुहुन्छ भर्सेस अस्ति एउटा कन्फरेन्समा हाम्रो कुरा भएको थियो राष्ट्रिय के अरे नेपाल राष्ट्र ब्याङ्कमा चाहिँ 40-45 जना त आइटी अफिसर मात्रै हुनुहुन्छ हजुरले यस सो यसले त एकदमै इम्पोर्टेन्ट क्वेसन रेज गर्यो हजुरले ब्याङ्किङ सेक्टरमा हेर्नुहुन्छ भने देयर आर भेरी फ्यु सफ्टवेयर
मन्त्रालयमा 35 जना पनि भने
हजुर हो अब ब्याङ्कमा हेर्ने भने मलाई जहाँसम्म लाग्छ मेरो धेरै नलेज त छैन तर सफ्टवेयरहरू युज गर्ने स्ट्यान्डर्ड सेलेक्टेड सफ्टवेयर हुन्छ होला जसलाई रेगुलेट गर्न धेरै गाह्रो हुँदैन तर तपाईँले यहाँ स्वास्थ्यमा हेर्नुहोस् त यति धेरै सफ्टवेयर छ यति धेरै नयाँ निकालिरहेको छ हाम्रो कुनै पनि एउटा इन्जिनियरलाई भन्यो भने एक दुई रातमा उहाँलाई सर्भिस हुन्छ नि एप्लिकेसन बनाइदिनुहुन्छ होला तर इम्पोर्टेन्ट कुरा के हो भने हामीले जे बनाइरहेछौँ त्यो नेपाल सरकार अथवा स्वास्थ्य मन्त्रालयको प्रायोरिटी अनुसारको सिस्टम बनिरहेछ कि छैन त्यो पनि एउटा एकदमै मुख्य ध्यान दिनुपर्ने हो हाम्रो स्वास्थ्य मन्त्रालयले विभिन्न लेभलमा स्वास्थ्यका इन्टरभेन्सनलाई प्रायोरिटाइज गरेको छ डिजिटल नेपाल फ्रेमवर्कले पनि विभिन्न इन्टरभेन्सनलाई प्रायोरिटाइज गरिरहेको छ त्योसित हामी कतिको अलाइन छौँ त्यो एउटा कुरा पनि मैले हाइलाइट गर्न खोजेँ र एउटा अब आवश्यकता के छ भने डिजिटल हेल्थ टेलिमेडिसिन अथवा मोबाइल हेल्थ होस् म चाहिँ मोबाइल हेल्थबाट परेँ यो सबैको लागि हेर्ने एउटा डिपार्टमेन्टै खाँचो छ कि जस्तो लाग्छ
मन्त्रालयमै चाहिन्छ
एक्ज्याक्टली किन भन्दाखेरि डिजिटल हेल्थ सस्तो छैन न टेलिमेडिसिन सस्तो छ न डिजिटल हेल्थ सस्तो छ मैले 2012 मा एक्चुअली बाजुरामा पुगेको थिएँ हजुर बाजुरा स्वास्थ्य अस्पतालमा चाहिँ त्यहाँ पुग्दाखेरि टेलिमेडिसिनको लागि एउटा रुम बनाउनु भएको रहेछ बन्द अवस्थामा थियो त्यति बेला अनि माकुराको जालीहरू सबै लागेको थियो अनि किन चलाउनु भएको छैन भन्दाखेरि चाहिँ त्यहाँ उहाँले भिसाट सिसाट के राखेर त्यति बेलाको टेक्नोलोजी राखेर 2012 को अनि सबै सिस्टम बनाएको तर के गर्ने यहाँ सेन्ट्रल हबमा बस्ने डाक्टर साहबहरू हुनुहुन्थ्यो उहाँहरू चाहिँ सधैँ आउनु हुँदैन त्यही भएर चाहिँ हामीले त्यो सर्भिस दिन सकेनौँ भन्ने कुरा थियो त्यो त्यति बेलाको समस्या थियो अहिले नहोला तर एउटा मैले हाइलाइट गर्न खोजेँ डाक्टर थिएन भन्ने कुरा हाइलाइट गर्न खोजेँ होइन मैले हाइलाइट गर्न खोजेको त्यहाँ इन्भेस्टमेन्ट कति भएको छ
ओके
त्यो इन्भेस्टमेन्ट इम्पोर्टेन्ट छ हामीले यहाँ कुनै पनि हामीले एउटा भनौँ न एउटा खोप लग्या जस्तो इन्भेस्टमेन्ट होइन यो एकदम महँगो इन्भेस्टमेन्ट छ बट एट द सेम टाइम यो 3-4 वर्षमा फेरि एक्सपायर पनि हुन्छ हामीले नयाँ किनेको फोन 5 वर्षपछि त्यो पुरानो हुन्छ अथवा 3 वर्षमा पुरानो हुन्छ
हराएन भने
सो आई थिङ्क हामी यो कुरामा पनि एकदम इम्पोर्टेन्ट फोकस गर्नुपर्छ जस्तो लाग्छ र त्यही डिपार्टमेन्ट अन्तर्गत एउटा नलेज हब पनि बढ्नु पर्यो कि हजुर
गुड ल एकदम राम्रो पोइन्ट थ्याङ्क यू डाक्टर नितिन सिद्धु कि लास्ट पोइन्ट बाँकी छ ओके ल थ्याङ्क यू सो मच
अब लास्ट एउटा हजुरले भनेपछि र अर्को कुरा के भने स्वास्थ्य मन्त्रालय स्वास्थ्य सेवा विभाग सरकारको रेस्पोन्स रोल के हो त स्वास्थ्य सेवा मात्रै पुर्याउने हो अथवा रेगुलेट पनि गर्ने हो र यो रेगुलेसन गर्नको लागि पनि हामी जस्तो स्टेक होल्डर्सले चाहिँ उहाँहरूलाई अकाउन्टेबल बनाउनलाई चाहिँ हामीले चाहिँ झकझकाइरहनु पर्छ र यो व्यक्तिबाट हुँदैन यो यस्तै टोलीले गर्यो भने मात्रै बल्ल त्यो कुरालाई हाइलाइट गर्नु
and as this is connected with both health and IT who will be the regulator that's a big question है त्यो पनि रेज गर्नुपर्छ होला थ्याङ्क यू नितिन अब in next 10 minutes maximum we are going to conclude the session अब यहाँ टेक्निकल पर्सन्स पनि हुनुहुन्छ कि हामी हेल्थ आइटी हो त डिजिटल हेल्थ भनेपछि पहिलो शब्द डिजिटल छ यहाँ राजेन्द्र सर हुनुहुन्छ पवन सर हुनुहुन्छ सुरेन्द्रजी हुनुहुन्छ अरू पनि हुनुहुन्छ होला सरी मैले चिनेको हजुर पनि ओके तपाईहरुको तर्फबाट आइटी को एंगलबाट के चाहिँ के इनपुट दिनु पर्यो त्यहाँ हजुर ए मुनिराज सर ओहो एकचोटि ताली बजाएर उहाँलाई फेरि सम्झौँ आइटी को पर्सपेक्टिभबाट पनि त केही त हामीले बोल्नु पर्यो नि त यस्तो हुनुपर्छ भनेर
What I say is IT is most important subject. बिना IT को के हुन सक्दैन नि
जहाँ हावा छ त्यहाँ आइटी छ अहिले
हावा पनि चाहिँदैन हावा
ओके
चल्छ As a matter of fact, मैले भने नि सुरु अघि पनि भनेको थिएँ I was not a doctor. I wish I was.
And you are almost doctor. अघि डाक्टर उदयले भन्नुभयो नि
Anyway, what I found, there is a close relationship between the technology, ICT, IC, whatever you call it, and other medical services. It should be married. It should be technical in engineering form, and also the telemedicine must be equally important.
Right.
With the technical know-how and video conferencing, all that you have to know. And medical
heart and lungs जस्तो
you have
lungs लाई heart चाहिने heart लाई lungs चाहिने okay okay Rajan sir any input particularly in connection with the IT perspective
अब यस्तो छ आईटी को मा त अहिले बिना आईटी त केही पनि सोच्नै सकिन्न we cannot imagine behind the IT. So let's make it more simple.
Okay.
Let's make it more simple. Nepal Medical Council ले आफ्नो प्रोफेसन को हिसाबले उहाँहरूले जुन कार्यविधि बनाएर उ गर्नुभयो टेक्निकली मिमा डाक्टर साहबले भने जस्तै हामी क्युरेटिभ डिभिजन हाम्रो पब्लिक हेल्थ एक्ट आईएचएमएस रोड म्याप यी सबैले र अहिले हाम्रो जुन डिजिटल नेपाल फ्रेमवर्क र हाम्रो आईसीटी पोलिसी नेशनल आईसीटी पोलिसी जुन छ यो सबैले रेस्ट्रिक्सन धेरै राखेको छैन मैले त्यही भएर भन्छु धेरै रेस्ट्रिक्सन छैन तर यही हो कानुन पछि लाग्यो भने रविको पद चट गरिएर जान पनि सक्छ कानुन भन्ने त्यस्तो कुरा हो है त्यस कारणले गर्दाखेरि त्यो अब कानुनै कोट्याएर हेर्ने हो भने त एकदमै कम्प्लिकेटेड हुन्छ तर हाम्रा विशेष गरी हाम्रो डिएचएस मन्त्रालय त्यसपछि आईसीटी पोलिसी डिजिटल नेपाल फ्रेमवर्कले मलाई लाग्छ कहीँ कतै पनि त्यस्तो खालको
चेकबार छैन
र इभन क्रस बोर्डरको कुरामा एउटा स्ट्यान्डर्डाइजेसन त छ त हाम्रो प्रोफेसनमा त डेटा सेक्युरिटी हाम्रो प्रोफेसन जो इन्जिनियर हुनुहुन्छ त्यो इन्जिनियरले आफ्नो डेटामा लिकेज त कुनै पनि हाल्नु उसको प्रोफेसन हो नि त्यो त त्यसकारणले उसले कहिले पनि गर्दैन त्यो उसको प्रोफेसन हो उसको जब हो उसको बिजनेस हो त्यसकारणले त्यसमा धेरै ओरी भइरहनु पर्दैन तर ल्याकिङ चाहिँ के हो भने जसरी फाइनेन्स इन्स्टिट्युसनहरूको फाइनटेकको चाहिँ नि एउटा जुन रेगुलेटर बडी राष्ट्र ब्याङ्क भए जस्तै त्यो हाम्रोमा चाहिँ ग्याप छ त्यो चाहिँ एकदम स्वीकार्नै पर्ने कुरा हो त्यो चाहिँ ग्याप छ
रेगुलेसन
होइन त्यस कारणले गर्दाखेरि त्यो रेगुलेसन रियलाइज पनि भएको छ ग्याप पनि छ होइन अहिले डाक्टर नितिनजीले भने चाहिँ गरी हामीसँग टेक्निकल पिपल्सहरूको ल्याकिङ छ 14-15 जना कुरा गर्नुहुन्छ 2 जना पनि विभागमा त आईटी को जम्मा 2टा मात्रै दरबन्दी छ अब भन्दा पनि हुन्छ हैन मन्त्रालयमा 1 जना मात्रै
दरबन्दी बढाउनु पर्छ नि त पोइन्ट आयो नि त रिजोल्युसन हो नि एउटा
हुँदैन ओके एउटा डाक्टरलाई एमएसपी ले प्राविधिक भनेर 1.5 लाख 2 लाख तलब दिन्छ भने एउटा आईटी को इन्जिनियरलाई 45,000 को तलबले बस्दैन त्यसकारणले आईटी पनि प्राविधिक हो उसको पनि सरबन्दी बढाएर सोलुसन हुँदैन त्यसलाई चाहिँ नि अर्को लाइनबाट ल्याउनु पर्छ प्राइभेट कम्पनीले इन्जिनियर पाल्न सके तपाईँ राख्न सकेको छैन त सरकारले कहाँ सक्दैन त्यसकारणले गर्दाखेरि मैले के भन्छु भने यसलाई रहेका कानुन मौजुदा कानुनहरुमा टेकेर जान
यसलाई नै सिन्थेसाइज गर्नु पर्यो
धेरै कम्प्लिकेटेड छैन जस्तो लाग्छ मलाई चाहिँ है
हस् थ्यांक यू अब हामी वी आर अलमोस्ट टुवर्ड्स द एन्ड वुड लाइक टु लिसन टु आवर जापानिज ओके पवन सर यु वान्ट टु एड समथिङ अगे नामले फेरि
मुसुक हाँस्नु मात्रै भयो उहाँ सधैँ हाँस्नुहुन्छ
Thank you, sir. And I second what Dr. Nitin said just now. So we have to be clear with the definition, because what we are doing is teleconsultation. It's not telemedicine. That's what we think from IT perspective. Okay, so that's, I think, from today onwards, why don't we call it digital health initiative? Okay, so that's one thing. The other thing is, it's very sad to learn that like we came up with a directive after COVID situation, and we are still defining the telemedicine service as to provide table, chair, computer, web camera. And we cannot go beyond that. And it's very saddening for us in terms of IT, because like when we think of digital health initiative, we think of digitization of the medical services.
Yes.
And digitization of, we've been talking about health informatics, and those things should have been done there. Not just table, chair, table kursi चाहियो, एउटा operator चाहियो, अनि एउटा VSAT चाहियो, एउटा internet चाहियो, अनि एउटा राम्रो खालको web camera चाहियो अरे. That's not telemedicine. Thank you.
Okay, now two input. Ladies, but एउटा पनि input आएको छैन है. We have noticed that. Please, anyone to volunteer? Or else, okay. Would like to take this. Oh, Dr. Rajani. No.
I think I have been speaking lots of things, but still I want to represent female voice as well.
Tali.
Okay. Actually, I would also like to add the human resource point. So I think the people with health informatics background should come also in this point. And not only like we are talking all these things staying in this urban area, but there should be something that is not only from the top to bottom, but bottom to up also. So we need to also see what is the need assessment of this particular rural area.
Users group. Very nice point. Very nice
So
point.
I think that's the my point.
Wow, thank you. Now, I would like to take this opportunity to listen to our international delegate. What's your viewpoint based on your experience in Japan and other countries of Asia? Would you like to provide some input to our government?
Government, okay. Very big. Very big, okay. Actually, as I said in my first talk, unfortunately, even in our country, telemedicine is not so popular. Even though we have our government push this tendency to all the people, including medical people and the citizens. But most of the doctor would like to take care of your patient in person. And also most of the patient would like to come to us. That's a big issue still. Unfortunately, even though the government subsidizes some support for the medical cost for online consultation and from patient, but not so expanded yet. So that I always say that coverage of the cost is quite low compared to the in-person meeting. That is a big issue because now we should, and also patient have to prepare the equipment for remote care, right? Of course, the patient, only patient you need is a smartphone is okay, but medical institute prepare the devices such as PC and also internet connection and also somehow the electronic health record or something like that. So sometimes these kind of the systems can be the barrier to push the medical institute to go to the telemedicine. So I just would like to ask the government to support financially. This is our first maybe.
यो चाहिँ छचोटि आयो यो point budget भन्ने चाहिँ.
And also the kind of advertisements. This should be the second. Even though we said the usefulness of the telemedicine to the patient, maybe most, not most, but not all of them believe us. But the voice from the government is quite important. Why is it so useful and how it is reduce the medical cost or how to contribute to your daily life. This kind of announcement from the government is quite important. Our government do not such kind of advertisement. This is, I think, quite big issue. And this is not the government, this is a kind of commercial companies. I would like to ask them to develop remote sensing devices. Comparing to the in-person meetings, and the very limited information can be available on-site remote consultation from patients. So that is a big issue in Japan, especially in Japan. So I just, the PHC as a kind of box was introduced from my colleague in Kyushu University in his presentation. That is a kind of one solution. So if we would like to use that kind of remote sensing devices, we should have the help from nurses. Nurses in the rural area is essential to take care of those kind of patients. So that's why I'd like to have more good equipment, and I'd like to have more support from the nurses. I'm not sure this is a governmental issue or something, but I'd like to.
Okay.
Like this.
Thank you. Thank you. A big hand for him. Now, final question from the people who are online respecting telemedicine. Presence.
Ravindra Bista sir or Navindra Bista sir, you are online, so do you have any comments? Yes.
Thank you very much, sir. A very good evening to you all. What I would like to request, if possible, let's have one course from this workshop for teaching master's students in health informatics or digital health, and even in medical field, even in nursing field, so that it will solve the problem of lack of human resources in the country. If we could offer any formal course at university and research centers, then this could be very effective way of capacity development of human resources in telemedicine. This is just my suggestion. I have no such any compliment. Very pleased to listen this reputed international conference in telemedicine. I'm sorry I could not join physically because of my so many teaching learning activities at university. I wish very best for this conference and grand success. Thank you very much.
Thank you. Mr. Sir from Ask Foundation, do you have any comments? Sir?
Yes, sir. Yes, sir.
Yes, Mr. Sir.
Thank you so much. I find it really interesting, the discussion, the way the discussion is going on now. I don't have a particular question, but I would like to wish my best wishes for this program. Thank you so much.
Thank you. Chang Chitron, Professor Chang Chitron from Taiwan, are you online? So do you have
I think Satya has raised his hand. Maybe he can talk first.
Yes, Satya.
Yeah, I don't have any question. I just have a comment. Actually, the theme for this this year's telemedicine symposium is very good. I always used to talk about nurses' role in telemedicine because this is really very interesting and very important topic. So we are always neglecting nurses, where these services are very important, the telemedicine services. And nowadays we are having this artificial intelligence induced telemedicine services. Once this picks up, then nurses' burden will come down drastically. And if the teams can work towards helping nurses, like now the latest software which we are trying to acquire now, that EMR and EHR, so a lot of benefits for the nurses. There's the system generated alarm system, which patient is sick, which patient is doing well, which patient need to be shifted to ICU. So all these systems are integrated in the EHR. Once these softwares are up and this becomes very easy for the nurses, and really I appreciate the thought of including nurses in the telemedicine. Thank you very much.
Thank you. Thank you, Satya. You have been always helpful for us. Okay, Professor Chang Chusong.
Hi. Hello. Yeah, it's my great honor to participate this ATS. I really learned a lot from you. And I think here in Taiwan, although we, at some point, we also have many medical resources, and some people, and actually many people, willing to help other countries. So I think with telemedicine, we can provide the services through this kind of technical. As I know that, for instance, I have a friend, he's a dentist. His church actually is going to send him to Nepal next week, stay there to help the people. I think we haven't discussed about the dental. Actually, they cannot do much with telemedicine, but consultation or the health education is also helpful. At least we can do something better than nothing. So that's, I'm really hope in the future, our technology, our telemedicine can be very, have lots of opportunity, can cooperate between our country and in this region. Thank you very much.
Thank you. Actually, we are very excited that you will be here in Kathmandu, but because of the other problem, you couldn't attend. Thank you, Professor. There is Delhi Raja. Are you online? Delhi Raja, sir. Delhi Raja, sir, and Jahir.
Namaskar.
Delhi, sir. Okay.
नमस्कार, म दिल्ली राजा आचार्य, अहिले चाहिँ जलजला गाउँपालिका पर्वतबाट छु। यहाँहरु सबैलाई न्यानो अभिवादन। म यसभन्दा अगाडि मेघदी जिल्लाको स्थानमा महावीर पुन सरसँगको यही हामी निवेरासँगै टेलिमेडिसिनको कामहरु गर्दै आइरहेका थियौं। त्यसमा यो कन्सेप्ट चाहिँ राम्रो छ। हाम्रो भूगोल सुहाउँदो चाहिँ धेरै कुराहरुमा हामी पछाडी परेको देख्यौं। अब यसमा यसका राम्रा कुराहरु चाहिँ आफ्नो ठाउँमा छन्, सबै राम्रा छन्, तर पनि के कुराहरुले चाहिँ हामीलाई यो लङ लास्टिङ गर्नलाई समस्या गरेको हो कि भन्ने कुराहरु देखिन्छ। यसभन्दा अगाडिको वर्कसपहरुमा पनि म सहभागी थिएँ। त्यसमा के कुराहरु निस्किएका थिए, जस्तै गभर्नमेन्ट सँगको संलग्नताका कुराहरु र धेरै कुराहरुमा चाहिँ हामी छलफल गरेका थियौं। यसमा खास के भएको छ भने यो डिजिटल हेल्थमा हामी यो एनजिओ आइएनजिओ र विभिन्न प्रोजेक्ट बेसमा चाहिँ डिजिटलाइजेसन गर्दै छौं। खास गरी अब हामी एउटा किसिमको डिजिटलाइजेसन गर्छौं, कुनै एउटा इन्टेन्स पोकेको एनजिओ आइएनजिओले त्यही किसिमको डिजिटलाइजेसन गर्न खोज्दै छ। हुन त टेलिमेडिसिन र डिजिटलाइजेसनमा त्यति धेरै एकरूपता नहोला, तर पनि हामी पब्लिकमा पुग्ने स्वास्थ्यकर्मी अथवा जो भोलिन्टियरहरु छ उहाँहरु पुग्ने कुराले पनि पब्लिकमा इरिटेसनको अवस्था आइसकेको अवस्था छ। त्यसैगरी यसको राम्रोको लागि अहिलेसम्म खासै सरकारले हैन यो यसो गर्नुपर्छ, यो हेल्थको लागि अथवा डिजिटल हेल्थको लागि अथवा रुरल हेल्थको लागि टेलिमेडिसिनका कुराहरु भनेर पोलिसीमै नआएको कुरा भइसकेपछि अब हामी हाम्रा हेल्थ वर्करहरु प्राय जसो हामी सरकारभन्दा बाहिर गएर गर्न सक्ने अवस्था नरहेकोमा हाम्रा सबै हेल्थ वर्करहरुलाई चाहिँ अब त्यसलाई समावेश गर्न र हाम्रा सरकारी जुन इन्स्टिट्युसनहरु छन् तिनीहरुलाई चाहिँ समावेश गर्नको लागि चाहिँ समस्याको रूपमा देखिएको छ एउटा। त्यसैगरी अर्को कुरा, अब हामी त भूगोलका कुरा, इन्टरनेटका कुरा, अब 5G 4G का कुरा गर्दै छौं, तर हाम्रोतिर अझै पनि 2G GPS देखि लिएर यो GSM सिमहरु चलिरहेका छन्। ती कुराहरुले पनि इन्टरनेटमा चुनौतीहरु थपिएका छन्, भूगोलका कुराहरु छन्। अर्को मैले आफै काम गर्दै गर्दा र अहिले देखिँदै गर्दाखेरि चाहिँ हाम्रो जो यो अपरेटिङ गर्ने व्यक्तिहरु हुनुहुन्छ, स्वास्थ्यकर्मी अथवा भोलिन्टियरहरु, उहाँहरुको यो क्षमता विकासको कुरा चाहिँ सबभन्दा चुनौतीमा देखिएको छ। र एउटा सामान्य कुरा सानो नेटको कुनै एउटा आइपी बिग्रिँदा बित्तिकै अथवा एउटा सामान बिग्रिँदा बित्तिकै त्यसलाई चाहिँ डिस्कन्टिन्यू भइराखेको अथवा काम नभइराखेको अवस्थाहरू छन् र यी कुराहरूलाई पनि सम्बोधन गर्ने गरी अझ मुख्यतः सरकारसँग चाहिँ सहकार्य गर्ने गरी यत्रो टिमहरू हुनुहुन्छ, एकदम रेपुटेड डाक्टरहरू हुनुहुन्छ र मेडिकल काउन्सिलको व्यक्तिहरू पनि हुनुहुन्छ। उहाँहरूले सरकारसँग कोलाबोरेसन गरेर कुनै एउटा प्याकेजहरू बनाउन सक्नुभयो भने र सरकारसँगै सँगसँगै हिँड्न लागियो भने चाहिँ यसको विकास चाहिँ अलि राम्रो हुन्थ्यो कि भन्ने चाहिँ मेरो आफ्नो कुरा हो। र खास गरी यो पार्टनर एनजिओ बेस डिजिटलाइजेसन गर्न भन्दा पनि अन्य चाहिँ हाम्रो एउटै रोड म्याप बनाएर त्यसमा गर्न सक्यौँ भने चाहिँ हामी सफल हुन्छौँ भन्दै यहाँहरूको यो कार्यक्रम र यो राख्ने मौका दिनुभयो, धन्यवाद त्यसको लागि, र कार्यक्रम सफलताको शुभकामना दिन्छु। धन्यवाद।
थ्याङ्क यू सबैजनालाई एक्टिभ पार्टिसिपेसनको लागि धन्यवाद। लास्ट पोइन्ट उता रोल्पा वा बैतडीतिरबाट के यसलाई कम्प्लिमेन्ट गर्ने लास्ट पोइन्ट हो अब यो, प्लिज डाक्टर धीराजेन्द्र इन सर्ट। रेजोल्युसनलाई ड्राफ्ट भइरहेछ, सो एक्चुअली उहाँको लागि ताली बजाइदिउँ त बिफोर लिसनिङ टु हिम। ए ओके माइक।
Thank you, organizer, especially Uday sir, for giving this opportunity to participate in this program. Especially मलाई के इन्फर्म भएको थियो भने यो जुन अहिले जुन वर्कसप हुँदैछ यो वर्कसपबाट 2-4वटा जिल्लाहरू छानिँदैछ, जस्तो पेरिफेरीमा हब हस्पिटलहरूको रूपमा, जसमा एउटा बैतडी हस्पिटल पनि एउटा हब सुदूरपश्चिम एउटा हब हस्पिटलको रूपमा एस्टाब्लिस गर्ने गरी प्रयास भइरहेको छ भन्ने मैले एनएसआईबाट थाहा पाएको थिएँ। अनि म यो प्रोग्राममा आउँदाखेरि पनि मेरो पनि त्यही छ, म त्यहाँ अहिले डिस्ट्रिक्ट हस्पिटलमा एउटा म एमडिजिपी हो, क्लिनिकल कोअर्डिनेटरको रूपमा त्यहाँ काम गरिरहेको छु। त्यहाँबाट ट्राभल चाहिँ यदि हामीले पेसेन्ट रिफर गर्नु पर्यो भने चाहिँ ट्राभल चाहिँ एकदम फार छ। इट्स टेक्स अलमोस्ट 6 to 8 hours to send patients to the other tertiary centers. So usually we have to see serious cases like we have to say even myocardial infections and cardiac arrest cases and different pulmonary related cases. So in those cases, these patients really need ICU care. So in morning sessions, we have talked about this e-ICU and all those. So if this podium choose that hospital as a hub hospital, or if you can integrate us with you, then it will be a very help to us. So that's my point. Thank you.
We appreciate your affection towards the institution you have been serving. Okay, with this.
Thank you, sir.
Okay, Srishti, quick. Okay, quick points. Last out, Dr. Rana. Okay.
Thank you, Uday sir, and everyone for inviting me on this platform. As a student of healthcare management, अघि नै धेरै कुरा उठिसक्यो, मैले जस्ट ऱ्याप अप सस्टेनेबिलिटीको कुरालाई चाहिँ पोइन्ट आउट गरेँ हैन। देयर आर भेरियस EMR, HR, telemedicine, digital health softwares around, and what the question is, what are we doing for its sustainability? I'd like to add a suggestion, a point, just as a student. Couldn't our health insurance system or private insurance system incorporate digital health or telehealth into its OPD so that it could be sustainable in long run?
Very nice point.
Thank you.
Okay, let's wrap up. Okay, Dr. Rana last. Rana लेखिन्छ कि राणा बोलिन्छ कि राणा? Okay.
समस्तमा मेरो नमस्कार. I am Dr. Anwar Bogati from Rolpa Hospital. I have been working in remote stations since 5 to 6 years. So from my personal working experience, the concept of this telemedicine can work wonders if we take it in proper path or in proper way, especially to remote area where we are working in extreme conditions and in extreme environment. So and different things are being discussed regarding laws, regarding budget, and everything has been discussed. So I don't want to go in those things, but for me personally, I came here in a view that I wanted to set up this telemedicine to my institution as well, because it's a very far away, and one way travel only can cost 15 to 20,000 for that patient. So I want to reduce that economic burden in first place, and this telemedicine can be handy for those patients, and as well as our personal growth also. So in that context, in according to need based, we have to start it from remote, and then we can come to urban, in my personal view. So a small start can यसले ठुलो फड्को मार्न सक्छ, त्यही भएर सो हामीले स्टार्ट चाहिँ गर्नुपर्छ भन्ने लाग्छ। अब यसलाई नमिल्ने कुराहरू छ, अरू कुराहरू चाहिँ हजुरहरूले अब मिलेर गर्नुहुनेछ। थ्यांक यू सो मच। यति भन्न चाहन्छु।
एकदम माहौल झन्झन तात्दैछ। डाक्टर मिङबर लास्ट पोइन्ट भनेर औँला उठाइराख्नु भएको छ।
उहाँहरूले क्वेसन उठाउनु भयो त्यो कारणले चाहिँ।
ओके,
बिकज रोल्पा भयो चाहिँ डाक्टर बैतडी government telemedicine program जुन चाहिँ छ अहिले, whatever the government program, we have already conducted training for the doctors from the district, from those areas, and the idea is to look after all the patients admitted at the hospital. All the patients, not only one or two. All the patients would be seen by the specialist. I mean, I don't want to say they would be seen by the specialist, but they would be treating. Local doctors would be treating with the cooperation from the specialist, from general hospital, Pradesh hospital or the province hospital. And in the general hospital, there will be doctors sitting there, specialist, eye specialist, I don't know what are so many other specialists. They will be sitting there. They will be looking after the patient of the 14 districts. Suppose this is gynecologist table. All the gynecology problem would come here. And she's going to look after this. And whatever question you have, they would be tackled right there. And another thing is, similarly, other specialties. And another thing is 24 hours is emergency. Anytime you have emergency at your emergency ward, that would be, you can contact the specialist at the Pradesh General Hospital immediately, anytime. Then and there, through the video conferencing, they would take care. They would help them. Whatever advice. There are things, more than 90% patients can be treated through telemedicine. But the rest of the 10%, they have to go somewhere. We can't do everything out there. So this is just the beginning, Mandy. The second step is, from there, it will be directly referred to tertiary hospital. Tertiary hospital, and from tertiary hospital, whatever treatment they provide, it will go back to the district hospital. So that way, all the records of all the patients would be in cloud. It would be there wherever they go all around. The records would be there. So that way, it is being. I mean, we are trying that way. We have already conducted one batch training all over Nepal. All the 7 provinces I have been myself. It was 2 days training. I did myself, and only one province, but number 2, I could not go, but I did through video conferencing. So that way it is coming on that way. Right now, the province number 7, Sudur Pasim province, they have also inaugurated. Okay, all the district hospital patient would be looked after by the specialist, and they are ready. They are anytime they will start that. So that is kind of information.
Thank you. Thank you, everyone, for your very active and enthusiastic participation. Now the floor back to Dr. Uday.
Thank you very much. Thank you. Actually, that is why this society is needed. That is why we have to knock the door of the government, knock the door of the regulators to push. And we always have to walk forward and then push them and pull them with us. So that is what our teachers have done, and that is what we'll be doing. So we don't have to be very much afraid of the rules and regulations, because we as doctors and engineers, we all know our professional values. So we have to respect that, and that is what regulation is. So thank you very much. With this, we would like to conclude, and we'll make a declaration from today. And tomorrow afternoon, 2 o'clock after lunch, there is a session with the WHO and government, and we will be presenting this declaration with the government personnel, and hope this will happen. And now it's very good that government people are also aware about the telemedicine, about the use of telemedicine. And there are like telecom authority, this Nepal Telecom Authority, NTC, they also have allocated budgets for telemedicine. And actually they don't know how to use this budget. And we are here to have this budget. So I think we will, in the years to come, this future of digital health, telemedicine is great. And this digitalizing the human resource, there are posts like digital nurse. So I was very happy to see in the online, there was one digital nurse. So she was online. So those type of posts is very good. So digital doctor, digital nurse, digital paramedics, those things. So we will be digitalizing, we'll be training, we will have curriculum, we will have trainings, courses, we'll have budget, so that this telemedicine, including telehealth, digital health initiatives will grow in future. Thank you. Thank you very much for this. Even for this afternoon also, there are so many people attending. So it's a rare happening. Thank you very much. Thank you all.